it. And at the same time, we have had speakers talking on, absolutely new things, pushing the envelope, and that is something very exciting. So now we enter day 2, and we have basically deep venous interventions as one of the main topics, and the very prestigious researcher award session, which we'll be watching very thoroughly, and looking at the youngsters who are going to be the next generation. So I pass on the mic to Dr. Rahul and Deepak for the house rules. Over to you.
Deepak, you want to say something, please?
No, I'm fine, Rahul. Please go ahead with the house rules. Let's start the meeting as soon as possible.
Sure. Yeah. I also welcome Professor Igor from Russia. Professor Igor, yeah. So he's here. Thank you for joining up. And so we got deep venous interventions. There are a lot of cases to discuss and a lot of presentations. Yesterday we had 600 people joining on the net from 32 different countries, and so which was brilliant, and we covered approximately 45 lectures, and so it was very tight schedule. Today we will start with deep venous interventions. Then we got a very prestigious Sevier Young Research Award. So we got 18 entries from all over the world. So there will be 3 awards, approximately $800 for the Indians, and there will be 3 awards of $800 US for the people outside the country. Then we got another 10 minutes talk on air guns. It should be very interesting. It's a slightly different talk from the vascular surgery. I thought vascular surgeons should learn about the pistols and revolvers and what is new in the air guns, and what are the best air guns in the world to buy, and what are the different sort of pallets, and if you want to go for shooting, the targets or whatever. And so you can learn something about that. So we got a newly appointed a lady instructor. So she's one of the first lady instructors on the air pistols. She has got a license here, so she's going to talk about for 10 minutes, telling us about that. And then we got the last sessions talking about the NOACs, and we have chosen some different topics like NOACs in children, something reversal agents and all. And then in the last we will have the election results for this year's and the GPM, and followed by the award ceremony. So we just finished the nursing paper presentations. We had 6 public papers from the nurses, which we have just examined. We have already got the results for the doctor's 3 paper presentation. So we will start. I will introduce the chairpersons. Tarun, please. Starting with Dr. Homan Jalai from Germany. Oops, where is gone? Yes, please. Thank you. And Dr. Jalai, he runs a very, very important course. Dr. Jalai, are you running this course this year, or is going to be virtual?
This year is going to be a little bit hybrid, so speakers will be on site and participants are online, because this is already in March 2021, so it couldn't be a real face-to-face congress, but hopefully like next year.
Next year, okay. Thank you. And we got Dr. Igor from Russia, and Dr. Willie Chi from USA. I think Dr. Willie may not be able to join, but let's see. Dr. Robbie George from India, Dr. Manish Rawal from India, Dr. Balaji from India, and Dr. Hemant from India, and Dr. Ajay Savlania from India. So we'll start with the first lecture, and it's the conference theme is absolutely a practical approach, how exactly you do it. And we got Dr. Lalit Garg, he's an intervention radiologist, and he's going to talk about the use of Penumbra device.
Good evening, everyone. I would like to thank you, Viacom, for giving me this opportunity. I would like to share my experience with Penumbra's Indigo system in deep venous thrombosis. As per Indigo system IFU, it is indicated for the removal of fresh and soft emboli and thrombi. It is indicated for acute and subacute DVT. We can do mechanical thrombectomy up to 21 days. It gives best result in acute cases. In subacute cases, it can be combined with thrombolysis. We can offer penumbra thrombectomy to acute and subacute DVT cases which are having significant iliofemoral thrombus load and significant swelling and pressure symptoms like compartment syndrome or significant pain, or patient having contraindication to anticoagulation or thrombolysis. Advantages are rapid recovery with significant reduction in thrombus load, and there is reduced risk of post-thrombotic syndrome. On ultrasound evaluation, we look for echogenicity of clot. Hypoechoic clot are acute one, and they give best result with penumbra. Acute on chronic type of cases will not give such a good result with penumbra. The patient presenting with isolated left lower limb unprovoked DVT should be carefully evaluated for May-Turner syndrome, as these patients require venous stenting, and patient counseling is very, very important. Indigo system has three main components: catheter and separator part, tubing and canister part, and suction pump. We take ultrasound guided access commonly into popliteal vein. Sometimes gastrocnemial vein or short saphenous vein can also be used. The patient can be kept in prone or supine position, which will be decided on the case-to-case basis. Each position has its advantage and disadvantage. When we are using CAT 8 system, we have to use at least a 10 French sheath, and sheath should be with removable cross-cut valve or rotating hemostatic valve. Indigo catheter have advanced tracking technology with large lumen aspiration and separator technology. And with extra torque feature, it gives a large circumferential aspiration. The Indigo pump have pressure gauge and pressure regulator, and it is connected to the canister and tubing part. The setup of pump is very easy. You just have to connect the canister to it and just switch on the button and it is ready. So we take our Terimo wire and MPA combination to the thrombosed vein. We park our wire in the IVC, and then over the wire we take our Indigo catheter to the location of clot. Then we introduce separator, and through the side arm of our RHV we connect the aspiration tubing. The another end of aspiration tubing is connected to the canister, and then we switch on the pump, and then we switch on the flow switch which is on the tubing part. We place our Indigo catheter proximal to the clot. If there is flow, we know that that part is thrombus free. We advance the catheter until the clot is engaged. If flow is stopped, we use the separator. We wait for at least for 1 minute to create the vacuum, and we repeat as needed until the vessel is clear. And we take venogram in between to assess our response of thrombectomy. Some tips and tricks during thrombectomy. During access, if the sheath wire is not going through the thrombosed part, we can use softer wire like Terimo. Sometimes we have to make a loop of wire to cross the thrombosed segment. As we don't have any roadmap because entire vein is thrombosed, we can use the straight course of vein as our roadmap. We should take venogram in between to assess the site of maximum residual thrombus. We should use coring technique by rotating our Indigo catheter upward, downwards, and sideways. If there is no flow in the canister, we have to flush the tubing. We have to check all the connection, flush it, and sometimes we have to flush the main Indigo catheter if any large clot become stuck in it. And we have to start from the iliac side and come towards the popliteal side. Some do's and don'ts: never kink the catheter. Take care of a tip because tip is the most important part. We should always keep the lytic drug on the shelf, and don't be over aggressive. If you have established good flow in the vein, some residual thrombus is okay. Turbopulse technique is used for subacute DVT cases in which we take a multisidal catheter and TPA is injected in 3 ml volume in different part of thrombosed vein. We wait for 10 minutes to 15 minutes and then we use the thrombectomy catheter. Whether to place IVC filter during thrombectomy, little controversial, but generally not required as we are providing negative suction, so chances of thrombus migration are very less. And as per recent guidelines, it comes into the umbrella of relatively expanded indication. Coming to some cases, this was a young chap presenting with acute DVT, significant swelling and pain, pre-procedure venogram showing complete thrombosis, and this is the post-procedure venogram after penumbra thrombectomy showing complete recanalization and a large amount of thrombus was aspirated. This was second case, a elderly male patient with hemorrhagic stroke, so contraindicated for anticoagulation, presenting with severe pain in left lower limb, significant swelling, pre-procedure venogram showing complete thrombosis, took patient for thrombectomy, complete recanalization was achieved, as you can see in these images, and this was the iliac segment which were also completely recanalized. These are the venogram images, good flow is achieved, and this is the iliofemoral segment, complete recanalization is achieved, and actually patient got symptom relief on table. This is the amount of clot we aspirated. So to conclude my talk, penumbra thrombectomy provide quick relief of symptoms with major thrombus load reduction and should be offered to acute DVT patients. It is easy to use with no major procedure related complications. So thank you, and I'm open for discussion.
Thank you, Dr. Lalit. So now we can ask questions for 2 minutes to each speaker.
So
And,
can I
please,
trick off, Rahul?
Welcome to. Yes, please, Robbie.
Yeah. Hi, Lalit. Nice talk. I enjoyed that. So certainly the penumbra and indigo has been very attractive because you can certainly reduce the amount of lytic dose and stuff. So one of the challenges in India has been the cost associated with the indigo, the catheter itself.
Yeah, sir.
So what has been your experience, and have you found any ways around it so that we can minimize the cost and still have an equally effective clearance, or at least somewhat effective clearance?
To minimize the cost, we are not using separator in maximum cases.
We are not using the indigo catheter always?
Yeah. Because actually we can reuse it in some cases, but generally if the thrombus is very hard, tip get damaged in single case only. So to minimize the cost, we are not using separator, but if the cost permits, we prefer to use separator in case because it gives good technical advantage.
Sure. Human, please.
Yeah, thank you very much for the nice case, nice presentation. In your second case, you showed a patient, mentioned older patient with the iliofemoral DVT and then performing the penumbra thrombectomy. I think the result was good, but the iliac tract had, at least at the end of the procedure, still, in my opinion, severe involvement. If we want to say maybe residual thrombosis, but I wouldn't leave an iliac tract like that without stenting. What is your opinion on that?
You are right, sir. Actually, we did balloonplasty also in this case. There was some narrowing also at the iliocaval junction. So there could be a component of May Thunder in this case. So actually, it was an acute condition. So we just did the plasty, and due to some financial constraint, we couldn't put a stent in that case. We have asked patient to follow up, and yes, definitely we will do a follow up venogram, and we will like to put a stent.
Yeah. Lalit, that please go ahead.
Sorry, sir.
I just wanted to ask you, we have used this in pulmonary embolism also. So have you so far used it in any case of pulmonary embolism?
No, sir, I have not used. It is being used in pulmonary embolism widespreadly, but I have not used, sir. I have used only in DVT, and some arterial cases also I have used, like in SMA thrombectomy, I have used it also.
Okay,
Dr.
last
Jalai,
question from Dr. Malakati. Yeah, please. Robbie, you want to say something?
Yeah, so I just wanted to ask Dr. Jalai, really, actually, if that's all right. This is a bit of a controversy regarding stents and acute DVTs in the iliocaval segment. And Manish and, the Gujarat group has always kind of held that you're better off just doing a plasty and leaving stenting to when the vein is not acutely inflamed. So just want to know Dr. Homanjalai's thoughts on that, because he has a huge volume of experience on this.
Thank you very much. Yes, of course, that is an issue to think about it. Which technique is better, to dilate it and wait? But from our, I would say now, 10 years of really focusing on venous system, our experience, I think Professor Duganci can tell something additionally to it. Leaving the residual thrombosis or residual stenosis won't work in many patients. So to be honest, in our group, from 100 patients, at least 85 will receive stenting. Not because we love to stent. No, this is additional cost, we know it. But leaving a residual thrombus with nearly more than 50% stenosis is a really high risk for not a good result. And we stent, we pre-dilate, and then we stent the area. Therefore, we use IVUS. In many of these patients, we use IVUS.
Can I just come in on that?
Okay.
It's okay, very quickly. I'm not sure I completely agree, purely because we used to also stent everybody after acute clot removal. We are deferring it now for 3 months because we are finding, in our view, that less than half of them actually need stenting for 2 reasons. Firstly, because their hemodynamic outflow at the venous system seems to be normal after 3 months, even though we haven't put a stent and only angioplasty. And secondly, because at least half of them, the symptoms come down. So I'm not sure, are we doing the right thing or not yet? But there is evidence that there's 8% rethrombosis rate within the first month in acute stenting. So I think the jury is still out and a trial is necessary on this. But I think both sides of the equation are valid.
Sure. I think because of the time, really, we need to move on. Thank you. There'll be a lot of talks on similar to that. We can ask questions there. Now we move to the next very important talk by Dr. Suat, and from Turkey. He's going to talk about how to do iliac stenting in chronic lesions, step by step. So he's going to present a case, exactly how we do it. Thank you, Professor Suat.
Dear colleagues, first of all, I want to thank my dear colleague and friend Raul Jindal for inviting me to give this lecture during YCon 2021. I wish all of you a healthy and happy new year, and I hope for the next year we will be together for YCon 2022 by face-to-face. Today I will talk about step-by-step approach in deep venous stenting. Actually, I will present one case for this presentation. This is a very young lady, 17 years old, and she has some form of Klippel-Trenaunay syndrome. 1 year ago, unfortunately, she underwent an external cup procedure for common femoral vein insufficiency elsewhere. From my point of view, I think she didn't need this procedure at all. After the procedure, unfortunately, she had a deep vein thrombosis, and even they didn't notice the iliac part. And when she came to me, she had a severe pain, edema, and venous claudication. And when I look at the duplex sonography by myself, I also notified the iliac vein deep vein thrombosis. And to confirm this, I make a CT venography, and I will show you the. And if you look at this, you will see the surgical incisions from the first procedure. And as you follow the vein at the iliac part, you see nothing. And even I had some hesitations about making this procedure by myself because she's very young. And maybe I don't know how many times I hesitated to make the procedure, but after then, when she said that she has lots of complaints and she is now almost preparing the exam for university, I decided to make the procedure. But procedure itself wasn't easy. You know that the puncture of the femoral vein or the deep femoral vein is the first step that you should success during the procedure. For this lady, I couldn't puncture the vein from the supine position because the femoral vein was very tiny and I couldn't puncture the vein. Maybe I could puncture the vein at the common femoral vein, and I tried. However, I couldn't have the access for my sheet because there was a cuff, and the cuff prevented the sheet pass through the common femoral vein. Then I could hardly puncture the vein from the common femoral, the femoral vein from the prone position. So you should be ready for such type of changes during the procedure. And now look at the first phlebography, and you see almost nothing from the iliac veins at all, and these are all the collaterals vein. And I could hardly recanalize the vein, and as you see, I again give contrast, but I couldn't have any right-sided, and I could only see the iliac bifurcation from the left side. And as you see, we are in prone position. It looks like we are in the left side. And this is not from this case, but sometimes you cannot recanalize the femoral vein or the iliac part with the femoral vein approach. And at these positions, you should be ready for coming from the jugular side, and you should have a snare in the armamentarium of your OR to get this wire from the femoral part, especially for the wire that you come from the jugular side. So snaring is important, and there should be a snare in your operating theater. And after this, I started predilatation from the iliac confluence, but when I want to show you this, this bulging area, a tight lesion, is just from the common femoral vein external cuff. So I couldn't dilate this with ballooning. And as you see, when I put the stent, even I couldn't do the post dilatation. It was a very tight lesion, and the cuff was preventing me. And look at this. I still have some lesions there. At this time, I decided to surgically open the groin, as you see here. So again, I changed the position to spine, and you see the cuff here. And then I surgically cut this, and I removed the parts of this cuff as much as possible, because it was very difficult to get all of the cuff at that time. And then I want to show you this. Look at this image. This was just before the removal of the cuff. And when I give the contrast, you see that there is a contrast stagnation there. So there was even no flow. So if I left this lady like this without removing the external cuff, she was definitely occluded. And after removing the cuff, you see that it changed, and we have a good washout time. So these are all everything you can have during the deep venous stenting procedures. And thank you for listening.
Thank you, sir. Fantastic lecture. Okay, we can go for the questions, please. I think there are a lot to discuss here.
So Swat, excellent talk, and obviously a very challenging case, young lady with a very nasty DVT. So when you excised the cuff, did you also do an endovenectomy, and did you add in an AV fistula? So when you do endovenectomies, do you add an AV fistulas as part of the procedure?
Dear Rob, thank you for the question. I just excised the vein, and I just excised the external cuff, but didn't do an endophlebectomy because the flow coming from the femoral vein and deep femoral vein was good. Since I measured the flow volumes before the procedure, I know the amount of flow coming from the leg part was good. I just excised the cuff, and then I post-dilate that area again before ending the procedure. And then, as I show you, the contrast washout was good, so I stopped the procedure like that.
Sure. This is not the question about the procedure itself, but these external cuffs, are they widely used in Turkey? Because this is quite a rare procedure, in my opinion, external cuffing in 16 years old girl.
Yeah, dear Igor, thank you for this question. You know, especially I totally agree with you. For this lady, I think there is no need for such a procedure because, especially for private practice, I think for having just money, unfortunately, some of our colleagues doing such type of procedures, but it is also uncommon in Turkey that we don't pursue that external cuff procedures, but especially for some private practice, I think I don't blame all my colleagues, but you know, some of them are doing such type of let's say I think they shouldn't do this, but they did the procedure, and you know, I really got sad when I see this lady with this previous procedure. And I also why I choose this lady, and I also wanted to highlight this problem, especially for deep procedures. We should be, I think, limit ourselves to just indications. We don't need to widen our indications for such procedures.
Sure.
And
Thank you.
I'm also showing this case in also presentations in Turkey just to highlight this problem.
Sure. Human, please. Human, please.
Thank you, Suat, for the nice presentation. So while you are stenting below the ligament, do you have any preference regarding this type of stent, size of stent?
Human, thank you for the question. Actually, I want to have such a preference, but you know, because of the reimbursement issue in Turkey, I am only able to use wall stent. Normally, I think below the ligament, we should use dedicated stents, but unfortunately, these are not reimbursed in Turkey at the moment, so I am unable to use dedicated stents.
Yeah, but also wall stent worked.
Yes.
So we got one question from the delegates. Do you perform surgical reconstructions for deep venous insufficiency?
Actually, Rahul, the only indication from my side for performing surgical procedures for deep venous insufficiency is unhealed venous ulcers. Sure. If the patient has an unhealed venous ulcers with proven deep vein insufficiency after correction of superficial and perforating vein procedures, and there is still an unhealed ulcer and well-documented deep venous insufficiency, then I perform. But this is a very rare indications to perform.
So, Shriram, please. Last question, please.
Yeah. Well, it's more a comment. We used to perform a lot more deep venous reconstructions before we discovered the significance of the NIVL and the results of iliac vein stenting. So today, the deep venous reconstructions are only to establish access with an endovenectomy on the femoral segment so that there's a good inflow in order to perform the iliac vein stenting, or because we are unable to recanalize an iliac vein stent and we need to do a femoral cable bypass. So really complications of what we have done now. Primary deep venous reconstruction is almost unheard of except in cancer, I think.
Sure. Thank you. I think we will move forward. It's a very important lecture by Dr. Shriram from Singapore, how to do intravascular ultrasound.
Greetings to all my friends at the Venous Association of India from Singapore. I'm afraid I couldn't decide which country I owed my allegiance most to, so I've put all the three flags up. I would like to discuss how I perform an IVUS to plan for an iliac vein intervention. Of course, I also use the IVUS for arterial as well as upper limb interventions and PCS, but that's not the subject of this talk. The problem is this concept of a critical outflow obstruction, which we had published fairly recently in phlebology, and the IVUS is used to decide whether acute non-thrombotic iliac vein lesion or a chronic outflow obstruction, is this lesion significant enough to require stenting, and what should be the nature of the stent that is used. I usually begin the procedure with an initial bilateral venogram. It's in the supine position if it's a chronic lesion. I usually use a prone position with popliteal punctures or a short saphenous puncture if I'm targeting an acute venous thrombosis. But either way, you begin with bilateral small punctures so that you can get contralateral wires across. It allows you to assess the position of the IVC. I only then upsize the sheath once the wire from the target side has been crossed into the IVC, since you need a 9 French sheath in order to pass an IVUS. One must remember to prepare the neck as well, especially if a chronic lesion is anticipated. You must have your own IVUS protocol, but a protocol is important because it saves time and it allows you to plan which side to upsize the sheath on. Your reporting will be standardized. You will not miss any significant lesions, since there are lesions other than non-thrombotic iliac vein lesions, as well as chronic thrombofibrosis in the veins. You can have lateral spurs, you can have compression from either tumors or from osteophytes in the lumbar vertebrae. You can have iliac vein webs, and these lesions will be missed without an IVUS. And in conjunction with your cross-sectional imaging that you might have done before, you will be able to plan the inventory to use for this procedure. So my pre-IVUS protocol is a bit like this. Use a small phalange puncture and confirm you're in the target vein. Bilateral popliteal access in acute thrombosis. I use a supine femoral and prepare the jugular for anticipated chronic lesions. You then do a sheath venogram and you assess the sort of anatomical landscape that you're dealing with, pass the wires into the IVC, and only then confirm that position, exchange it for a standard Teflon wire to do your IVUS, and then upsize the sheath for the IVUS and stent compatibility. The site at which I start is at the level of the right renal artery, and you can see the right renal artery here, and that is the IVC, and that is usually the site where I start the IVUS itself. Others may start it higher. The other key important point as you do a manual pullback down the IVC like this is the bifurcation of the IVC into the two common iliac veins, and you see a sort of splaying of the IVC at its bifurcation. And the final site where your IVUS actually ends, or your pullback of the IVUS ends, is at the level of the sheath. So I have marked the start position, the key important position in the middle, as well as the end position of your manual pullback. What I normally do is I record every image of interest in still position and come back and review these images one by one. So this is a normal IVC with an aorta. This is a normal common iliac vein origin. This is a common iliac vein with some compression. There's an external iliac vein web here in this position. There's a popliteal venous thrombus in this patient, and here is at the level of the inguinal ligament. You can see the inguinal ligament as well as some lymph nodes. So I record stills of each of these and come back and review these pictures at the end. This is a typical NIVL that you're likely to see, normal common iliac vein, the mid common iliac vein compressed by an NIVL with a reduction of the cross-sectional area from 192 to about 78, and then back in the external iliac vein. So in a standard NIVL, this would be the proximal landing zone, and this would be somewhere where the distal landing zone is. You must, of course, be able to identify, and you will with experience, lesions like this calcified iliac artery sitting on top of the iliac vein. The calcium plaque here will require a fairly high radial outward force stent in order to be able to expand this vein. We measure the stent based on the cross-sectional area, and this is my stent guide. One must remember that a slight oversized stent is likely to cause more pain, but an undersized stent is to be avoided because it will lead to a persistent iatrogenic outflow obstruction. So it is a bit of a balance. Reassess the upper landing zone of the stent. The usual site is here between the pedicle and the spinous process, and that is where you aim between these two goalposts. However, the final position of the upper landing zone is usually based on the IVUS itself, but this is a sort of target guide to where you probably need to land the upper end of the stent. Have access for contralateral balloon control, as will be obvious in this particular IVUS. This is a free-floating thrombus that you may be able to see inside the femoral vein, and if we don't have contralateral IVUS, and just think of it as a chronic lesion as it might appear here, then you're liable to lead to an embolism.
Tarun, the video's stuck.
I think it will move. I think it's got.
No, it's still going on, sir. It's still going on.
And these are the typical starting and end points on IVUS, a common iliac vein that's normal, the NIVL, as well as the stent at the end of the procedure.
I think it's in the. I think, sir, it's in the video only, sir.
Yeah, Tarun, we know, we can understand. Don't worry.
Sure, sir. Sir.
That's still now. Just keep the video going. The video should just play.
Tarun, your internet is working well?
Yeah, mine is. I'm okay.
No, Shriram, no, Tarun, I'm just asking Tarun. Tarun, is your internet working well?
No, internet is working very well, sir. The audio is not there in this.
So to summarize, this is my approach to IVUS and iliac vein stenting. You must make a decision on a prone or supine approach early before you start. Use a small French access and then upsize if required. IVUS from the renal artery, do a deliberate pullback slowly and look at each site. Freeze all the frames of interest so that you can come back and see them again. Once you've done that, you can put the catheter back in and do the manual record for the CDs and for medical legal purposes. Make your measurements, do a pre-stent angioplasty, and then only deploy the stent if you've got good inflow. Repeat the IVUS at the end for good stent apposition, and if required, do a post-dilatation. With that, I thank you all for listening, and I hope to see you all again when this dreadful pandemic is past us. Thank you very much.
Thank you, Shriram. Shriram, is there any, you had any case where you had a very tight lesion and, you could not dilate?
Yes.
And the second question to pertinent to that is, so what is the highest pressure? Like in AV fistulas, we go up to 36 millimeter mercury. So once I go to 36 millimeter mercury, I stop, because if I do it more, it will rupture, in our experience. And so what is the highest pressure you go in the CIVs? And is there any patient where you could not dilate the lesion? And if you could not dilate the lesions, what will be the options you have?
Okay. Yes, you can have lesions that you're not able to dilate. Firstly, the veins behave quite differently from the arteries, and the physiology of the dilatation is different as well. In the artery, we are trying to dilate the artery and actually to induce injury. We want to induce arterial injury because the artery will then remodel. It's not just a mechanical opening of the artery. With veins, we're not looking at a medial remodeling of the artery, so we're not really trying to create damage. So my suggestion would be, if you're unable to dilate, I wouldn't dilate straight away with a 16 mm balloon. If you've got a tight lesion, then immediately I would do serial dilatations. You may well know now what is the target vein stent size that you want to reach, 16 or 14 or 18. If you're unable to achieve that with serial dilatations, my suggestion is don't stent now. Come back and try and redilate at a second sitting before you stent. Because once you've actually put in one of these nitinol vein stents, it is not that easy to sort of force dilate it. You should have a pre-dilatation, let us achieve the stent size that you want. The self-expanding stents do not have the radial outward force required to be able to dilate the stent over time. So either we manage to achieve the serial dilatation to what we want, or we can come back and do a second one, but don't stent if it is underdilated. This is my view.
So what is the highest pressure you can go? Like, you can use an Atlas balloons, non-compliance and...
Oh, you can go up to 23, 24, but my point is don't start trying to achieve a 24 with the 16 mm balloon. I would start with the 7 or 8 mm balloon, and if you're already reaching maximal pressures in them, don't try and force it with the 16. Dilate it to 12 or whatever you're able to achieve on that sitting. And then once you've reached somewhere near the burst pressure of a 14 mm balloon, back off. Come back and do the 16 and 18 dilatation in a second sitting a week or 2 weeks later. And often you will find that you're able to achieve that. And then stent only at the second sitting, don't stent at the first sitting.
Sure. Any more questions? Please. Any role for covered stents and high pressures?
Not yet. And there are two reasons. The big advantage, unless of course you have a rupture, which is not that common in veins, fortunately, as compared to arteries. Thus far, there has been no role for covered stents, and the reason for that is very clear. The reason why we put covered stents in arteries is because of endothelial hyperplasia going through the interstices of the artery. Veins do not actually undergo endothelial hyperplasia. Veins undergo medial hyperplasia in response to stenting. The in-stent restenosis that you see in veins histologically is often chronic thrombosis or thrombofibrosis. It's not really multiple layers of endothelium like you see on the arterial side. So the purpose of a covered stent, which is to try and restrict the degree of in-stent restenosis through endothelial hyperplasia, that doesn't quite apply to veins. So thus far, no. Unless, of course, there's a pop, in which case you're trying to stop the bleeding.
Yeah. Yeah, Hemant, please.
Yes, Hemant.
Shriram, thank you very much. What are the criteria for you to say that is a case of real Mye-Turner syndrome and I'm going to stent it? Because we know there are a lot of overtreatments calling so-called Mye-Turners, because if you put IVUS, you might see in over 30–40% of young ladies lying in a supine position, and you put the probe on it, the duplex probe, everybody has a Mye-Turner. And you also see a lot of compression and shapes, which we see also in CT scans, in entire cava and common iliac veins. For you, when are you going to say that is a Mye-Turner, and which factors comes to your decision?
Okay. I will start by saying I will not stent based on the degree of cross-sectional area reduction on IVUS. The decision to stent or not stent should probably be almost definitely made in an NIVL even before we start the procedure. So what determines that? One hemodynamic criterion that we use, before we used to use plethysmography and MVO by SVC, maximal venous outflow by segmental venous capacitance as an index. But now we predominantly use VAFI, the veno-arteriolar flow index, which if you have a liter going down the leg in 1 minute, you should have a liter coming out of the leg in the same minute. If you have less than a liter coming out, there's probably an outflow obstruction. And we find that at less than 0.7, we're about to publish this, about 300 cases of this now, 300 plus. It does suggest that if the WAFI is less than 0.7, so only about 70% of venous outflow compared to arterial inflow, you likely have a significant lesion. But then it is a clinical decision. And we have now boiled it down to a clinical judgment based on a simple acronym called ABRE. It has nothing to do with the stent. ABRE stands for agony, which means the symptoms have to be bad enough to justify stenting. Swelling alone or a bit of swelling is not justification. R stands for recurrence. So if there is recurrent superficial venous incompetence, you're possibly missing an NIVL higher up. We would not do it for primary varicose veins where we find there's also an NIVL. B stands for BMI. So ABRE, A, agony, B is BMI. Patients with higher BMI above 30 who are obese tend to do better with stenting, as you know, for their symptoms. Patients with very low BMI, less than 21, 22, they tend to have more prolonged pain due to stenting. So thinner patients, we try not to stent. Heavier patients, we have a slightly lower threshold to stent. And the E stands for eczema. Skin changes. There have to be skin changes around the ankle, suggesting that there's the chronic venous insufficiency has progressed to a point where you can justify stenting. So in an NIVL, I sort of use the ABRE acronym as a judgment thing for agony, BMI, recurrence, and eczema, and along with the hemodynamic finding of lower veno-arterial flow indices at the groin. That sort of gives me an idea that if I find a lesion, then I will stent. Of course, that lesion may be an iliac vein web, which only needs an angioplasty. It might be a lateral spur that only needs an angioplasty. It might, of course, be an NIVL or a lumbar osteophyte that will require stenting. So that's how I make a decision.
Thank you very much.
Thank you, guys. We are running short on time. So we go to the next one, please. Dr. Tarun Grover. He's the Director of Vascular Surgery at Medanta Hospital, New Delhi. He's going to talk about how he does an AV fistula angioplasty. And he's going to also share a case where he has used a Covera, a covered stent from Bard.
Hi, welcome friends. I'm Dr. Tarun Grover. I'm the director at the Division of Peripheral Vascular and Endovascular Sciences at Medanta, the Medicity Hospital. Today, I'm going to discuss our experience with the Covera's newly launched stent from BD for AVF salvage. And this stent is an excellent stent, very flexible. It comes on a self-expanding platform. And since it's a covered stent, so it's proven to be better than the existing peripheral stents used for AVF salvage. I'll quickly show you a few cases. The first case is a patient with a chronic kidney disease, and this patient had a left brachiocephalic AV fistula, which had an outflow obstruction for which an LSV jump graft was used. And during routine surveillance, what was picked up was that there was an increased back bleed and increased venous pressure during dialysis. And the fistula had converted from a good thrill in the fistula to a pulsatile fistula on palpation. And here you see how we usually carry out our fistuloplasties is that first we gain an excess either with a small 4 French or a 5 French sheath, or you can use a 16 gauge cannula as well, just to take a venogram and decide what is the ultimate plan. And here what you can see is that a 16 gauge cannula, the excess has been taken and still pulsatile. So that's what I was trying to tell you is once the thrill starts missing and you start getting a pulsation, you know that we are dealing with intestinal obstruction. So here what you can see is that this was the original cephalic segment which had got stenosed, and now it's completely fibrosed. And this will tell you that this is the vein graft, the LSV conduit. Though all of us, know it's not one of the best conduits to be used, but we do use because we don't get sometimes adequate veins available in the upper limb. and this was used, and you can see there is a tight fibrotic stenosis. So most important part of any, I would say, fistuloplasty or venoplasty is to gain your wire access across the stenotic segment, and then you can end up with a balloon dilatation, serial balloon dilatation for this. So here what you can see is the wire has been crossed, and now we start doing serial balloon dilatation. Now here you see when you deal with significantly chronic fibrotic lesions, though you go to a very high pressure with these balloons, whether you're using a high pressure balloon like a Conquest or other balloons which are now we have Conquest which goes up to 40 millimeters of mercury, but still you have these waste, and there is always a fear that if you go beyond a particular atmosphere or beyond a particular pressure, then there is always a possibility of rupture of these fistula. So here you can see this very resistant waste which was not going. So ultimately what we decided to do is just to place a Covera stent. So this is a 10 into 100 millimeter long stent. So once you have a stent, a covered stent, then you can be very aggressive with your balloon dilatation. And the good part about this stent is that the dial system which is used for deployment, it's almost similar to the Venovo stent. So you have a smaller dial which gives you I would say a more precise slow deployment, and there's a larger dial which gives you a fast deployment. And the triaxial system, it's very good so that the stent does not jump, and the margins also covered, unlike fluency. So the neointimal hyperplasia at the end is less as compared to the previous existing stents. And the other advantage over fluency is that fluency used to be a very stiffer stent, but this is significantly flexible, which gets conformed to if there is any flexion or extension in any area where the stent is being deployed. So post-deployment, you can see the remodeling being done. And once you remodel it, now you can be a little liberal with the dilatation, because in case you cause any tear also in the vein, nothing is going to happen because you have already endolined it with a covered stent. So this is the completion run, and this 110 into 100 millimeters Covera was placed in this patient. And here you can see we have taken various venograms in arm in abducted position also, just to demonstrate that there is no kink. And it's very important whenever you do these fistula salvages, always rule out central venous obstruction, because these patients always have history of underlying catheters. So coming to our second patient, this patient, again, chronic kidney disease on maintenance hemodialysis. This patient had a right brachiocephalic fistula, because as most of you must have seen that when these patients, they get fistulas exhausted on their non-dominant arm, then usually they are offered on the contralateral side or the dominant arm. And this fistula was also salvaged 12 months back with the VMI, with the Sopera stent for a cephalic arch stenosis. But again, this was also a failing fistula with poor flows and increased pressure. And as you know, that these patients are on regular surveillance, and the duplex revealed that there is a significant stenosis of outflow vein and instant stenosis. So here again, you can see the initial venogram being taken once the wire is across the stent. And you see there is a long segment of vein which is stenosed prior to the stent, and there is a significant amount of neointimal hyperplasia at the distal end also. So post-balloon dilatation, you see, this is the image post-balloon dilatation. And there is a significant recoil and a persistent refractory stenosis at either ends. So again, the plan was to manage these refractory stenosis, which was quite fibrotic, again with the Covera stent, because all of us, we know that the cephalic arch is a very notorious area, because if you dilate with a larger balloon, there is always a possibility of having a rupture there. Again, 100 into 10 millimeter Covera was placed, and intentionally it was placed like jutting out from both the sides so that you deal with both the lesions. And this is the completion run. And unfortunately, during this time, we didn't have those flared out Covera stents, but now we have those also available in such a scenario where you want the stent to protrude into the subclavian vein across the cephalic arch. Then you can use the tapered or the flared out stents which are available now, and there is no residual stenosis. And coming to my final patient, again a patient with left upper arm BVT was done for this patient, and all of us, we know usually the distal part of either AV graft or basilic vein transposition, they start developing a stenosis at the distal end close to their junction with the axillary vein. So this patient also presented with increased venous pressure and back bleed, and the duplex revealed significant short segment stenosis in the outflow vein. So the plan was to do a venogram and do a fistuloplasty. So now sometimes there could be, the culprit could be a kink or hemodynamics in this area which caused this fibrotic stenosis. And this was a quite significant fibrotic stenosis, and it was just the first balloon dilatation. Probably it was just a 6 or an 8 mm balloon which was used, and immediately you see the moment we deflated the balloon, there was a rupture in this area. And it's very important to understand that whenever you're doing these procedures, you must have a backup inventory available, so that in case you have this sort of an unfavorable outcome after balloon dilatation, then in these cases what you can do is you can immediately put a covered stent. And luckily we had a covered stent, a Covera, available to us, because we do have a very aggressive I would say practice of doing fistula salvage. So we always have these inventory on our table. And so 10x60 Covera was placed, and here you see there is no extravasation, and this is the completion angiogram. And in fact, this patient underwent HT during the same evening, same afternoon after the procedure. And the good other important part is, unlike fluency, which require a large diameter sheaths, so here the largest diameter available is 10 millimeter, which goes through an 8 French sheath also. And this is just a pursing suture which was taken so that you don't end up pressing these fistulas for a longer duration, rather than just put a purse string so that these are fine. So in the end, I would say that always keep in mind what do you want to accomplish for your patient, and treat accordingly, whether you want a symptomatic relief, whether you're creating a dialysis excess, or there is an excess placement for these patients, then you have these patients with venous obstruction. And when to place a stent or a stent graft at first go, or shall one go on and on with the plain balloon angioplasty, is still debatable. And what we have, I would say, a protocol in our institution, or the standard recommendation is, we end up placing a stent or a stent graft after a rupture, because then definitely there is no bailout in such a situation, or there is significant poor result of venoplasty, or a post difficult CTO recanalization, where we have really spent a significant time in recanalizing these patients, or else these patients are coming back to us within 2 to 3 months. And then definitely we have to go ahead and stent these lesions. And it's very important to explain these patients that multiple interventions are the rule rather than exception in these patients. And so thank you everyone. And now actually we have been very aggressive with the use of Covera. We have used this for salvage of AV grafts, for even pseudoaneurysms in the AV grafts. And so this was a small celebration we had in our unit when we did the first 10 Coveras in India. So thank you so much.
Thank you, Taran. A very nice presentation. I just want to ask you one question. Like, it's a really, it's a very, very difficult set of subjects. Tell me, like, the first case, you placed a covered stent in the area where you use a puncture. So can you puncture these grafts? Because once we used to put in these plain stents, we were going through the stents and we could do the dialysis. So can you also puncture these grafts also?
Thank you, Rahul, for the question. Usually we try to avoid that. And in fact, in the first, it was not the cannulation site. The first case was probably the one where somebody had used an LSC conduit to bypass a steno segment. Ideally, probably that could have also managed, the steno segment could have been managed endovascularly, but somebody offered a surgical reconstruction. So that was the anastomotic site of the LSC conduit, proximal and distal, which had stenosed. And the distal one, because you have a circumferential proline suture going around the anastomosis, so we could anticipate that whether you go with a very high diameter or a high pressure balloon, you can't dilate more than the circumferential length of the proline suture. So that was our plan, to intentionally put a covered stent and then rupture the anastomosis, so that at least you endoline the area. So that was more distal, not the cannulation. But coming back to your question,
we definitely try to avoid putting a covered stent in the area where we have to cannulate. But on occasions where people had pseudoaneurysm of the grafts, we had initially placed fluency, and we had told these technicians that they can puncture the fluency stent graft.
Oh, okay, fine. Okay, thank you. Any questions, please?
No, hi, Tarun. Very nice talk. So one question, you again, I think I've asked you this before at another meet as well. So the 1000 seems to be the default stent size for AV access.
Yeah, you know, it's just a matter of coincidence. But if you really go back and see these images, probably that was the desired one, because you had to cover the whole length of this segment, and it's very difficult to decide putting two smaller stents rather than you then endoline the whole thing. So it is just that it's by default that except for the rupture one. The rupture one, we could have gone with a smaller stent because that was the only culprit area. But that was in such a hurry, and we had the only one which was available was the 10 centimeter long. But otherwise, it was just the lesions were such that, so we have been placing these for cephalic arch. Now you have these players one, and then you can use a smaller one, because in the cephalic arch you don't need a very long one.
Thank you.
And we moved on the next lecture. It's a very interesting lecture by Dr. George from South America. And it's going to talk about open and percutaneous deep venous reconstructions. Thank you, George.
Hi, everybody. I would like to thank the organizers of VICON 2021, this annual conference of Venous Association of India. And my presentation, particularly, I would like to thank Dr. Rahul Jindal. And I am sure we are going to have him soon in my country in the same way that I am going to be enjoying yours after all this nightmare of coronavirus is over. We're going to expose the prosthetic valve experience from Colombia for post-phlebitic syndrome. Once again, thanks to the Indian Society for the kind invitation. Looking forward to see and feel in all my senses your beautiful country. My financial disclosure, I am working under a research grant from Hancock Jaffe, the producer of this device. We are having a high number of patients with CVI and post-phlebitic syndrome all over the world. So the way to solve this is by creating something which is different than the approach that has been done so far, which is conservative therapy and, in some cases, surgical reconstruction with very poor results. Our approach is based on this frame of stainless steel. In the future, it's going to be nitinol. And we have a monocusp valve that will replace the damaged valve after post-phlebitic syndrome. This is the way the valve looks after it is implanted. And on your right side, you see the valve, how it looks with the monocusp leaflet. The first in-man study is studying safety, things such as infection, pulmonary embolism, native vein injury, and allergic reactions, reflux measured by duplex ultrasound, VCSS, the Venous Clinical Severity Score, and pain by analyzing the visual analog score, and of course, quality of life using the veins SIM-QOL score. Inclusion criteria, we included in this study patients with HL reflux, more than 1 second of reflux, with pulmonary incompetence, either primary or secondary. In all our cases of this study were secondary to post-phlebitic syndrome, C5, C6 patients with the ability to walk and no arterial disease as demonstrated by a negative ABI. This is the number of patients, 11 patients with an average age of 70.8. We get a reflux decrease by 45%, a VCSS decrease by 57%, and a VAS decrease by 62% in our series. This is the reflux analyzed, and you can see the way it decreases with a media of 51% in the 11 cases. We have the reduction with BCSS with a media of 61% and BCSS score with almost an improvement in 9 points after 1 year follow-up. Pain with a reduction of 65%. You see the score, the scrolls going down in every case. And this is the superimposed reflux BCSS and BAS with an improvement after 1 year follow-up in every sense that we measure. 3 patients with C6 showed ulcer after 90 days of implantation. No new ulcers occurred in any of the patients of our study, and the average ulcer-free days was 130 days for C6 patients who healed. The vein SIM-QL data shows also a very significant, statistically significant improvement in QL and SIM scores. We have 1 seroma that was successfully aspirated, 1 over anticoagulation with Coumadin therapy, and 2 minor wound infections treated with antibiotics in C6 patients. We have nevertheless 1 valve thrombosis at 5 months due to non-therapeutic ranges of anticoagulation and non-compliance from the patient. From the surgical point of view, we perform longitudinal venotomy and the femoral artery, femoral vein, with exposure of the inner aspect of the vein, placement of the vena valve, and patching the vein to make some room to allow this bulky new device to be part of the body. The healing culture, the healing of the ulcer after 90 days is dramatic, and after 60 days, we return almost to normalcy in these cases. We conclude that there was no serious safety events 180 days and 365 days. We have 1 known valve thrombosis at 5 months already mentioned. A reduce in the reflux by 51%, improvement in BCSS by 61%, an improvement in VAS score by 65%. Statistical and significant improvement in veins, SIM and QL scoring at 6 months at least, a substantial venous ulcer healing, and we, of course, are evolving in the technique from a beginning of 2.5 hours till an actual timing of 40 minutes in all cases, of the last 6 cases. The next step of this study is going to be a pivotal study with the approval of FDA and a decrease in the size of the vena valve by 9.0 millimeters instead of 10, which is the size that we are using so far. We, of course, are going to begin working with percutaneous introduction of this valve. So far, we have 1 competitor, which is the Blue Leaf device, a device that has been showing some improvement in some cases from New Zealand with endo dissection that creates a neo valve from the endothelium that seems to be working also. And I invite you to check on the literature to see how it goes. In my name and the name of my team, thank you very much, and I'm open to your questions.
Thank you, George, for sharing your experience, and really congratulations for doing this, pilot study. Please, Shriram.
Firstly, George, thank you so much for that presentation. I heard the first part of it in Bali during the ASVS meeting, and I'm still amazed at the presentation. Couple of questions and a comment. The Blue Leaf, I'm not sure how far that's going, because it's essentially a percutaneous or endovascular Meleti valve technique, and many of us haven't managed to replicate the Meleti valve technique in the open procedure. I don't know whether we will replicate its result endovascularly, but why do you choose the femoral vein, firstly, the common femoral vein, as the valve level? And in your work with the industry, would you consider putting the percutaneous valve at the level of the external iliac vein? Because as we know from Professor Raju's work on the Starling compression in the abdomen, it is really the entry into the abdomen that is the key point of pressure transmission, where we would like to see some degree of pressure regulation. So that might be one point. Secondly, do you have any experience at all in people who've had femoral vein thrombosis, but the profunda has undergone coaxial transformation, of using that valve at the level of the profunda and the common femoral?
Yes, the first question, Professor Narayanan, and once again, it's an honor to answer those to you. The size of the valve, 10.0, makes it, that's the point that we got it. We got into the decision already taken from the FDA, and that's where we get into the femoral. I have a slightly difference between conception between putting a valve on the iliac and maybe just conceptualizing the segmentalization of pressures between the femoral and a second valve, not above but below. I'm talking about popliteal. So I would love to see that. Actually, one of my insights on the device to decrease the size is just to place it on the popliteal, because I think that the difference is going to be down there, not above.
Yes.
When I completely agree with you when you say that trying to do the Maleri, it's something that we train there. I was in Modena with them, with Dr. Maleri and Dr. Luli, and it seems so easy to perform. It was so easy to perform over there, but somehow my patients in my country are completely different, and every single time that I try to do the endo valve and the endo dissection, I end up with a lot of holes in the posterior aspect of the vein, and it's really, really difficult. The Blue Leaf device has been showing some very nice experience that I'm sure it's going to be out there in the next days or months. They have already completed the first in human trial. They are presenting 13 cases, if I'm not sure, that they will be out there at the Journal of Vascular Surgery. And it seems to be very easy and very logical. But of course, we need to have the device in our hands, and we need to do at least 10 or 20 cases to see how it works and if it works. So far, the idea of a prosthetic valve works on my mind much better. Definitely, it needs to be packed into an endo device, and it needs to be solved the problem of how to hook it, how to put it in place, because one of the things that when you check on the history, the first valve, prosthetic valve, that I can recall, that I can search on the literature, was placed by my father in 1989. And from those 3 very early cases, he got 2 embolizations. So you can imagine the problem that we're facing. It's something that is going to come sooner or later. I think we will end up with a device that is going to be packed in an endo, and we will look for a version 2.0 or 3.0 in the near future.
Lovell, do you want to speak anything on the Blue Leaf? Because he just wrote that they have just published their 1-year data, the Blue Leaf. So I haven't gone through that publication. So I'm just seeing if Lovell has gone through the publication and has got some insight into the results at 1 year.
Good morning. Can you hear me?
Yes, Lovell, we can hear you.
Loud and clear. How are you?
Thank you. Good morning. So yes, the results were published. They look very good. The whole thing is not necessarily what we're seeing in terms of reflux. We use that as a corrective measure, but the bottom line is we're taking these patients and are we healing their ulcers, and their ulcers are staying closed. So that's what the ultimate is, and we need to look at that as we go forward. But the creation of this endo valve is, if you have the right patient, you select the right patient, as Jorge would say to you, then you're going to have a good result in terms of being able to be effective in creation. Whether it works or not, for the long term, we need to be seen. Thank you for the privilege, Rahul.
Thank you. Thank you, Lovell.
Hi, Rahul, I've got a quick question,
please.
if that's all right. So, George, fascinating work. I mean, really interesting. So, can I ask where you see the place of the introduction of a prosthetic valve in this era where we move so much more to correcting deep venous outflow obstruction as the primary way of managing severe CVI?
where do I see that, or how do I see it in the near future?
So how do you see the role of a valve, given that today we've kind of moved to a situation more where we are addressing the deep venous outflow obstruction as the primary modality of treatment for severe CVI, because that does seem to be increasingly what we think of as the culprit lesion.
That's a very, very good question, because so far, what I think the valve is going to work, it's going to be only in those pure reflux. If you have an obstruction, it's a completely different story. You have to convert that patient from obstructive into just refluctant by placing a stent. And we don't know what is going to happen. So far, I enforce myself to perform this procedure only in refluctant, pure refluctant. If I go there, if I go to the iliac, and if I check that there is some debris or some kind of obstructive procedure, obstructive phenomena going on, we just send the patient for a different path, which is the stenting. And the teachings from Mississippi group shows us that just by placing the stent and opening, you correct as much as you can by just doing that without taking care of the valve so far. So the patient gets even free of compression stockings just by placing and having the stent. That's what that group has shown us. It goes sometimes against a lot of rationale that you can get in your mind that how it's going to work, but it's the data shows you that it really works. So far the valve is going to be only for pure refluctant patients.
I'm really sorry. We need to stop all of you, because I know there are questions and it's a very interesting topics. We go to the next talk by Dr. Shekhar. He's going to cover up principles of venous stenting.
Good morning, friends. I'll be speaking on venous stenting principles and how I follow them. What we will discuss is iliac vein stenting. What we will not discuss is SVC stenting. Venous stenting related to dialysis access salvage and IVC stenting and its associated pathology. So to start with, the typical scenario where we suspect an iliac vein lesion is when we have a patient presenting with non-healing ankle ulcers commonly, but not necessarily in the left leg. Very often we see that the signs of CVI in the patient's leg are disproportionate to the superficial reflux findings on a duplex. There is a history of a bursting pain on prolonged standing and a history of multiple varicose vein surgeries with no significant relief in terms of healing of the leg wound. These are some of the pictures of cases where patients have landed up being diagnosed by various modalities, which I will discuss, of having iliac vein lesions. The preliminary investigation for iliac vein lesions is a CT venogram or an MR venogram. Very often patients have already come to our outpatients with these investigations being done. These are good modalities, but they have pitfalls. Very often they are false positive and false negative. False positive meaning that the CT or MRI says that there is a compression or a lesion, whereas when we further investigate, we find that there is nothing of that sort. And false negative meaning that the CT MRI tells us that all is well, whereas when we further investigate, we find that these patients have definitive iliac vein lesions and have benefited from the definitive treatment. Of course, these investigations, in addition to the above, also add to the cost. And there is, of course, an issue of claustrophobia from MRI in many of our patients. So the next investigation that we do is an ascending venogram. The anesthesia we use is a local anesthesia with sedation. Of course, we have an anesthetist on standby at all times. The access is almost always the popliteal vein because we need to assess the entire inflow. The sheath size is 5 French. Local anesthesia, as I said, we use a headhunter H1, 4 or 5 French and a thermowire to perform the initial venogram. And occasionally we require smaller wires when we have encountered SFV lesions, which we had not previously expected. The sheet size, as I said, to repeat, a venogram 5 French, which we upgrade to a 6 or an 8 French when we plan an IVUS, and a stenting, if required, the sheet size is to be upgraded to 11 French. These are some of the pictures of venogram that I'd like to share with you. As you can see, and let me clarify right at the beginning, a misconception that is that there are no collaterals does not mean no obstruction. Very often when you do a venogram, there is a school of thought among certain clinicians or interventionalists who say that there are no collaterals, so there's really no, the iliac vein is really normal, which is not true. And as I will show you in my subsequent pictures, the 2 slides on either side, you can see the lesion on a venogram itself is quite suspicious. In the center, again, double compression. The central lesion is quite obvious, but there is also a second compression close to the iliac cable junction, which might not be very obvious on a simple venogram. A little bit about the history of iliac vein compression. In the 50s, a lot of work was done by Cockett and colleagues, and they were the ones who initially said that venogram would only diagnose about 50% of cases of iliac vein lesions. But the continued reliance of venography to diagnose this lesion has been the main impediment in recognizing the wide prevalence of these lesions in limbs affected by CVD. Venography, as I said, is not sensitive because iliac vein lesions are often 2-dimensional rather than circumferential and may be easily missed in frontal projections. Iliac vein compression per se is a misnomer because compression is only one characteristic of the lesion. We might have intramural fibrosis with luminal webs. Membranes also we can find, and in some limbs affected by PTS or post-thrombotic syndrome, the iliac veins are diffusely stenotic with no focal cues. Compared to IVUS standard, the level of iliac confluence estimated by venography differed by as much as 1 vertebra in one study. So data also suggests that lesions are completely missed on venogram, and they might be as high as 67 to 69%, which is quite a startling figure. A little bit about IVUS. As I said, always superior to venography because area metrics are important in iliac vein stenting. IVUS guided stenting can be performed under fluoroscopy without contrast, especially in our CKD patients. And a more compelling reason to utilize IVUS over venographic guidance is that venography is inferior in identifying major anatomical features essential for accurate stenting. This is a quick video showing you one of the cases of IVUS that we are performing, as you can see on the left. There are 2 IVUS machines available to us in India. One is by Boston, one is by Philips company. Both have their pluses and minuses, and I've used both of them. This is a picture showing you, there are 2 pictures. On the left, you can see the Opticross 18 IVUS that by Boston. On the right, you see the Philips Volcano. Both show you very nicely and accurately iliac vein lesions, which have been marked out, and it also gives you the area, the dimension, and the actual percentage of compression. There are more benefits of IVUS. It detects residual thrombus post-lysis and helps decide whether to stent or when. Dimensions of the stent, landing zones, post-deployment evaluation is also very accurately done by the IVUS. A little bit about pre-dilatation of the lesion prior to stenting. In the days where we didn't have access to IVUS, pre-dilating a lesion with a balloon and seeing the pathognomonic wasting used to always excite us, as you can see here. The usual balloons that we used to use are the 14 or 16 mm, but nowadays, besides this, we also use IVUS, and so this is no longer used as a test to detect whether there is an obstruction or not. There is a question asked whether we need to use dedicated venous stents. Yes, the answer is yes, certainly, because the wall stent is an off-label use as it was designed for extravascular use, a much higher in-stent restenosis rate. And when we deploy into the IVC, sometimes we need to deploy the stents into the IVC a bit. They can occlude the contralateral mouth if it's not an open cell kind of a pattern of the stent. These are some of the venous stents that we use. Two of them are available only in India, the Venovo by Bard and the Sinus Venous by Optimate. You can see they are both having the open cell pattern. There are certain trials that have been conducted for the various venous stents. Among the ones used in India, the Venovo has been subjected to the vernacular study and has given good results. Some of the pictures I'd like to share with you of venous stenting. As you can see, as I've mentioned previously, a good inflow is what is paramount to a successful venous stenting, as you can see on the picture on the left and on the right. An IVUS-guided bilateral venous stenting has been done, and you can see good flow across the stent into the IVC. Disappearance of collaterals is gratifying. Of course, this is something which you can see in this picture on the left. A grossly diseased iliac vein with obstruction and multiple collaterals. You might not always, as I said, see this picture, but when you get this picture in your stent, then it's extremely gratifying to see the complete disappearance of collaterals when your stent is deployed. Post-stenting IVUS, very, very, very useful. We use it for all cases, almost all cases now when we deploy a venous stent. And you can see very accurately the good deployment of the stent on an inside an iliac vein. When to stent? Any narrowing greater than 50% is significant in veins. If it's an NIVL, we diagnosed it, you stent right away. In post-thrombotic, if you're sure there is no residual thrombus, we stent right away, or else we defer it. The reason why we defer is because there is good data to suggest that if you have residual thrombus in the iliac vein, the stent patency rates significantly come down. What diameter stent to use? As you can see on the table, previously we were of the idea that we used to use, a lot of us who have been doing iliac vein stenting for some time now started off using narrower stents, and then the rates of stent occlusion are extremely high. Now we understand that the minimum size in a common iliac vein is 16. We sometimes even use 18 mm stents in the common iliac. How far to stent? We try not to jail the opposite vein as far as possible, but sometimes it does happen, and which is why we always try to highlight the fact that we should prefer to use an open cell pattern stent rather than a closed cell, so that there is no significant obstruction to the outflow from the opposite iliac vein. Below, we can get into the common femoral vein, but we should always spare the profunda vein. Post-stenting anticoagulation, initially we use heparin or LMWA for all our cases. Thereafter, if it's NIVL, we put the patients on long-term antiplatelets. If it's a post-thrombotic case which we have stented, we use Novax as indicated for the initial thrombus. But once that initial period of thrombosis, a course of Novax is over for thrombosis as advised, as per protocol, then patients are then put thereafter on long-term antiplatelets. Surveillance and aftercare for NIVL, 6 monthly duplex is what we advise. Post-thrombotic, monthly duplex for the first 3 months, and then 6 monthly. I must like to also emphasize before I conclude that in over and above venous stenting, it is important that we don't forget things like wound care and compression for the lesion, as well as calf pump strengthening exercises, especially if our patients are elderly, with good physiotherapy. Thank you.
Thank you, Shekhar, for a very nice and lucid presentation. The length of the talk was very big, so we'll just take up one question. I know there are a lot of questions to be asked. Shriram, you have raised the hand, so you can ask the first question if you want.
It's really my question is why do you use the Opticross? I have no truck with either company. My issue here is with rotational IVUS versus solid state IVUS. The problem with the Boston IVUS is that it rotates around the catheter. As we could see in your last video, there's a lot of wire artifact when you use the rotational system in larger vessels, which is probably much better for cardiac imaging for small vessels. I don't deny it. But in a larger vessel, you get a lot of vibration of the wire and wire artifacts. So on the venous side, my preference would be for a solid state IVUS like a volcano. Is there any particular reason why you use the Opticross? Besides the fact that Opticross also has only a 22 millimeter imaging diameter as opposed to a 60 from an 035.
Yeah, it's basically goes down to availability. The Boston IVUS is, we have easy access to it because the machine is procured by the hospital. So we just need to procure the catheter. Whereas the Philips IVUS is still, it's difficult to access. And sometimes, you post a case and they don't land up at the right time. So, so that's the only reason. I agree with you absolutely. I agree with you absolutely. Yeah.
One more question, and then we'll move on to the next topic, please. Heman, please, you want to ask something? Yeah.
Rahul, can I? Edwin here.
Oh, Edwin, yeah, please.
Yeah, Shekhar, thanks for that talk. It was really nice. I wish you could go on without speeding up. Quick question. Now, with these patients who you put in a 16 and an 18 millimeter, we've had patients who come with back pain following such large stents. Have you had that problem? And if so, how have you tackled it?
Well, in my experience, the back pain is there for the first 24 to 48 hours, but thereafter it goes away. We've never had a case which has, who has had a lingering chronic backache. It's there for the first 24 to 48 hours, but thereafter, if you size your stent properly, then probably that is the key. Yeah, that's the role of IVUS. I mean, if you put a very large stent into a very small vein, you're going to land up with the persistent stretching pain. So that again highlights the fact that you need an IVUS to size your stents. If you size your stents properly, then probably you can cut down the incidence of back pain.
Sure. Thank you, Shekhar. Heman, please. Sorry.
Thanks.
Thank you very much for your presentation. I know we are on lack of time, but regarding the follow-up, I would like just to comment on it. A very early follow-up after 2 weeks after the procedure is really critical and very important. If you leave the patients for 4 weeks, as we have it also in many big studies, it is a drawback. Why? Because many of these patients, they have already the collaterals, and you open now the highway. They go home like PAD patients. If they suffer from an occlusion, they don't even realize it, or many of them don't realize it. So they come back to your scheduled 4 week, and it is too late. You can't do anything. Then you have go in the chronic course and again recanalize the chronic occluded stent. But if you catch them after 12 days, 14 days, you still can do the lysis or percutaneous mechanical thrombectomy.
Yeah.
Thank you, Heman. And I think I have to stop you all. And please don't go. I've just requested Jasmine because she has to go somewhere. So we are taking that lecture on air guns now. And you can relax and have tea because we have been running from 1.5 hours and listen to this lecture. And after that, we will start a Young Researcher Award. And thank you to all the panelists and all the speakers for a wonderful discussion on the deep venous system. So Jasmine, as I told you, she is an air weapon dealer and entrepreneur, and she's certified shooter. And Punjab, where I belong, the North India, is a very, it's like, and we got an American touch in India. So where everybody likes to have a weapon, with them, either an air gun or the other ones. So Jasmine, welcome, and she's on the panel now. And Tarun, if you can play her video, recorded video, and then we can ask any questions about air guns to her.
Sure, sir. Sure.
Guns and guts go together. Well, that's exactly the case with me. I am known by the name of Jasmine Kaur Roy, the director of Singh Gun House. I can be rightfully regarded as the first lady who is dealing in guns and related business. My motive to join the industry was to break norms. It is a perfect example of women breaking barriers and entering into a male-dominated industries. Well, I am humble enough to say and acknowledge that I have clearly carved a niche for myself here. Good evening to all the prestigious doctors and the esteemed members of this conference. Today I am here to discuss and talk about the topic introduction of air weapons and how are they beneficial for us in our life. When you want to mix things up and add something a little different to your arsenal, then you might already have on hand our selection of CO2 air pistols is a great addition worth considering. So let's discuss about classification of air weapons. First of all, let's move to CO2 air pistols. What are CO2 air pistols? There are two types of CO2 air pistols. One which can be used with pellets and second which can be used by BB steel balls. So let's study what's the difference between them. As you all know that we need ammunition for any kind of weapon. So the ammunition used for the air weapons are pellets and BB balls. These are .177 number caliber pellets and .177 number caliber BB balls. So these are the ammunitions which are used in the air weapons. So my main motive to tell you about the ammunition is there are two types of CO2 air pistols. One is pellet one and the other one is BB balls. Before moving to the next slide, I would like to tell you that a weapon is having a magazine in which the ammunition has been inserted. So you might be wondering that where are these pellets and BB balls used? They are inserted into the magazine with a 12-gram CO2 cylinder, which is the medium for CO2 gas for air pistols. Without this, you can't fire an air weapon. So, first of all, CO2 cylinder is inserted into the magazine area of the air weapon, and then pellets or BB balls accordingly are inserted into the air weapon, and then the pressure is created and the air weapon is fired. But additionally, I would like to tell you that there are certain models which can support both pellets and air pistols. Both pellets and BB balls. So they can support both the ammunition kind, but at the different type. Not at the same time, but at the different time. So I think I'm clear on this point that what are CO2 air pistols, what are the types of CO2 air pistols, and what kind of ammunition is used to operate the CO2 air pistol. Now let's move to the air guns. There are two types of air guns which can be used. One is PCP and the other one is break barrel. Let's discuss about PCP first. So, PCP air guns or pre-charged pneumatic air guns, how do they work? PCP guns use compressed breathable air, CO2 as the propellant to fire pellets. For this purpose, the air in the gun's air tank is compressed by using a high-pressure hand pump, scuba tank, or carbon fiber tank. For the tanks and the CO2 scuba tanks, I'll talk to you in the further slides. But for the moment, I'm telling you what are PCPs. Once the gun's tank is filled to the desired pressure level, the gun is ready for use. The firing sequence of a PCP is really quite simple. When the trigger is pulled, a valve opens and a quick burst of compressed air is released to travel up the barrel, pushing the pellet in front of it. Each time the gun is fired, the pressure and the volume of available air in the gun's air tank is slightly reduced. So basically, the motive of telling you about this PCP is you don't need to insert a 12-gram CO2 cylinder in this. You have to use the scuba tank with the connector pipe or a pump to fill the CO2 gas in a PCP air gun. So how will it work? First of all, you have to fill the PCP with CO2 gas and check the digital manometer inside it, and then you have to add the pellets in the magazine. There is a rare case that you have to use the BB balls, steel balls or the copper balls in the PCP air gun. So, how to fill CO2 gas in it? There are two options, scuba tank or a pump. You can also use carbon fiber tank, that is also a possibility. You can see on the screen that this is the scuba tank on the left side. Sorry for the inconvenience. On the left side, it is a scuba tank, and on the right side, it is a pump. For filling the CO2 gas in the PCP air gun with the scuba tank, you need a connector pipe to join the scuba tank meter and the nozzle of the air gun. With PCP pump, you don't need to use any connector pipe because you can use it easily with that only, with the pump itself. So let's move to the brake barrel air guns now. So what are, first of all, brake barrel air guns? Brake barrel air rifles or air guns are air guns that use a spring power plant to compress the chamber. To cock the gun, you simply break the barrel down and load the pellet and break the barrel back up into the position and then fire. Brake barrel air rifles are one of the most common choices on the market. They are affordable and can produce power from 600 feet per second all the way up to 1500 feet per second. When looking for an option that performs well again and again, this is a great choice a shooter would need. But the good news about the brake barrel air guns now is the imported air rifles have also been inserted with 10-shot magazine, which is such a great news about that. Because previously there were only single-shot air guns. So people were not preferring brake barrel air guns because of this mechanism of being a single shot. But now there are such a beautiful air guns, brake barrel air guns in the market with the 10-shot magazine. But what people personally think when they prefer brake barrels is they do not need a CO2 gas cylinder and a CO2 gas pump. So this makes brake barrel air guns more convenient to carry around the world. Now I have given you the classification of air weapons, but now I just want to tell you that the only permitted caliber by the government of India for air weapons is .177. So you specifically need to check that when you are buying an air weapon, it is of .177 caliber and the energy is less than 20 joules. Gone are the times when people were importing .22, .357, .45 air guns, air weapons. But now, under the Arms Act 2016, the only permitted caliber is .177, which is legal in India. So you all might be thinking that why I am discussing about the air weapons today. As we all know that it is not that easy to be a firearms license holder in our country, but personal defense is the important part of our life now, especially for women. So no need to worry because I'm going to tell you some of the benefits of air weapons. Because according to the Arms Act, there is no license required for buying an air weapon. only identification proof is required to buy an air weapon for the .177 caliber. So let's discuss what is the process of buying. Visit a reputed licensed dealer. Make a choice between CO2 air pistols or CO2 air guns. If you're going for air pistols, make sure you have a preference for BB air pistol, pellet air pistol, or having a preference for who can support both BBs and pellets. Secondly, if you're going for air guns, you have to choose what is the purpose you're buying for. If you're buying for target and plinking, go for break barrels. If you are interested in hunting, targeting, plinking, and competition, go for PCP air guns. After you have chosen your right air weapon, you just need to carry a bill with the serial number of the weapon from the dealer, so that you can carry that weapon around the world and nobody could restrict you on that. But the things to make sure before buying an air weapon in India especially, caliber should be .177, energy should be less than 20 joules, bill generated by the dealer should have serial number of weapon mentioned on the bill, so that using that bill you can carry your weapon anywhere you would like to for your safety. These are the most important 3 things you have to make sure before buying the air weapon. It doesn't matter how powerful your air weapon is. If you are having an air weapon who is having energy more than 20 joules and a caliber upper than .177, then it is not correctly legal in India. So you need to make sure these 3 things before buying an air weapon. Now let's come to the benefits of using an air weapon. You can use it for plinking, for targeting, for competition, for hunting, for self-defense. If you are bored with your work, you can just go to a range, you can just check the fires and you can just use it for targeting. If you are interested to be a shooter, you can use an air weapon for shooting as well, for the competitions from the district level, from the beginning level to the end one. And you can also use it for defense, for your personal defense, because there are different types of pellets. Actually, I just want to tell you that there are pellets which have different heads. One is point-headed and the other one is flat-headed. Flat-headed is basically used by the shooters who are targeting, and point-headed is used for defense, so that we can save ourselves. And there is nothing difficult to use an air weapon. Whenever you are carrying an air weapon, you should have CO2 inserted in that and a magazine loaded, because the air weapons which are being manufactured now are having a very good safety locks. Just put on the safety locks and use it whenever you have to use it for defense or you are traveling anywhere. It is not a big deal to use an air weapon, but when used in a correct way, that can be used for targeting, that can be used for plinking, that can be used for competition, that can be used for defense. One should always know all the benefits of an air weapon. So that's it with the classification and benefits of air weapons. So if you want to contact us, regarding any air weapons or firearms, since we are a firearms dealer since 1970, feel free to contact us at singgunhouse@rediffmail.com or the numbers mentioned below. If you want to visit us, you can visit us anytime at Singh Gun House, Patiala. So, thank you so much to all the prestigious doctors and esteemed members of this conference who have heard my talk, and especially Dr. Rawal Jindal, who has given me the opportunity to be the part of this conference. Now, feel free to ask me any questions and I will try my best to answer all your queries.
Thank you, Jasmine, for the introduction of air guns to us. And please, if there are any questions, anybody wants to ask, feel free to ask. But Jasmine, I'll start the ball rolling for 5 minutes. Tell me, is the velocities you mentioned is it less than 20 joules or more than 20 joules, which are legal?
Less than 20 joules.
Yeah, because in your presentation, it was written more than 20 joules.
I think that was by mistake.
Yeah, sure. No. So it is less than 20 joules, right?
Yeah, less than 20 joules.
Yeah. Okay, fine.
Thank you, Jasmine. That was a nice basic lecture. Now, most of us in Punjab do have weapons, and I have a licensed Smith & Wesson revolver. But it's getting more and more difficult to get the license. So every time I renew, it's always a problem. So now tell me regarding the air pistol, how good is it as a defense? Will you be able to grievously injure somebody who's attacking you with that?
As I have mentioned in the slide that there are different pellets.
Yeah,
pellets
in the most powerful, can you injure a person? Seriously,
yes.
That is the aim of the defense, isn't it?
Now we are having premium hunting pellets which are having the point headed. That can be used for defense, and that can be used in a very good way for defense. So you need not to carry a firearm for defense if you are not having a firearms license.
Sir, I'm telling you, the pistol I'm using, the air pistol which I'm using, if you put in a plastic bucket, it goes through and through into the wall. And that also, it's not a hunting pellet. It's just a BB pellet. So that is so strong. And the velocity is so high that you cannot see. And, it is invisible.
What is the cost of the high-end pistol, the highest cost?
CO2 air pistol you're talking about?
No, the one used for defense. Pistol,
yes, sir, same thing. Yeah, CO2 pistols,
yeah. So it can cost you up to 40K to 50K. In between that. It depends upon the import rate because the rate of euros keep on changing.
Thank you.
Yeah.
Okay. Any other questions, please? Okay. Thank you, Jasmine.
Thank you so much
for the introduction. Thank you for joining.
Thank you so much. Thank you so
Rahul,
much.
Dr. Olim, somebody has raised their hand.
Oh, just a minute. Sorry. I can't see. Just a minute. Okay. Olim, please. Olim, can you speak, please? Hello, Olim.
Dr. Rawal Jindal, hello.
Hi, Olim.
I'm very sorry. I'm in my shift and I missed my talk. I'm very sorry, but I'm ready.
No. You haven't missed your talk. Your talk will be soon. Don't worry.
Oh, really? I saw about these air guns and
no. We just preponed this lecture because she has to go somewhere. So we are just going to start the young.
I was very troubled.
No, don't worry. Not all.
Okay, thank you. I'm sorry for that.
Thank you. Okay, Jasmine, thank you. Thank you for joining.
Thank you so much. Thank you.
Okay, Tarun, we'll move to the next session, please. It's on Sevier Young Research Award, which is very, very important. So this is all the research work which is happening in India and abroad. So we had around 35 entries and we have selected 18 entries. One entry hasn't sent the presentation. So we have total of 17 entries. Now I'd like to invite the chairpersons and the judges. Dr. Leung Pong from Malaysia. Dr. YP Leong, Tarun, please, if you can put in the slide, please. He's a past president of Asian Venous Forum and also the past president of Asian Society for Vascular Surgery. Thank you, YP, for joining.
Hello, hi. Nice to meet you.
Thank you. Dr. Tomas from Poland. He's the president of Polish Society of Nephrology. Professor Alan Davis, he doesn't need any introduction. Thank you, Professor, for joining. I think Dr. Christopher, he could not join. Dr. Vijay Thakur from India. He's the Secretary of Vascular Society of India. Dr. Sandeep Agarwal from, he's the president of IMA and he's from Gangaram, Delhi. Dr. Radhakrishna Raju, he's a member of Venous Association of India. And Dr. Venkat Reddy, he's a member of Venous Association of India from Bangalore. So you, all the judges have got the score sheet. All the members will be judged on the following. There are 5 points to be acknowledged: the study design, statistical analysis, background, methods and results, timing of presentation, contribution to innovations, and questions and answers. So they have to be just like 4 points for each, to a total of 20. And 14th talk is not there. The rest of the talks are there in a serial order. And once you have just all the talks, if you can send us the results by WhatsApp or email. All the presentations are pre-recorded so that we don't have an internet problem. The presentations are not stuck, but all the candidates are available online to answer questions. There will be 5 minutes for the talk and 2 minutes for discussion. Thank you. I'll hand over the mic to Professor Alan Davis, please.
Ravul, thank you very much. It's my great pleasure to help chair this session, and it's a great pleasure to ask Dr. Chowdhury to start off the session. Thank you very much.
Okay, Tarun, if we can start with the first talk, it's by Dr. Piyush Chaudhary.
Sir, we are.
Hello everyone, I am Dr. Piyush. Today I am presenting a single center experience of EVLT of varicose veins with infinite fiber 5-ring. As we know, EVLT is the most commonly used method for treatment of varicose veins. In this procedure, laser fiber is placed in the vein. Laser energy is used to damage the vein wall, resulting in inflammation and ultimately the scar tissue. Here we can see an example of varicose vein before EVLT, and size of the vein decreases with time. At the end of 1 year, you can see just a scar tissue. So what is laser fiber? It is a flexible fiber optic laser delivery system. So coming to the characteristics, first is the tip that can be bare, tulip tip, never touch, or radial. Second is type of emission. It can be frontal emission or radial emission. Why radial fibers? Because it has a fused tip for maximum safety. There is no front firing, and radial rings are arranged in a long continuous section leading to uniform energy deposition along the vein, which results in the low power density. Is radial fiber better than bare? Yes. Comparatively, it causes less post-op pain and bruises. Pulling out is easier, less to negligible coagulation formation, less cord formation, easily return to the daily life. So here are a few studies which confirm that the radial fiber minimizes adverse effects compared with the bare tip laser fiber. So coming to the types of the radial fibers, it can be single ring, double ring, or 5-ring. Aim of our study is to assess clinical safety and efficacy of the new 5-ring infinite fiber in the treatment of varicose veins. In our study, it is a non-randomized prospective study of 30 patients with primary varicose veins from October 2020 to Jan 2021. It includes C2 to C5 patients. Venous Doppler was done in all the patients. Bilateral varicose veins were treated in the same setting. GSV, SSV, and epiphyseal veins were treated. Then follow-up was done 10 days, 6 weeks, 3 months, 6 months, 1 year, and 2 years. Patients who visited our OPD were selected consecutively. Patients with either SFJ or SPJ incompetence were treated. Epiphyseal and very superficial veins were also treated. Those patients were included who had chronic DVT less than 1 year, active SVT less than 6 weeks, acute DVT, lymphedema, or peripheral vascular disease, also pregnancy. Coming to the procedure, 1470 nanometer laser was used along with 5-ring corona fiber. 6 French sheet was placed, laser fiber placed, also laser tip placed at 1 to 1.5 centimeter distal to the junction in most cases, and in some cases at the junction for cross-sectum. Standard tumescent anesthesia technique was used using USG. Now, laser was set at 8 watts power, 8-second pulse. Ablation was done in pulse mode, 1 centimeter retraction. And after that, perforators and varicoses were treated with STS. Total energy was noted after the completion of the procedure. Intra-op and immediate post-op VAS score was noted. Follow-up was done at 10th day and 6 weeks post-op. Primary endpoints were occlusion rate and incidence of pain. Other endpoints, post-op pain using VAS score, post-op bruising, adverse events, and the study equipment failure. Coming to the data, 19 were men, 11 were women, total legs 36, patients were 30, GSV, SSV, epiphyseal veins, and most of them were GSVs in 29. Average GSV diameter was 8.24 and length was 33 centimeter. Also, SSV diameter was 7.7 mm and length was 19 centimeter. Coming to the results, occlusion rate at 10th day and 6 weeks post-op was 100%. Incidence of pain in treated area was found in 1 patient. And secondary results, average intra-op VAS score was 3.4, immediate post-op 1.7, maximum score was 7 and minimum was 0. Bruising seen in 2 patients because he had very superficial vein 2 mm. Incidence of adverse events was nil. There was no equipment failure and no EHIT. Cord was palpable only in 1 patient with epiphyseal vein ablation. So in conclusion, infinite fiber causes less bruises, pain, and cord formation. What are the future recommendations? That we should conduct a study between 2-ring and 5-ring fiber. And also there is a need to compare 1470 versus 1940 laser using infinite. Thanks.
Thank you. We've had a question from Dr. Lowell Cabinet. Could you explain to us why you used pulse mode?
We use the pulse mode because after each pulse, it is easier to pull out the fiber. And sometimes by mistake, if you're not attentive in a continuous mode, you may pull a little bit more or less of a fiber.
Okay. Does anybody else have any questions?
May I ask about the energy that you use for the procedure per 1 centimeter of the treated vein?
It was around 64 joules.
Yeah, if this is 64 joules per 5 rings, means that you have 12 joules per ring.
Yes, it is divided equally in each ring.
Thank you.
Can you tell me, do you really think there's any benefit in looking for E-hits?
As I have studied and listened to the different talks also, I think it is important to look for the EHITs regularly, and accordingly you have to place your fibers at the SF junctions, because if it is a significant, then it can cause difficulty in some patients, and especially if you are in some private practice, it's very, very important to look for any adverse sign which you can cause with a cosmetic treatment.
So do you think in routine clinical practice, we should be doing ultrasound after endothermal ablation? After you've completed the procedure, yes, you do it to check the junction then, but do you think you really need to do it after that in any long-term follow-up, unless you're doing it for research?
I think so. If you are doing regularly crossectomies, then you should make a protocol to do such kind of Doppler scans at regular intervals.
Okay. Any other questions?
Can I just ask a question? Your study, I think the ultrasound done at 6 weeks.
Yes.
What do you think of the long-term results? Is that more important at 6 weeks? I suppose. Does it tell us anything? I mean, the more of the recurrence may happen later on.
In terms of recurrence, I can tell that for 6 weeks, we haven't seen any recurrence. There was 100% occlusion of the veins. But in terms of efficacy of the fiber, we can just add on that it is very, very smooth. When you pull out the fiber during the laser procedure, it is very smooth, and hardly in any patient you can see any coagulum at the tip after the end of the procedure. And we have noticed that comparing, because we used only 1470 laser, so maybe using another frequency can give us more benefits, but still we have to see, still it's a new fiber, So we are still looking, but we are very much satisfied with this fiber.
Okay, thank you very much. I think it's time to move on to the next talk.
Thank you, sir.
Good afternoon, respected teachers. I am Akhilesh Kumar, junior resident from IMS BHU Varanasi, going to present a paper whose title is a study of GLUT1 and nerve bundle for differentiation of hemangioma and vascular malformation. This study is done under the guidance of Professor Amrita Kar, Professor Puneet, Professor S.K. Tiwari, and Professor A.K. Khanna in the Department of General Surgery, IMS BHU Varanasi. Introduction: vascular malformation and hemangiomas are benign vascular lesions that are difficult to distinguish from one another clinically and on histopathology. This confusing terminology leads to improper diagnosis, illogical treatment, and misdirected research. Vascular malformations are a result of error in morphogenesis and divided into subtypes based on their constituent vessels like capillary, venous, arterial, lymphatic, and combined form. While hemangiomas result from derangement in angiogenesis with exuberant proliferation of vascular elements due to imbalance between angiogenic and angiostatic forces. Therefore, arteries and arterioles are not the part of the lesion. The presence of arteries, arterioles, or both as an integral part of the lesion is often used as diagnostic criteria for differentiating vascular malformations from hemangiomas. Aim of a study: in this study, the presence of interlesion nerve and specific ISC markers such as erythrocyte type glucose transporter protein 1, GLUT1, and S100 have been studied to differentiate hemangiomas from vascular malformation. Methods: this is a prospective type of study with 32 sample size. Only the surface hemangiomas and vascular malformation were included in the study. Patient of varicose vein, trauma-associated AVM, intracranial lesion, and visceral hemangiomas were excluded from the study. For histopathological evaluation, and IHC samples were collected in formalin. All the H&E stent slides were evaluated under light microscope. For histology, immunohistochemical staining was performed by a streptavidin biotin method for GLUT1 and S100. A statistical analysis was done using SPSS for Windows version 23.0 software. For categorical data, chi-square and Fisher extract test was used. For comparing two groups of mean independent students, t-test was used. The critical value of P indicating the probability of significant difference were taken as less than 0.05 for comparison. Results: out of 32 patients, 26, that is 82%, were vascular malformation and 6, that is 18%, were hemangioma. GLUT1 expression was present in all 6 cases of hemangioma and 1 case of vascular malformation. Nerve bundle was present in 24 cases of vascular malformation and absent in all cases of hemangioma and 2 cases of vascular malformation. S100 was found positive in 26 cases of vascular malformation and absent in all 6 cases of hemangioma. In this slide, the above picture on the left side shows H&E stent slide of hemangioma containing multiple thin wall blood vessels, and on the right side shows GLUT1 positive status on IHC. The below picture on the left side shows H&E stent section of arterial venous malformation containing thick wall blood vessels and nerve bundle, and on the right side the nerve bundle get highlighted by S100 on IHC. In this slide, the above picture on the left side shows H&E stent section of hemangioma containing multiple thin wall blood vessels, and on the right side shows GLUT1 positive status on immunohistochemistry. The below picture on the left side shows H&E stent section of arterial malformation containing thick wall blood vessel, and on the right side showing nerve bundle get highlighted by S100 on IHC. This table represents the expression of GLUT1 nerve bundle and S100 in hemangioma and vascular malformation, and we can see that GLUT1 is expressed in all 6 cases of hemangioma and 1 case of vascular malformation and absent in 25 cases of vascular malformation, while nerve bundle was found in 24 cases of vascular malformation and absent in all cases of hemangioma and 2 cases of vascular malformation. S100 expression was found in all cases of vascular malformation and absent in all cases of hemangioma. This table represents the sensitivity, specificity, and predictive value of GLUT1 nerve bundle and S100 for diagnosis of hemangioma and vascular malformation, and we can see that GLUT1 has 100% sensitivity, 96% specificity, and 85% predictive value for diagnosis of hemangioma. Nerve bundle has 92% sensitivity, 100% specificity, and 100% positive predictive value for diagnosis of vascular malformation. S100 has 100% sensitivity, 100% specificity, and 100% positive predictive value for diagnosis of vascular malformation. Discussion: out of 32 patients, 26 were vascular malformation and 6 were hemangioma. GLUT1 in diagnosis of hemangioma has higher sensitivity, specificity, and positive predictive value as compared for diagnosis of vascular malformation. ACE100 in diagnosis of vascular malformation has higher sensitivity, specificity, and positive predictive value as compared for diagnosis of hemangioma. Presence of nerve bundle in diagnosis of vascular malformation has higher sensitivity, specificity, and positive predictive value as compared for diagnosis of hemangioma. Conclusion: this study shows that GLUT1 was expressed in all cases of hemangioma and one case of vascular malformation. Nerve bundle and ACE100 expression was found in vascular malformation but not in any case of hemangioma. Thus, we can conclude that GLUT1, ACE100 expression, and presence of nerve bundle in vascular lesions can help to differentiate hemangioma from vascular malformation. Thank you.
Dr. Kumar, could you tell us what the clinical importance of these findings are to how you would manage a patient differently?
Sir, it is very important to diagnose, to confirm the diagnosis, sir, because in case of hemangioma, it is seen that most of the lesion gradually decrease by itself. But in vascular malformation, we have to operate things, sir. So if we know the diagnosis before, we can manage according to the diagnosis, sir.
But you, so what you're saying, you're going to have to do a biopsy first to do your appropriate immunostaining.
Yes, sir.
So if you look at the S100, do you think there's any difference in the S100 pickup of nerve to skin in those people with different types of venous disease?
Sir, ACE100 is found only in vascular malformation in all types, sir. Either it is a capillary type of venous malformation or lymphatic, in all types, sir. ACE100 is found, sir.
No, what I'm asking you is if you do S100 staining on skin in patients who have leg ulceration, you find that you have a different distribution of nerves compared to people who have inverted commas normal skin. Did you have any skin taken from the tissues of the people with the malformations or with the hemangioma?
No, sir. It is ACE100 stain the nerve bundle only present in the wall of the blood vessels in the tunica adventitia.
Fine. Okay, that's fine. Thomas?
Do you think that the staining that you use can be used for all malformations, or this is only for AV malformations? Because we know that this is just part of the group of this pathology. The first question, and second, what was the age of these patients? Because speaking about the hemangioma and the spontaneous regression, it's probably also important if you check this in the young population or in the older ones when we have the persistent pathology on the skin of the patient.
So the first thing is that, sir, it is used to differentiate. We can differentiate all type of vascular malformation from this study, sir, by using GLUT1 and ACE100. And other thing is, sir, I have taken, sir, patient also includes the children and also the adults, sir. It has, this study included both the patients, sir.
Okay, and a difference between the children with possible regression and with the patients which are older and you have the lesions that persist for the rest of their life in the staining, is there any difference?
No, sir, there was no any difference, sir.
Okay, thank you.
I've not found.
Does anybody else have any questions for Dr. Kumar? If there aren't any other questions, Dr. Junjival, am I meant to be chairing all of this? Are you inviting different people up to chair different bits? Sorry, I'm happy to.
It's absolutely fine. All of you guys are chairing, and and anybody can just shoot the questions, and the talks will keep on going one after another.
Okay, so should we move on to the next? That would be great. It'd be great to have Dr. Mithra, who's going to talk to us about the analysis of gait.
Respected teachers and my dear friends, my topic of interest for research in phlebology and lymphology is the assessment of peripheral neuropathy and gait analysis in patients with chronic venous ulcers. A venous or a stasis ulcer is the most severe form of chronic venous insufficiency, which account for majority of the lower extremity ulcerations. The common risk factors being old age, obesity, previous injuries, or superficial or deep venous thrombosis. They are well known for their long-standing refractory and recurrent nature, the most common complications being cellulitis and osteomyelitis, or rarely even malignant change. They are associated with high morbidity, causing significant impact to the quality of life and the financial burden to the family. The venous ulcer should be regarded as a multifaceted syndrome in which the components of neuropathy and gait abnormalities are the least studied and so not addressed appropriately in most of the cases. Research suggests that neuropathy and gait abnormalities affect the healing of the ulcer. Neuropathy is due to the local tissue destruction along with the damage to the peripheral nerves. An EMG reveals a prolongation of distal motor latency and a reduced vibration threshold. The most common nerve fibers affected are A alpha, beta delta, and thermoephrine C fibers. A few studies have been done to identify a relationship between chronic venous insufficiency and gait alterations. The patients with venous ulcers also have abnormal walking motions and foot pressures. So, the treatment of associated neuropathy and physical rehabilitation with gait training in order to supplement the current treatment of venous ulcers can potentially improve healing rates or decrease the recurrent ulcers in these patients. The study design is as follows. The primary objective being to analyze the prevalence of peripheral neuropathy and to establish its association with gait disturbances in patients with venous ulcers. And the secondary objective is to treat the peripheral neuropathy and gait disturbances as an adjunct in the management of chronic venous ulcers. It is a case-controlled study involving 25 limbs with active or heel ulcer compared with 25 control limbs with C2 to C4 disease. This will be studied at Christian Medical College over a period of 1 year. Inclusion criteria of patients with not infected venous ulcers or a history of ulceration. An exclusion criteria or any history of neuropathy or other conditions like diabetes, concomitant arterial disease, or other orthopedic or systemic pathologies. Once the case is included in the study, the proper history and examination is done along with an objective neuropathic assessment with the help of neuropathy disability score, which includes vibration and temperature perception, along with the pinprick as well as Achilles reflex. And the systemic and the subjective assessment will be done with the help of neuropathy symptom score based on the patient's symptoms like unsteadiness in walking, burning or aching pain, pricking or tingling sensation, or any numbness in the feet. And patients with active or heel ulcers would be sent to a special gait analysis lab wherein the patients are made to walk across a mat which is attached with calibrated capacitive sensors which are connected to a computer which detect the pedal pressures, dynamic pressure distributions, range of movements, as well as kinetic and kinematic measurements. And these results are evaluated and correlated statistically with the neurological data to see whether treatment of the peripheral neuropathy and gait abnormalities would benefit the patients with venous ulcers. Thank you.
So could you tell us how reliable you think these clinical measures of neuropathy are, and whether, if you're going to do a study, you should actually do formal neurophysiology measurements?
Yes, so there are various scores like Toronto score, Michigan score, which includes various modalities of this methods of assessment of peripheral neuropathy. But we have included this neuropathy disability score only for the sake of it is user friendly and it can be done quickly in the OPD itself.
Okay. And what percentage of venous ulcer patients do you think have a gait abnormality?
Usually about 20 to 30% of them, even they come limping to the OPD they say there's some mild tingling, numbness is present. Vague symptoms they will be keep on telling, but on examination, the motor power will be normal. All the movements will be normal, in other than the where the posture aspect is involved.
Thomas?
You assess the patient walking, and we know that in a big group of patients with venous leg ulcer, we have the ankle mobility disturbances with limitation of the ankle mobility. And assessing walking and looking for the objective parameters. Do you think that this is worth to assess also ankle mobility in this study, because this will be something that can objectively evaluate the possibility of at least ankle movement, which is important for calf muscle pump efficacy. So do you think that this would be the parameter that can be included, ankle mobility?
Yes, sir. Ankle mobility, it can be assessed even by simple examination, but the other parameters like this kinetic and kinematic studies, which includes the various pressures in the ankle as well as the calf. We want to see whether there are any abnormalities present in this class of patients.
Thank you. Thanks.
One last question. Do you think the gait abnormality or the neuropathy is the result of the venous ulcer, or is it causing the venous ulcer? What is your hypothesis?
It is like a vicious cycle, sir. Initially, venous ulcer causing gait abnormality, and gait abnormality, they develop this stiff ankle movements, and again, I think this is the venous ulcer.
So, what will be your treatment protocol? Your secondary endpoints are based on correcting the deformity and correcting the gait changes. How are you going to?
In case the neuropathy is confirmed, we will be using it's like a nerve we want to test nerve stimulating agents over the ulcers, and rehabilitation of the patients in a center called this Physical and Medical Rehabilitation Center at those hospitals.
Okay, thank you, Dr. Kataria. Dr. Mitra, should we now move on to the next talk by Dr. Kataria?
Good evening all. Today I'm going to talk about a study which we are carrying in the Department of Vascular Surgery at CMC Bellour. Compression versus no compression after endovenous ablation of truncal reflux and concomitant staph phlebectomies in patients with chronic venous insufficiency. As we all know, the chronic venous disease comprises spectrum of clinical manifestation in form of asymptomatic visible veins to venous ulceration. And it can be associated with a reflux, obstruction, or both. Treatment options include conservative measures like limb elevation, compression hosiery, or various intervention surgical procedure which can be open or endovenous. Society of Vascular Surgery and American Venous Forum, they have recommended endovenous thermal ablation as a preferred treatment. And post-procedurally, the compression therapy is usually advocated to reduce the pain, echymosis, edema, and to facilitate target vein occlusion. However, the compression therapy is more kind of theoretical advantage than the evidence-based. Therefore, Society of Vascular Surgery guidelines recommend compression therapy as grade 2C level of evidence. If we go through the literature in a meta-analysis published in 2019 by Chakrachi et al., they identified the 5 studies. Out of these, 3 studies did not find any significant difference in various parameters, while 1 study was in favor of extended therapy, compression therapy, due to improvement in the post-operative pain and quality of life, while 1 study was in favor of shorter therapy due to associated complication. Similarly, in another study which is published recently in European Journal of Vascular and Endovascular Surgery, they did not find any significant benefit of compression therapy after radiofrequency ablation. However, there is a lack of evidence regarding the role of compression therapy in patients who are undergoing both truncal ablation and staph phlebectomies. And most of the previous studies which are done, they are included the patient of the class C2 to C4. And there is a lack of evidence in the Indian population. So objectives of our study are to assess the anatomical success rate in terms of target vein occlusion, to assess the clinical efficacy in terms of VCSS and quality of life using the civic scoring, and to estimate the magnitude of post-operative pain using VAS score and need of post-operative analgesia, and to determine the safety in terms of various post-operative complications. So this is a prospective randomized controlled trial which is undergoing in the Department of Vascular Surgery at CMC Vellore with a target sample size of 180, and a dropout rate of 15% was assumed for 3 months follow-up. And there were two groups, group A and 2, of 90 patients each. And the patients of age group between the 18 to 65 years and clinical class of C2 to C5 and patient who have truncal reflux diagnosed on the duplex ultrasound scanning are included in the study. While the patient who have active DVT, post-thrombotic limb, having previous surgery for varicose veins, pregnant patients, patient not willing for surgery, or any contraindication of compression therapy, they are excluded from the study. So randomization is done using the block randomization method, and patients are randomly allocated using the sealed, consecutively numbered opaque envelopes. This is a detailed algorithm of the study. The patients who fit for the inclusion criteria, fit in the inclusion criteria, they will be pre-operatively assessed for the venous clinical severity and the CIVIC 20 score. And all the patient will undergo standard endovenous ablation of the truncal reflux with concomitant staph phlebectomies. Post-procedure, each patient will be given compression for 48 hours along with the analgesia for 48 hours. After 48 hours, the patient who fall into the compression group, they will be advised to continue compression therapy, and patient who are in non-compression group, they will be advised to discontinue compression. And patient will be assessed at day 5 for the anatomical success rate and for the post-operative pain and the need for analgesia from day 3 to 5 and any major or minor complication. Then patient will be reassessed at the 3 months for the anatomical success rate and for the VCSS scoring and the quality of life scoring, and along with post-operative major or minor complication. So data will be analyzed using the appropriate statistical method, and difference in the primary and secondary outcomes will be presented with the 95% confidence interval. So this is the VCSS scoring which will be used, which we are using, and the CIVIC 20 scoring, which is the Indian version, and we have translated into the various language according to the patient from where the patient region. Thank you.
So how many patients have you recruited so far?
So we have started the study in November, and total we have included 22 patients till now.
Okay. Because we've conducted a similar study called the Cometa study, which has just been published in the Annals of Surgery. I think one of the questions I think to you, do you think it would be helpful if you had a group that did not have phlebectomies?
So it's already been studied. The patient the previous studies they have included, they have not done any staph phlebectomies. They have not mentioned about any phlebectomies done. So we are basically I think this is already because of the previous study, it is somewhat established that compression may not be mandatory, but we want to see the patients who underwent staph phlebectomies along with.
Okay.
You have wide range of the patients from C2 to C5, and yes. We know that the response to the compression of some of these patients probably will differ. Like we have C2 asymptomatic patients and patients with big swelling. So what will be the size of the groups that you plan in this study regarding C3, C4, C5 pathology? Because I think that analyzing all of them together only you can miss the message that you are looking for.
Yeah.
So did you plan any size of the groups in the particular C2, C3, C4, and C5 pathology?
So we have not planned like that. We will include this much number of patients, but definitely we'll do a subgroup analysis of different groups, which we were after the 180 patients, that how many patients fall into which group. Then definitely we will be able to know about the significance level of the different groups.
Thank you.
Could you just clarify for me, and I'm sorry if I missed it, are you going to record the analgesic requirements in each group?
What requirements, sir?
The analgesic requirements. In
Yes,
each group.
we will be recording the maximum VAS score from day 3 to 5, and for 2 days we are giving analgesia to each patient, regular analgesia, and after 2 days we will ask them to take when it is required. So they will be assessed for 3 to 5 days because we are doing staph phlebectomies.
No, I understand that,
Yes,
but
sir.
will you actually record? Because a lot of patients who have endothermal ablation and stab phlebectomies don't need to take any pain relief at all, and there's a variation. So are you going to, if you have the premise that compression reduces pain, which may or may not be true depending on your thoughts, are you also going to look at the analgesic requirement, the amount that they take in each group?
Yes, sir. We will be because we will advise them to take only when there is a maximum pain. So not like mild pain is there, and we will be making them understand about the VAS scoring also. So if they have any pain, only then only they will be taking.
Okay. Do we have any other questions? If there aren't any other questions, thank you very much. And will be a pleasure to ask Dr. Agarwal to talk to us about the post-thrombotic syndrome.
Hello everyone, I am Dr. Rahul Agarwal from Care Hospitals, Hyderabad. My study is on prevalence of post-thrombotic syndrome in survivors of cancer-associated thrombosis. Patients with cancer are 4 to 7 times more likely to develop VTE, which can occur anytime during the cancer journey, but more frequently in the first 3 to 6 months after being diagnosed with cancer. Sometimes a VTE can occur a few months before the diagnosis of cancer is made. VTE in these patients is the second most common cause of death. In cancer survivors, long-term consequences such as pulmonary artery hypertension and post-thrombotic syndrome can develop. In general, post-thrombotic syndrome is the most common chronic complication of deep venous thrombosis, causing a significant social and financial burden. PTS consists of pain, cramps, heaviness, paresthesia, and pruritus. Approximately 60% of the patients with iliofemoral DVT will develop PTS. There is limited information about the prevalence of PTS in survivors of cancer-associated thrombosis. The objective of this study is to understand the prevalence of PTS in survivors of cancer-associated thrombosis. This is a retrospective study conducted using electronic medical records of all patients who underwent VTE treatment between January 2015 and July 2019. Only patients who had DVT in the lower limbs associated with malignancy were included in this study. Patients with VTE at any other sites were excluded. Their demographics, clinical and radiological data were retrieved. Follow-up data was collected over telephone and Villalta score was used. 95 out of 1,364 lower limb DVTs has cancer-associated thrombosis. Mean age was 55.6 years. 56 patients were females. Swelling and pain were the most common symptoms. Venous Doppler was commonly used for diagnosis. Left leg was most commonly involved in about 55% of the patients. Most common malignancy associated with lower limb DVT was breast cancer, followed by cervical cancer, followed by lung cancer. The most common site was iliac vein, which is about 50.52%, followed by femoral vein, which is 18.94%. All patients were initially started on low molecular weight heparin and later switched to oral anticoagulation like warfarin, acetrom, dabigatran or rivaroxaban. A minimum duration of 6 months of oral anticoagulation was given to all these patients. At 1 year, the mortality was 28.57% and the overall mortality was 68.18% at the end of the study. Villalta's PTS score was used to identify patients who has developed PTS in cancer-associated thrombosis survivors. At a mean follow-up of 2.4 years, 27 were alive, of which 8 developed PTS. The results of this study should be interpreted taking into consideration the limitation of the retrospective study, such as the missing data and the selection bias, as there are highly selected patients with severe disease referred by the oncologist. The results of the study shows that PTS can develop in cancer-associated thrombosis survivors, and the prevalence can be as high as 30% at the mean follow-up of 2.4 years. The cancer-associated survivors should be followed up and educated about this possibility to reduce the morbidity. Thank you.
Thank you very much. Would you like to comment as to whether you think using the Villalta score in this way actually has overdiagnosed the post-thrombotic syndrome? Because we know that just if you've got chronic venous disease, you can score moderately highly on the Villalta score. Would you like to comment on that?
Being a retrospective study, yes, there is a possibility that we may have a higher incidence of PTS, but scoring of more than 5 and again then follow, we can follow them further and calculate the Villalta score again, so we can decrease this possibility. And if they come for follow-up, and then we can image for the deep veins and decreases the, have a correct incidence of the PTS in them.
Okay.
Do you have any data regarding the moderate and severe post-thrombotic syndrome in this patient who survived? Because this will be an important epidemiological message. So what was the rate of the patient with the severe form of post-thrombotic syndrome? And if you can mention what kind of thrombosis, what was iliofemoral or distal or popliteal, whatever.
Those subgroup analysis is not done in detail, but that's a good question. I can look into it.
Thank you.
Because it might be useful to present your results using the LETS classification.
Can you, on your study, tell us which cancer has the higher incidence of post-traumatic syndrome? I know you mentioned that the majority of your patients are CA breast. Is it because the incidence of breast cancer is much higher than the others? Do you look at to see which particular cancer have a higher incidence?
I didn't get the question correctly, sir. But if you're asking in which cancer has the higher, it's commonly the pancreatic and the GI cancers which are more associated with deep vein thrombosis. But in our study, it was the breast cancer.
Is that because you have a higher incidence of breast cancer in that group of patients you study, or is that figure based on the percentage of such patients?
It's two reasons, sir. One is because of the higher incidence, and also because the pancreatic and GI malignancy have lower 5-year survival compared to the breast cancer. So they will have, because of our follow-up of 2.5 years, they will go out of the PTS. They will not have the time to develop PTS over a period of time.
Okay.
Have you compared the development of PTS with the treatment protocol, whether the patient had a proper anticoagulation or compression therapy during the acute DVT, or is it just all patients in whatever way they were treated?
All patients have taken anticoagulation for 6 months, sir, but compression therapy, the compliance is less, so that is not taken into consideration.
Because that is going to be significant in development of post-thrombotic syndrome. So is it just the malignancy, or is it the compliance with the therapy which has caused the PTS?
Compression therapy per se may not affect a long-term PTS, but studies, all the RCTs are don't give a clear stage if the compression therapy will really decrease the incidence of PTS. They also have some say positive and some say in the negative sense.
how long you are going to continue the anticoagulation in these patients?
Our protocol is to continue for at least 6 months. But if the patient is having an active cancer again or a recurrence, or if they are having an active chemotherapy or undergoing radiation therapy, we will continue for anticoagulation for few more months, like 3 more months, and then review them again.
Okay, I think we've probably had our 2 minutes of questions. So I think, thank you very much. And I think it's our turn to go on back to Dr. Harita Katari, who's going to talk to us about basilic vein transposition and stents.
Thank you.
Good afternoon, everyone. My name is Dr. Harita. In our case, it's religious to start. Fistula is lifeline in CKD patients. Basilic vein transposition is the third best option. And while creating one, we swear on vein mapping and vein marking. Historically, Mr. Dagger was the first one to do single-stage BVT. In limited option CKD patients, it's a challenge to decide between creation of a new fistula or salvage of the existing one. In our research, we intend to study long stents in BVT salvage. We included all consenting patients with multiple access failures with current failing BVT, significant recoil or suboptimal flows after angioplasty, re-recurrence of the lesion after, within 3 months of angioplasty. We excluded patients with major inflow lesions and central vein stenosis. Our toolkit for salvage includes brachial access, 6 to 7 French sheath, hydrophilic wire to cross the lesion, Teflon wire to deliver the hardware, 6 to 7 mm balloon dilated at 20 to 22 atmosphere pressure for a period of 2 minutes, followed by placement of long self-extent. We all know vein lesions are tough and notorious. Literature says the angioplasty results stay best for 3 to 4 months. Maybe stents have a better longevity. Translating this, our device placement success in our study was 100%. At 6 months, the PVTs with stents, out of 10, 9 were functional. By 10 months, 5 of the patients required angioplasty, including 1 patient who needed a stent to cover juxtaanastomotic and in-stent lesion. Our primary assisted patency at 3 months is 80%. One of the patients was not willing for intervention, so we did a BVT in other arm. Certainly, our results are better than plain angioplasty. Most of our lesions were diffuse with or without involvement of swing, and many of the patients has soft thrombus overlying it. Few cases to discuss. The first angio looks gory. Then post-angioplasty, it shows suboptimal flows. Post-stenting, good flows are noted. In this case, the vein is diffusely diseased. After angioplasty and stenting, good flows are noted. Now, this one is a re-intervention case for critical stenosis. Luckily, this access is viable. Now, this case involves both swing and vein. Stenting has been done and good flow is noted. Now, another case. Every proven intervention was an experiment in initial stage, so each trial matters. Few challenges we faced due to stents. First of all, cost, complications, paucity of literature to support it, and risk of needless use of stents. Limitations of our study, we have a small sample. It's an observational and single arm study. But on the brighter side, we have pick points. The lesions which are not, vein lesions which are not responsive to repeated angioplasty, they respond well to stents. Covering critical lesions with spot stenting and leaving behind diffusely diseased vein, these patients tend to return to the endo suite faster with more complex disease. So long stent is the answer. Treatment of in-stent stenosis is a possibility now. And most important, access, the untimely demise of access should not be acceptable because each access is precious. In future, our research will be strengthened by addition of a comparative arm, detailed statistics, and increase in the sample size. As a united team of vascular surgeons, nephrologists, and able technicians, our motto is to save fistula, save life. Patient awareness, communication, and timely intervention are the key to longevity of the access. Strict follow-up is our norm. I don't have any disclaimers or disclosures to make. It is a non-funded study. Thank you all for your time and attention. Have a good day.
Thank you very much. Would you just like to tell us how in your unit, you decide whether you're going to go for an endovascular solution rather than an operative solution?
Sir, the cases here we are discussing are patients who are having limited options for access. I mean, most are failed people who have no options for any access. And we have selected patients who are having repeated failures with even other procedures also, who are on perm cath or who are not having any other options. So these are particularly those patients.
Okay, and how do you decide between a stent and a balloon, or a cutting balloon, or a drug-eluting balloon? How do you decide?
So in our setup, we have very limited experience with the drug-coated balloon, Supera, or any other options apart from self-extents. We are comparing here between the plain balloon angioplasty and long self-extents. These patients where the angioplasty has failed for more than 3 times, or suboptimal flows are noted and repeated angioplasty has failed in these cases we have stented. According about this DES and other Supera or anything else, we haven't tried it yet.
Implanting such long stents in this position in the venous system, do you use any special anticoagulation or antiplatelets agents? What's your protocol? And second question, in the patient that you treated by stent implantation, did you check the rate of the stent injuries, I mean the breaking of the struts, because the location is particular and the risk of such complications which can lead to the stent occlusion is quite high. So what's your experience in this field?
So first of all, we don't give any anticoagulation in this patient. If we have done only plain balloon angioplasty, we give a single antiplatelet for 3 months. And we have stented the patient, we give dual antiplatelets for 3 months and continue on single antiplatelets thereon. And for the second question about complications, in our 10 cases, we have faced only one complication, that is in-stent stenosis. I have already mentioned about it. Because we haven't covered the juxta-anastomotic part, the lesion extended into the stent also. I mean, so we had to stent again with 6 into 120 mm, re-stent with 6 into 120 mm stent.
Thank you.
So no other complications were there, sir. If these stents extend into subclavian vein, or if we are going to plan into central veins, then the complications are higher. But in our series, we didn't face any other problems.
Is there any stent thrombosis after this one? Any incident stent thrombosis?
No, sir. No, sir. We did find that there was a soft thrombus overlying these critical stenosis, but per se not thrombosed BVTs.
If there aren't any other questions, thank you very much, and we'll move on to our next talker, and that's Dr. Syed Mohammed Ali Ahmed, who's going to talk us about Shiva versus RFA.
Randomized control trial, Chivas versus RFA with or without sclerotherapy. Chivas, it is a French term which says cure conservatrice et hemodynamique de la insufficience venous and ambulatoire. It is an often underused, underperformed and understudied technique of correcting varicose veins in the Indian subcontinent. Chivas uses principle of hemodynamic correction by column pressure fractionation, venous shunt disconnection, and preservation of venous drainage. Chivas represents a physiologic approach to the surgical treatment of varicose veins based on knowledge of the underlying venous pathophysiology gained through detailed Doppler scanning. Chivas procedure consists of stopping reflux and diverting it back into competent deeper vein through a sophisticated system of precisely placed ligation. This is a schematic presentation of Chivas where the deep vein and the perforator vein and superficial vein system is depicted with inverse flow and veno-venous shunt. Here, the fragmentation of venous pressure has taken place, interruption of the veno-venous shunt, preservation of the re-entry perforating vein, ligation below the perforator veins, and the suppression of smaller veins that remain undrained. Comparing Chivas with RFA, RFA is radiofrequency ablation. It is a commonly performed and extensively used modality for the treatment of varicose veins by ablating the long saphenous vein. The RFA procedure involves using a catheter electrode to deliver a high-frequency alternating radiofrequency current leading to venous spasm, collagen shrinkage, physical contraction, and subsequent thrombosis. Aims and objectives. In this prospective randomized controlled trial study, we aim to compare Chivas and RFA with or without sclerotherapy and study the outcome of Chivas versus RFA with or without sclerotherapy for the treatment of varicose vein in the Indian population. Study population will comprise of patients presenting to Department of Vascular Surgery, Government Rajaji Hospital, Madurai Medical College. Inclusion criteria will be patients presenting with C2 to C6 varicose veins, patients with recurrent varicose veins. Exclusion criteria will be secondary varicose veins, and patients satisfying the inclusion criteria will be subjected to real-time Doppler ultrasonography for mapping of the anatomy of the venous system. Patients satisfying the inclusion criteria will be randomized blindly into two groups with concealment using automated randomization system. The two groups will be patients undergoing Chivas and the patients undergoing RFA with or without sclerotherapy. We plan to analyze our RCT by intention to treat analysis. Subjects analyzed in the groups to which they are randomized. Sample size will be 200, 100 for Chivas and 100 for RFA. The study duration will be for 3 years. Data will be analyzed with SPSS 23.0.0.2 SPSS system of Chicago. X to the power of 2 test will be used to compare baseline characteristics between groups in order to check whether any differences had occurred by any chance. Post-procedural outcome scores will be analyzed using linear regression with 2 levels of adjustment and COVAG for secondary outcomes including quality of life and clinical improvement with adjustment in outcome for baseline values. There is no conflict of interest. Ethical committee submitted for approval and there is no source of funding. Conclusion: the quality of life, clinical improvement, symptomatic relief, recurrence rate, complications will be assessed and compared between both. The ambulatory venous hypertension will also be assessed pre-op, post-op, and at subsequent follow-ups. Endpoints: quality of life based on Aberdeen varicose vein questionnaire and symptomatic relief based on VCSS. The results shall be declared at the end of 3 years.
Thank you very much. Could you just clarify for me why you've elected to potentially using Shiva use the surgical technique, then you've decided to do RFA with sclerotherapy rather than RFA with phlebectomy? Is my first question.
We decided to do Chivas as we cater to a population which is quite poor, and Chivas it helps the patient can go back on the same day, and it is cost effective. And we are doing our hospital protocol is when we do an RFA, we do it with sclerotherapy as it is easier to do, and we have got a good expertise and we have been doing it since a long time.
Okay. What you didn't tell us is where you've got the sample size for. What actually are you thinking the difference might be? When you actually did your sample size, can you tell us what you've actually calculated on what was the primary endpoint difference that you're expecting to get with the AVVQ between the two techniques?
Our primary endpoints will be symptomatic relief based upon the venous clinical severity score and quality of life based on the Aberdeen severity score. This would be the primary endpoint. The secondary endpoint will be the ambulatory venous hypertension, which would be calculating by the column interruption duration.
Yeah, but whichever of those two you've picked as a primary endpoint, you will need to have calculated what you predict may be the difference to get your sample size. So I want to know what difference you're expecting.
It was 0.22.
0.22 in what? In the AVVQ or in the VCSS?
In the VCSS.
Okay. Okay, that's interesting, Thomas.
Speaking about Shiva, as you mentioned, this is the routinely done procedure in a hospital. But In this study, what will be any size limit regarding the diameter of the vein when you would not qualify the patient for Shiva, because we know that results, especially in the patient with very large veins, are a little bit different. And as you mentioned in your talk, you have C4, C5 patients as well, so very advanced disease. So any anatomical limitations regarding the size of the vein treated by Shiva, because we know that with radiofrequency we can safely do the procedure up till even 15 millimeters. Would you do the same for Shiva?
No, for Shiva, veins which are less than 3 millimeters, we wouldn't be doing. Any vein that is greater than 3 millimeters, we would be going through with Shivas.
But what about the trunk of the saphenous vein?
What
what
about
will be the diameter that you will not touch with Shiva?
Please repeat.
Now you want to use Shiva and also radiofrequency. So is there any saphenous vein size limitation that will be contraindication to go for Shiva?
Yes, that would be 3 mm. There are two subgroups. There is one group that we would be entirely doing with Shivas, and there would be one group which will be treating with RFA and sclerotherapy. The cutoff would be the 3 mm.
As the biggest value or smallest value?
That would be the smallest value.
Okay, but the biggest one?
Biggest one, we haven't as such given it a fixed value. The smallest one would be 3 mm, biggest one we haven't given, because this is a new study that we would be starting. We haven't started the study yet. This is a proposal, it is waiting for ethical committee.
Okay, thank you.
Do we have any other questions? If we don't have any other questions, thank you very much. And it's a great pleasure to move on to our next talk. And I apologize to Dr. Viswanatha Atteragapura, but I'm sure I pronounced that completely incorrectly. So I apologize for that, but I look forward to listening to your talk.
Good evening, everyone. I'm Vishwanath from Care Hospitals, Hyderabad. I'm here to present my work on objective assessment of anatomical changes in advanced chronic venous insufficiency using artificial intelligence and machine learning techniques. Chronic venous disease is characterized by unique morphological changes in the lower limb. Having a reliable objective tool to study these changes can provide an opportunity to answer several challenges associated with CVI, like predicting which group of patients with early disease progress to an advanced stage, differentiating venous from non-venous edema, and diagnosis of deep and proximal vein pathology. Application of artificial intelligence and machine learning techniques to image analysis, coupled with availability of large amounts of digital data, is bringing revolutionary changes to the field of diagnostic radiology. AI and ML methods excel in interpretation of complex imaging patterns and providing a quantitative assessment of such data. Application of this technology to the field of medicine has resulted in giant strides in the areas of drug discovery, genetics, and oncology. However, its application to understand vascular pathology remains to be fully explored. Our aim is to provide a tool for objective assessment of severity of chronic venous disease using artificial intelligence and by studying the soft tissue changes associated with it on MR venograms. Ours is a prospective pilot study in which we analyzed MR venograms of 32 patients with unilateral CVD who presented to our clinic between November 2019 and September 2020. We included patients who were 18 years and older with unilateral CVI with clinical stages C4 and above and who underwent an MR venogram. Patients with clinically bilateral disease and those with history of DVT or arterial disease were excluded. We retrieved MR venograms of patients from packs and collected them into CDs. We used microdicom viewer to read the data, and data was anonymized. Pre-processing techniques like Gaussian blur were applied. Images were converted to JPEG format, and Google Collaborative Notebook were used for image analysis. A 121 dense-net convolutional neural network was trained to identify whether a venogram was normal or not. We wanted to study whether the algorithm was able to differentiate a normal from an abnormal leg, and if so, how. and to separate and quantify the areas of individual leg compartments and analyze the texture of soft tissues which reflect the changes associated with chronic venous insufficiency. This slide shows the patient characteristics. Majority of the patients were male between 40 to 60 years of age and had left-sided disease. We used 4,100 images from 32 patients to train, validate, and test the model. We could achieve an accuracy of prediction up to 97%. We used deep Taylor decomposition to explain how the model was able to make its predictions. The areas highlighted in pink and blue, that is changes in the subcutaneous tissue and bone marrow, were responsible for labeling a venogram as abnormal by the CNN. We used multi-Otsu thresholding to auto-segment these images based on the grayness of each region. By doing so, we were able to separate superficial and deep compartments of the limb, as each one had a different level of grayness. Then we were able to calculate the cross-section areas of individual compartments of the limb and were also able to measure the ratios. We then calculated the ratios of cross-section areas between normal and corresponding abnormal limbs. CVD is characterized by changes like edema, inflammation, and fibrosis, all of which cause a change in texture on the affected side. So we constructed what are called gray level co-occurrence matrices for texture analysis. There are several variables which can be used as a measure of texture like entropy, contrast, etc. And we measured energy levels and dissimilarity levels in the images for texture analysis. This graph shows energy level ratios between normal and abnormal limbs, which is a measure of texture. The limitations of the study include lack of true controls and lack of predefined methods for research. Though we used more than 4,000 images for training, a larger number would have improved the sensitivity and accuracy of the model. In future, we would like to train the model using a larger sample size, validate the model with existing standards, and create an internet or mobile-based application to facilitate the routine clinical use of this technology. To conclude, AI and ML can be successfully used to objectively identify and quantify anatomical changes in CVI. This could help clinicians in monitoring progression of the disease and response to the treatment. Thank you.
Thank you very much. We all hear lots of things, and we're all doing work on AI. But how do you think this will majorly benefit patients? In which areas of the management of venous disease do you think this is likely to benefit patients the most?
Yes. This technology can be used in several areas of management of patients with venous disease. Suppose we have a patient with a C2 disease, and he asks us whether he should get an intervention or is he going to progress in future to a more severe form of disease, say C3 stage or C4 stage. And suppose we can do an MR venogram and be able to identify the soft tissue changes earlier before they manifest clinically. We can offer him some advice on whether he should get it done or not. And also, it can better differentiate a venous edema from a non-venous edema and predict an ulceration before it occurs. Also, we can assess objectively the response to treatment, be it a compression treatment or an ablative therapy. We can actually study the soft tissue changes and see whether they are resolving or not. And moreover, currently we use a classification system which is very descriptive for using labeling chronic venous disease, like a C classification. So this kind of studying soft tissue changes objectively can provide a base for creating a classification system based on the severity of the disease.
But so what do you think the number of patient numbers that you need to put in to make this a valid tool?
3,000 number, as per the AI engineers, they say is a very good number, but the model is a continuous model, and as you keep adding data to it, the robustness of the model will keep increasing. So there is no end to what we can do with it.
Okay, Thomas.
Congratulations for this idea and this work. I think this is the future for sure. You assessed globally the shape and also the thickness of the tissue and also the texture. And you use just one sequence of MRI. It's TOF, as I saw. Yes, it's the major way that you analyze the pictures. Do you think that adding the phlebography, MRI phlebography, especially with the new modalities like 4D imaging, gives you the chances to have the complex view into the not only anatomy but also hemodynamic that can be assessed in such a, let's say, simple way, but in reality it's a very difficult way.
Yeah, it definitely will, sir. And we conducted this as a pilot study to see whether the idea works or not. Since it is working, we definitely will take your comments into consideration and we'll consider that also.
Thank you.
Anyone else got any other comments about this very nice, innovative study? If not, thank you very much, and I look forward to hearing more about this in the years to come and how it changes our clinical practice. Thank you very much.
Thank you
now
so
my
much, sir.
great pleasure to introduce Dr. Aturu, who is going to tell us about lipodermatosclerosis.
Good evening, everyone. I'm Dr. Harini Aturu, consultant psychiatrist from CARE Hospitals, Hyderabad. I would like to present our interdepartmental research with vascular department on the experiences of patients living with lipodermatosclerosis. As you all know, varicose veins and chronic venous disease have significant impact on quality of life. Patients with LDS, in addition to dealing with symptoms associated with venous insufficiency, must cope with psychological aspects of living with discolored legs. Understanding the patient's perception on LDS can help the clinicians to tailor the treatment options to meet the expectations of the patients. Hence, in this study, we aim to understand the experiences and challenges faced by the patients suffering with LDS. CARE Hospitals Institutional Ethics Committee approval was received and the trial was registered in CTRI. All eligible patients were screened for the inclusion and exclusion criteria. Only patients aged 18 and above with skin discoloration in the legs due to venous disease were included in the study. The face-to-face interview was conducted by the authors using qualitative, semi-structured, and in-depth interview to record their experiences, including patients' chronological narrative, their reflective discussion, and their unique experiences of living with LDS. So this was the semi-structured questionnaire that was used. The results showed that 21 men and 9 women were included. The mean age was 52 years and the average duration of the symptoms was 82 months. The interview results were transcribed and searched for keywords. The key words were organized into 5 domains covering areas of perception of disease, physical, psychological, family, and social impact. So most of the patients thought that obesity, trauma, and lifestyle were responsible for their condition. Most of them perceived the skin discoloration to be untidy and stigmatizing. The second domain, physical impact. The common physical symptoms were pain, swelling, and discoloration. Some people had sleep disturbances. Many were unable to sit or stand consistently, which impacted activities of daily living and work. The third domain, psychological impact. Patients described the psychological impact as feeling sad and guilty. They were worried and anxious about the condition. Some of them expressed self-pity, self-neglect, and self-blame for the condition and the delay in seeking appropriate medical advice. In the initial period, most of them were concerned or hesitant about revealing their condition to the family members, leading to delay in seeking medical advice. When revealed, the family members were also anxious and concerned, but were supportive in helping them seek appropriate medical advice. The marital issues were not expressed much. Coming to the impact on social life, most of them were embarrassed and worried that others might notice the skin discoloration and ask them questions. This led to restrictions in their daily wear and social and work life interactions. Before concluding, The limitations of the study should be considered. This being a pilot study, the number of participants was small. However, this was deliberately done to generate proof of concept and develop themes on which further interviews can be based. Also, in this study, the pre-existing psychological conditions such as anxiety and depression were not assessed and considered. Within these limitations, this study shows that patients with LDS have several psychosocial symptoms that needed to be explored and addressed for better holistic care. Further research is required to derive a structured and validated questionnaire for clinical use.
Thank you very much. I just wonder if you could answer for us, because we all know that people with chronic venous disease are more likely to be depressed and anxious compared to the normal population. Could you maybe tell me what you're obviously developing a new score with your semi-structured interviews. Could you tell us, did you use anything like the HADS or the CES score to get, which may or may not be a gold standard, but something that is there as a more generic test to, in a way, validate your findings? Well, I accept you're looking at a small group, but it would be quite nice to know, were your cohort, where they compared to the rest of the general population?
I'm sorry, yeah. So in this study, we initially gathered what we call grounding techniques. So we got some themes and the key features. So we want to go on to make a questionnaire, and then further study, we want to, as you said, some gold standard questionnaires like HADS, Hospital Anxiety Depression Scale, and also the Anxiety GATS scale. And we want to correlate each question to see how the HADS scoring and GATS scoring is, so we know which questions are more related or giving us appropriate validity and face validity, so we can generate a proper questionnaire. So the research is just we got only the key words in this, and from here we still have to carry on further research.
And how do you think your deprivation index will score against your respective tests?
You mean how some of them are not looked into, or
No. Sorry, what I meant was, in the UK, we often look at things dependent on people's, inverted commas, social class, but rather than on social class, you do it on deprivation, which looks at multiple factors, be it race, be it income,
yes,
be it education. So and just wrapping it all up in the deprivation index. So I just wondered whether you'd collect any data on deprivation indices when you do the larger study.
I will definitely include all the demographics, including all the parameters what you have mentioned. This will give us a broader idea, like which social category of people, men, women, what age group, whether they are working, not working, dependent, all these kind of categories, as we look into closer on a bigger scale, will give us or the clinicians or the vascular surgeons to understand or pick who may need early interventions from the psychologist or psychiatrist. So definitely in the bigger study, all those parameters will be taken, correlations will be done, and the study or the scale will be further validated to make more specific for this lipodermatosclerosis patients.
Thomas?
Lipodermatosclerosis we can see in C4, C5, C6 patients. So there is the variety of the patient group, and I think that if you think about the publishing this research in the future, which would be great to read, you have to supply your study with objective evaluation of the disease severity, so like VCS score and also some other investigation which will just make the objective evaluation what are the patients who you are checking, and this should be the part of the study, because if you focus on the lipodermatosclerosis only, this group is very unhomogeneous. So if we speak about the lipodermatosclerosis in course of the chronic venous disease, this group should be established and also properly objectively checked. So just advice.
Yeah, thank you. I will definitely go into that. In this study, what we have done, we only wanted to focus on lipodermatosclerosis. So the vascular team, when they have seen in their clinics, they were the ones who have picked up the cases. They discussed about the research, and patients who were interested volunteered for the study. They gave the consent, and then they were approached, patients were approached. So it was in conjunction with the clinical team.
Okay, thank you.
Okay, thank you very much. If there aren't any other questions, Dr. Ataru, thank you very much for that very interesting presentation. Thank you. And it's now my pleasure to ask Dr. Luthra to come and talk to us about endovenous ablation.
Good evening, everyone. I thank Venous Association of India to give me this opportunity to present my proposed research. Honorable judges, teachers, and dear friends, I'm Dr. Lav Luthra from Department of Vascular and Endovascular Surgery, Fortis Hospital, Mohali, Punjab, India. The topic of my research is outcomes with 1940 dyed laser for the treatment of incompetent saphenous veins. We know the various available options for treatment of varicose veins, thermal and non-thermal techniques. Endovenous laser ablation has emerged as the most accepted and standard minimal invasive technique. There have been continuous worldwide efforts to identify the ideal wavelength with maximum possible selective damage, with greatest margin of safety and lowest incidence of adverse events. We all are very well aware of the concepts of wavelengths in laser treatment. We have evolved from 810 nanometers to 1940 nanometers of wavelength for laser treatment. The previous wavelengths were specific for hemoglobin or both hemoglobin and water, whereas the 1470 and 1940 are very specific for water. Longer the wavelength, there is an increased absorption in water that results in reduced optical penetration, thus with minimal side effects. So what is the principle of dyed 1940 laser? Higher a tissue or a chromophore coefficient of light absorption, the greater is the quantity of heat generated, and this heat is more confined to a particular zone. 1940 acts on water's second largest absorption, theoretically resulting in more efficacy and safety after the varicose veins. What does the literature suggest? The 1470 data available shows the average power required is around 10 to 15 watts, and the average lead that is generated is somewhere around 70 to 90 joules per centimeter. Whereas with 1940, the average power required is around 4 to 5 watts, and the lead generated around 45 to 50 joules per centimeter. So what are the results of 1940 laser in Indian population? Sorry, we don't have an answer to this question. So we have proposed this research. Our aim is to assess the efficacy and outcomes of 1940 nanometer laser in endovenous treatment of incompetent saphenous veins in India. We would be statistically analyzing our patients at the end of 1 week, 6 weeks, 3 months, 6 months, and 1 year on VASCOR, closure rates, bruises and cord formations, endovenous heat-induced thrombosis incidence, residual veins, nerve energy. We would also be calculating the lead in every length of the vein treated in all the patients. It is a single center prospective study with a total duration of 1 year. We will be including 50 patients after ethical committee clearance and surgery consents. Patients between age 18 to 70 years with incompetent SFJ, SPJ or both, and with symptomatic varicose veins would be included. Pregnant women, patients with DVT, recurrent varicose veins, arterial insufficiency, and patients who do not give consent would be excluded. All the surgeries would be done by a vascular surgeon who has an experience of more than 500 legs in endovenous treatment. The procedures would be daycare and done under tumescent anesthesia, and all standard operative room protocols would be followed. We will be using a 1940 laser with power set to 5 watts with a duration of 8 seconds, resulting in a lead of 40 joules per centimeter. So why this study? 1940 laser is the newest modality. It is one of its kind. We want to conduct the first study in India to evaluate its role in treating varicose veins. We want to assess its efficacy and outcomes in Indian population on the basis of VAS score, closure rates, bruise, cord formation, nerve injury, and E-hit incidents. Our references. Recently, there have been 2 published articles on initial outcomes of 1940 diode laser in incompetent saphenous veins. Both the studies have very clearly shown satisfactory initial outcomes and minimal incidence of side effects and patient compliance on the basis of pain. Thank you.
Thank you very much. Would you just like to clarify for me the importance of wavelength as opposed to the actual amount of energy that you're actually delivering at any given point?
Sir, as we all know that we've evolved from the lower wavelengths to the higher wavelengths, and like I very clearly mentioned, the principle that a 1940 diode laser would be using. The advantage is that with a lower wavelength, with a higher wavelength that is very specific to water, we can use a lower power, and the overall lead for every centimeter of the vein that we are treating is in comparative to the lower wavelengths like 1470, 980 or 940 is very less. So in most of our patients, when we treat them endovenous laser treatment, the main complaints are skin bruising or incomplete ablation of the veins. So with the higher wavelength and using a lower power, we are reducing the side effects, bruises, the local skin complications, and we are able to get a good quality of ablation in comparison to the lower wavelengths.
And do you think 50 patients are going to be enough to tell you anything?
No, sir. This is just a proposed study. We have started this protocol. We have been using 1940, but we feel initially in the first stage of the study with 50 patients, and then if we are getting good results, we can extend it. Definitely, we are going to take it to more than 50 cases.
Okay, Thomas. Oh, sorry, Venkat.
There was the question from someone.
I think it was Dr. Venkatash, but I couldn't see his full name.
Dr. Venkat Reddy. Dr. Venkat, you want to ask some question, please?
Okay, if there is no question, I have 2 questions to you. First, you use the pulse mode of laser working, and why you choose pulse and not continuous mode? This is first question. Continuous pullback mode. And second, as I saw, you use the same energy, 40 joules per centimeter for each vein. It's correct? Without taking into account the size of the vein?
To answer your first question, sir, pulse mode and continuous mode, we feel that when we use a pulse mode, because it is always when we are pulling the fiber out. So by using the pulse mode, we are able to not miss any segment of the vein, because if sometimes in the continuous mode with the speed of pulling back speed, there are possibilities we may miss a segment of the vein. Then the overall concept and the principle of the treatment is lost. So we prefer a pulse mode for that. And your second question, can I please?
This was the question about the energy which you plan to apply, because on the one slide you show us that this will be 40 joule per centimeter. It's for all veins the same, independent on the size of the vein?
Yes, we will be using, because in the 1940 lasers, we are using a 5 watts with 8 seconds. That is around 40 joules per centimeter. So we will be using the same energy in all our patients, because usually the patients we encounter have hugely dilated varicose veins. But definitely this can be modified, and we may not include those patients who may require a higher amount of energy because of the huge or the bulky veins. Like for example, patients with varicose veins of diameter around 15 or 16 mm, we may have to use a higher amount of energy. So those patients will not be included in our study. The main concept, the main principle of our study is to see that if a fixed amount of energy, that is 40 joules per centimeter, can serve the purpose of treating our patients and not causing any further complications that are usually encountered with the lower wavelengths.
Thank you.
Okay.
Thank you, sir.
Okay, that's fine. Victor, do you have a question you want to answer? Something came up in the chat, in the Q&A.
How do you going to make this study is going to be good when you compare to other like RF or MOCA?
Sir, there have been a lot of publications that have compared RF, MOCA, and then endovenous laser treatment. Yes, I agree to this fact that there is not much significant data, significant difference between RFA and EVLT. But because we have seen in our practice, and that patients usually after minimal invasive techniques usually come up with some complications like pain, bruises, cords, and residual veins. And so evolving lasers like 1470 and then 1940 have shown some promising results. Like I mentioned in my references, the two studies that have been published very recently show that the patient satisfaction is of great significance in comparison with the patients who were treated with 1470 lasers. So
Okay.
I believe that EVLT has better outcomes in relation to patient satisfaction in comparison to RF.
Okay, Dr. Luthra, we'll stop you there. Thank you very much for your presentation, and it's a pleasure to ask Dr. Reddy Wide to come and talk to us about column interruption duration and venous insufficiency in the asymptomatic group.
Good evening, everyone. I'm Dr. Sudarshan from Madurai Medical College. My research topic is role of duplex-derived column interruption duration in identifying venous insufficiency in normal and high-risk asymptomatic volunteers. Varicose veins affect 15 to 25% of the population. The main abnormality in chronic venous insufficiency is ambulatory venous hypertension or ambulatory venous pressure. The way to measure this ambulatory venous pressure was standardized in 1970s, which included cannulating the dorsal foot vein and measuring the pressures of deep and superficial venous system. This is based on the concept that superficial and deep venous system act as a unicameral model where the pressures get quickly equilibrated. But if you look at the journals, this is an article published in the Journal of Vascular Surgery in the year 2000. The author stated that ambulatory dorsal foot venous pressure is not always accurate in detecting changes in the pressures of tibial and popliteal veins. Another similar article published in the year 2000, the authors concluded that the dorsal foot vein, GSV, popliteal or posterior tibial veins clearly exhibit different pressure waveforms in response to cough exercise, which indicates the three veins behave hydraulically as separate compartments in limbs. This is an article published last year in the Journal of Vascular Surgery, Venous and Lymphatic Disorders regarding measurement of ambulatory venous pressure and column interruption duration in normal volunteers. The take-home message was, traditional ambulatory venous pressure measurement through the dorsal foot vein does not reflect cough pump pressure dynamics in the superficial and deep axial veins. Column interruption duration may be an easier, non-invasive surrogate. What is column interruption duration? This is the duration of the reappearance of the flow after collapse of the vein. This is measured by applying BP cuff to the upper cuff and cough ejection produced by cuff inflation to 110 millimeters of mercury followed by quick deflation. The duration of the reappearance of the flow in the posterior tibial vein and GSV below the cuff is measured, and this represents the column interruption duration for the corresponding veins. The advantages of column interruption duration are, this is a non-invasive method, and this explains better about venous filling in the superficial and deep venous system. the need for the study. As duplex-derived column interruption duration is found to be a better alternative to explain cough pump dynamics, this study is being undertaken to evaluate its role in identifying venous insufficiency in normal and high-risk asymptomatic volunteers. Use of the study. If duplex-derived column interruption duration in identifying venous insufficiency is found to be statistically significant, then data can be used to modify the onset and progression of the venous insufficiency in high-risk individuals. Research protocol. The objective of the study, as stated earlier, this is to evaluate the role of duplex-derived column interruption duration in identifying venous insufficiency in normal and high-risk asymptomatic volunteers. This is being conducted in Government Rajaji Hospital and Madurai Medical College, Madurai. It's a prospective study. It is being conducted over a span of 5.5 years from November 2020 till April 2026. Interim results after completing 1 year of follow-up will be published in May 2022. Sample size. All patients satisfying the inclusion and exclusion criteria will be included in the study. Inclusion criteria are high-risk volunteers, that is, volunteers having risk factors like obesity, whose occupation demands prolonged standing or sitting, with a family history, female sex, tall height, and normal volunteers without having any symptoms of venous disease and with normal clinical examination and normal duplex examination within the age group of 21 to 40 years will be included in the study. Exclusion criteria: persons with history of venous thrombosis, major surgeries or major injuries to the lower limb, and age less than 21 years or greater than 40 years will be excluded. Statistical analysis. All the data will be analyzed using the latest SPSS software version. There is no conflict of interest. This study is submitted for approval for the ethical committee and source of funding for the study is nil. Study proforma and endpoints. Study proforma includes collecting all the basic data, including height, BMI, and family history, and clinical examination and duplex examination are done to rule out any venous disease. The endpoints are CEP grade and column interruption duration in GSV and posterior tibial vein. Methodology. Normal and high-risk volunteers with CEP clinical status C0 asymptomatic are included in the study, and the CEP status and column interruption duration in posterior tibial vein and GSV below the knee are recorded initially and at every 6 months, and the data will be analyzed statistically to evaluate the role of column interruption duration in identifying venous insufficiency in high-risk and normal volunteers. Thank you.
Thank you very much. Could you just, and maybe I've missed the point, could you maybe just tell me how many patients you need? But much more importantly, if you look at the progression of venous disease as from the Edinburgh study or the Bonn study is about 1 to 2% per annum, do you really think it's worthwhile doing follow-up every 6 months and not doing it? You've got a 5-year study, but maybe only doing it at 2, 4, and 5 years, just to minimize the number of follow-ups that you're doing, or if I missed the point?
So we are including the only healthy volunteers in the study. So we plan to do for every 6 months. We basically include the patients who doesn't have any clinical or ultrasound disease of ultrasound venous disease. So healthy volunteers, so we want to evaluate every 6 months to see over a period of 5.5 years if they develop any venous insufficiencies.
Well, but what I'm trying to suggest maybe is that if you could, rather than using your resource to scan people quite so frequently, you would be better to get more people and scan them less infrequently when you've only got a disease that progresses by 1 to 2% per annum. That was my suggestion.
Sure, sir. We'll include that in the study, sir.
Thomas?
Except the SIP classification, do you send a score to evaluate the patients in regard to the severity of the disease, like venous clinical severity in this study? Because I think that combining the data that you are going to reach from this study with the clinical severity of the disease in an objective way would be nice.
Okay, so sure, sir. We'll include. We propose to include only SIP studies, SIP grading alone.
Yeah, but you know, SIP, it's you know, just the description of the class SIP. There is nothing about the severity except the clinical picture. So perhaps would be good to get more data from and more results, which will be important clinically to add just the simple evaluation by VCSS score. Just the suggestion, of course, you decide. Thank you.
Sure, sir. We'll include that also, sir.
I think it's
What do
very
you
good.
mean by high risk asymptomatic patients?
Sir, who have any family history of varicose venous insufficiency or tall height and any body obese patients, those patients will be included on whose occupation demands prolonged standing or sitting. Those patients will be included as high risk patients, sir. High risk healthy volunteers.
Yeah, because your proposed study is age limit is up to 40 years only.
Yes, sir.
Okay, if there aren't any other questions, that will be a very interesting study to hear about in the future. Could we now move on to Dr. Kota, who's going to talk to us about some genetic profiling in malformations? Thank you.
Good evening. Vascular malformations are one of the commoner diagnoses that we make in our outpatient clinics. However, the treatment response has always been heterogeneous, with increased risk of recurrence as well as increased risk of re-intervention in these patients. With advances in gene therapeutics, we have noticed that there is a specific gene pool associated with these vascular malformations. So targeted drugs have come into foray. In a step directed towards the same, today we propose to look at genetic profile of sporadic venolymphatic malformations in Indian populations. This is our recent experience with sirolimus, which is again targeted towards one of the genes which are present in these venous malformations. And we have actually seen that 100% of our patients had regression in size and pain relief. This encouraging data has actually provoked us to do the study. In 1994, the genetic basis of familial forms of vascular anomalies has become evident. And by 2011, next generation sequencing have identified somatic mutation in various sporadic vascular anomalies. These mutations were seen to involve tyrosine kinase receptor signaling pathway, and the mutations were predominantly enriched in endothelial cells. Though most vascular anomalies were associated with a single gene mutation, some were associated with more than one gene mutation. And specifically, venous malformations have been seen to involve mutations in as many as 8 different genes. The various somatic mutations are seen in genes like TEC, PIK3CA, glomalin, and MAP3K3, with potential drug targets under development. The objectives of this study are to define the prevalence of known somatic mutations in sporadic venous, lymphatic, and venolymphatic malformations in an Indian population. The clinical implications we expect to find are whether targeted drug therapies are have significant effect in our population of patients. This will be a prospective cross-sectional study which will be conducted over the coming year in the Department of Vascular Surgery with in conjunction with the Department of Clinical Genetics, CMC Vellore. We will include patients who present to us with sporadic vascular malformations, including venous, lymphatic, venolymphatic, and FAVAs. We will exclude familial malformations, patients with arteriovenous malformations and vascular tumors, deep-seated or visceral malformations, and malformations which are unamenable for biopsy will be excluded from the study. This is the basic algorithm of the study. Once the patient consents for the study, a biopsy will be taken from the venous malformation. This sample will be preserved in saline. The DNA will be extracted and further subjected to polymerase chain reaction, which later on Sanger sequencing and next generation sequencing will be done to identify the specific panel of genes that we had previously discussed, like TY2, PIK3CA, and MAP3K3. Our sample size has been calculated to be 25 based on the estimated prevalence of these gene mutations seen by Green et al. The cost of a single gene panel will be 15,000 rupees. The total funding of the study will amount to 3,75,000 rupees. We have no conflicts of interest. This is a clinical photograph of a child who is barely able to open his eyes, and the exciting treatment response seen when treated with sirolimus. So this is one of the main reasons that we find foray into gene therapies in vascular malformations exciting. And this is our first step towards the same. Thank you for your attention.
Thank you very much. Could you just tell us, do you think there's any likelihood to be anything with the FOX2 gene at all, or why you've focused on those three?
So we've looked at various meta-analyses that have been conducted, sampling various case series as well as case reports looking at sporadic venous malformations, which is one of the commonest vascular malformation pathology that we have come across. And based on the prevalence of the gene mutation seen in these studies, that's how we decided this specific gene panel. So as far as we have reviewed the literature, we've not come across FOX being one of the genes involved in these vascular malformations, specifically venous malformations and renal lymphatic malformations.
Okay. And how do you think the genotyping will actually affect the drugs that you come up with? Because there's obviously sirolimus and other things that you've used with good effect.
So the sirolimus that we have used in our case series so far has actually been used empirically in most patients, because unfortunately Indian patients do have issues with money. We do come from a poorer socioeconomic class. So we have been using the sirolimus empirically. Only 3 out of those 25 patients have actually gone the PIK3CA typing because they were affordable for that. So we actually want to know what is the prevalence of these mutations so that, you know, it would be justified to use these drugs in our population specifically. There have been no studies so far in our populations. And on an average, we see about at least 10 to 15 venous malformations every month, which makes it quite a significant amount of our case profile. And there are a lot of patients who come back needing re-interventions. We have followed up patients for almost 10 years now who keep coming back. It's we obviously feel like we've failed them if we can't offer them anything more than just an intervention, either in the form of sclerotherapy or resection. And I think we do need to consider gene therapies in making the treatment complete in these patients.
Okay. Thomas?
Do you see any, I mean, because I am not familiar with the literature concerning the use of these 3 compounds which you want to investigate. Do you see any difference in checking venous, arteriovenous, and lymphatic malformations? What is the evidence from the literature regarding expected results?
Yes, so arteriovenous malformations, or any malformations that have arterial involvement in them, have not been studied in terms of gene therapy because the drugs have not been adapted to their specific targets. However, venous and venolymphatic malformations have been dealt with sirolimus, and various studies have come across good results. And when we looked at our data from the past 3 years, that's when we first started using it. We did have 100% response, but it comes at a cost because almost 25% of our patients had cytopenia, which is basically secondary to bone marrow depression caused by sirolimus. So I think we need to really justify whether we can use these drugs and what is the genetic profile of venous malformations in our populations. And we also need to look at other drug therapies which are analogous to sirolimus. Like, for example, other than the PIK3CA mutation, we are also looking at the TIE2 mutation and MAP3K3 mutation. We do have drug targets against them. So once we identify that they are as prevalent as they are said to be in literature, we can actually start using newer agents, looking at new agents in these.
Okay, thanks very much. Sorry, we are running on a bit in time, so we'll stop you there. But thank you very much. It's now my great pleasure to ask Dr. Bradwan to come and talk to us about the role of platelet-rich plasma in leg ulceration.
Assalamu alaikum. My name is Ahmad Radwan. I'm vascular trainee in the Egyptian Fellowship of Vascular Surgery. My topic is the use of autologous platelet-rich plasma versus conventional dressing and treatment of chronic venous leg ulcers. Under supervision of Professor Dr. Hisham Adil Alauddin and Professor Dr. Wafi Fuad Salib and Dr. Rami Mikhail and Dr. Abdurrahman Ahmed Mohammed. Introduction. Venous leg ulcers are an important medical problem. The chronic and recurrent nature of their venous leg ulcers causes morbidity, severely reduces quality of life, and increases the cost of healthcare. Venous leg ulcers account for approximately 70% of all leg ulcers and affect 2.2 million Americans annually. Management of venous leg ulcers include many modalities to obtain good results and improving patient lifestyle. These modalities include compression therapy, medical treatment, surgical and interventional procedures, and local wound care. If a healable venous leg ulcer does not heal, despite good standard treatment, adjunctive therapy should be considered. Application of autologous rich plasma has gained popularity in plastic and reconstructive surgery and orthopedics since this therapy was shown to be effective and safe in terms of better survival of fat tissue and bone grafts. Platelets contains proteins known as growth factors that triggers biological effects, including direct cell migration, angiogenesis, cell proliferation, and differentiation, which are key in the process of tissue repair and regeneration. Recent studies reveal that healing both of chronic and acute wounds is modulated by growth factors, and that cellular tissue receptors in this process of regeneration interact favorably with these. That prospective study included 40 patients with chronic venous leg ulcers recruited from the Meta Specialized Hospital for whom treatment with BRB was done for 20 patients weekly for up to 3 weeks, one session of injection per week. This was the study group, and applying saline dressing for 20 patients, control group, in addition to compression therapy and follow-up. Our objective was to compare rate of wound healing. Treatment results were calculated by percentage and of improvement in area of the ulcer in regard to rate of wound healing. Inclusion criteria was leg ulcers with an area of at least 4 centimeters, duplex ultrasound confirmed deep venous reflux or superficial venous reflux with duration longer than half a second, and or obstruction at target extremity. Normal arterial flow. The ulcer is unresponsive for at least 2 months to conventional treatment procedures, including local wound care, typical antibiotics. Exclusion criteria was patients who had more than mild reflux within greater saphenous vein or saphenofemoral vein reflux requiring operation. Pregnant women, patients having a history of malignancy, long-term steroid use, coagulation disorders, severely disabled patients, patients having exudative and discharging wound indicating presence of active local infection, neuropathic or ischemic ulcers. There was no significance in age in both study and control group according to age or according to gender or even body mass index. Change of basal cell basal ulcer area in same time period of both groups showed that in the first week, study group showed significant reduction in surface area compared to control group. This is a picture of a patient with one injection. That will be the result with marked improvement in the ulcer area. This is another patient with complete healing. This is another patient with which does not improve. Conclusion: we can draw the conclusion of our studies results that the use of BRB contributes to improving the results of treatment of venous ulcers, and that is an effective and safe therapy. However, we need to consider that application of this or any other treatment should always be accompanied by the necessary management of the underlying disease, in addition to a suitable pressure bandage that improves the venous return and facilitates favorable clinical course of lesions. Thank you.
Dr. Radwan, I'm just going to ask you a quick question because we've got to try and do a little bit of catching up on time. Could you just tell me how many applications do you think you would need to get the average leg ulcer to heal? Hello? Dr. Radwan?
So I think he's not there, sir.
Oh, he's not there. Okay, if Dr. Radwan isn't there, we'll move on to Dr. Hamed, who can tell us about chemical and mechanical catheter-directed sclerotherapy. And I will ask my colleague, Dr. Uberneck, to ask you the question after this talk.
So the Dr. Hamid is also not there. The presentation is also not here, sir.
Ah, in that case, we're catching up very well on time, and we'll move on to the sinuracrolate closure by Dr. Shirinbeck.
So.
Dear colleagues, first of all, let me appreciate the privilege and pleasure to present our paper at the Venous Association of India conference. I'd like to share with you our first experience and initial results of sinuracrolate closure of incompetent saphenous veins. As we know, sinuracrolate vein closure is a non-thermal, non-tumescent in the venous treatment modality, using sinuracrolate adhesive to occlude the vein lumen and eliminate the reflux. Long-term outcomes of the sinuracrolate closure have shown high occlusion rates compared to methods of thermal ablation. Therefore, the purpose of our study was to assess the results of sinuracrolate closure and the treatment of refluxing saphenous veins in a single center. Between July 2019 and November 2020, we treated 220 patients with a mean age of 68 years. Females were 59% of cases, and 56% of our patients were elderly. The mean diameter of the truncal vein was 9.5 millimeters, and 75% of our patients were C2 and C3 according to SEEP clinical classification. Overall, 250 sinuracrolate closure procedures were performed. Of these, 78% were great saphenous vein occlusion, short saphenous vein and anterior accessory vein occlusion were performed in 18 and 4% of patients respectively. Simultaneous adhesive ablations of several truncal vein at the same session were performed in 34% of our patients. Most of them were 2 great saphenous vein ablations, followed by great saphenous and small saphenous vein ablation. Selective sinuracrolate closure was performed in the vast majority of our cases, in 90% of our patients, and only in 10% of patients we used adjunctive side branch treatment, and all these 10% needed compression stockings. What was our results? Anatomical success was achieved in 100% of our patients. In 2 cases, we had partial great saphenous vein recanalization. The so-called phlebitis-like abnormal reaction was observed in 20% of our cases, and foreign body granuloma at the excess site we saw in 1 patients. Intraoperative pain score according to visual analog scale was very low, and in 95% of our patients it was less than 3. The length of truncal vein stumps varied between 0.5 and 2.5 centimeters without any case of glue propagation into the deep system. Our occlusion rates were 99.2%. We had no case of DVT, pulmonary embolism, or paresthesia. A very quick glance at our complications. Phlebitis-like abnormal reaction was treated conservatively. Foreign body granuloma was observed in 1 case and was excised surgically and confirmed histologically. The sinuracrolate closure in some patients was performed at the entire vein length, and we can perform it below knee, far below the knee, in both the great saphenous vein and short saphenous vein, and therefore we have total vein occlusion, which is not always possible in thermal methods of ablation. Here's a case of great saphenous vein occlusion in an elderly patient before and after 1 month. High rates of vein occlusion in short and long-term, painless procedure, no need for tumescent anesthesia, no risk of thermal injury, no need for compression, stockings, no need for capital equipment. It's a fast procedure and fast return to normal activity. These are all advantages of cyanoacrylate closure, but also we identified some special indications for cyanoacrylate closure, such as local anesthetics intolerance in cases of contraindications to compression therapy, in cases of skin conditions, morbid obesity, and low pain threshold of patients. In summary, ladies and gentlemen, cyanoacrylate closure of incompetent saphenous vein is a safe, effective, and comfortable treatment method. It's a method of choice in multi-morbid elderly patients, in morbid obesity, and in peripheral arterial disease that exclude the use of compression stockings. Cyanoacrylate closure results in high occlusion rates up to 99.2% at 15-month period of follow-up in our study, and this completes my presentation. I thank you very much for your attention.
Congratulations for the results. 99% after 15 months looks really great. And I have just 2 short questions. First, what kind of device do you use? Because this was not mentioned in the presentation. And the second is regarding this granuloma case which you described. This was granuloma in the course of the saphenous vein, or granuloma in the place of the vein puncture? Because this is probably a very important issue in regard of the late granuloma reaction. So please. We don't hear you.
Dr. Olim, just mute yourself once and then again unmute it. No, I think it's better if you remove, plug out your headphones, please. And now unmute yourself, please.
Sorry, we still don't hear you.
Can you just type in, please, if it's okay?
Yeah, just Dr. Olim, just type the answer.
So please type where was the granuloma and the name of the device, and we probably will not have this discussion normally. Venasio, okay, this is known. And the granuloma placement? Injection site or? Okay, but in the place where you punctured the vein or just fairway?
I think, Thomas, to be fair, he said it was at the puncture site when he presented it.
Puncture site, okay, perfect. Thank you very much. So as we cannot provide a further discussion in this way, we will go to the next. Professor Davies, please.
Okay. Thank you very much. It's a great pleasure to get Dr. Naguib from Egypt to tell us about endothelial injury with laser ablation.
I'm Suhail Naguib, vascular surgeon from Alexandria, Egypt. I'm very happy to be with you today, and I'd like to thank the Vicon 14's virtual conference for the great invitation and letting me be with you today presenting biochemical endothelial injury detection of saphenofemoral junction in endovenous laser ablation of varicose veins. First, the thrombus formation and extension to femoral or popliteal veins and pulmonary embolism may be thought as a complication of EVLA. In management of the varicose veins, we have to study the thermal energy effect of the procedure under standardization condition on biochemical markers on platelets, and endothelial activity could be of valuable in thrombosis reduction. Heat and thrombus formation. The degree of heat induced depend on direct contact or indirect contact. Direct contact with the vein lead to thorough destruction of the vein using high temperature photothermolytic process. Indirect contact when the blood is left within the vessel, and heat is lower because the absorption of the energy by deoxyhemoglobin binding of the blood and degeneration of steam bubbles, which indirectly affect the vein wall and cause endothelial damage and intraluminal thrombus formation. Biomarkers: first, the FDPs is a coagulation marker that released when activated factor 10 cleavage prothrombin, and D-dimer is the marker of fibrinolytic activity. In surgical patients, both increase. B-selectin is the adhesion molecule, facilitates adhesion platelets and neutrophils to the endothelium and cause platelet aggregation and further thrombus formation. Thrombomodulin is an endothelial factor that's rapidly released into the blood upon endothelial activation. The aim of our study to investigate whether an immediate rise of biochemical markers can be observed when laser ablation of grade 7S vein is performed under a standardized treatment condition, leaving the proximal 2 centimeters away from the common femoral junction. We had 25 patients admitted to vascular surgery department, Alexandria Armed Forces Hospital, with varicose veins and grade 7S vein reflux, all treated by endovenous ablation from January 1st, 18 to December 30th, 18. We took blood samples from iliofemoral and antecubital veins before, during, and 1 day after procedure. B-selectin, thrombomodulin, FDPs, and D-dimer were tested. Our results with demography: age range from 16 to 56 years, and male to female ratio 2:1. We have predominance left side affected, with grade 7S vein reflux in all patients and small 7S vein in 4 patients, vein diameter from 4 to 12 millimeters, degree of reflux from 2nd to 4th, with duration 0.5 to 0.7 seconds. Our results: we have no immediate rise in the B-selectin or thrombomodulin in neither iliofemoral nor antecubital veins. D-dimer and FDPs were significantly elevated postoperatively in the 2 regions, as you see in the figure. We had no significant VTE events immediately or during the follow-up period in all patients. To conclude, Mr. Chairman, dear professors and colleagues, 1480 pulsed mode diode laser doesn't induce measurable endothelial and platelet activation in the iliofemoral region during the endovenous ablation of varicose veins, yet D-dimer and the FDPs could be of value in cases of VTP prediction in EVLA. Thank you, and looking forward to be with you next year.
Thank you very much. Do you use any thromboprophylaxis patients, and if yes, what are the indications in your series? Can you switch on your microphone?
Yes. Can you hear me now?
What are the indications for thromboprophylaxis, and if you use thromboprophylaxis to avoid the thrombotic complication, especially EHIT? Do you see any particular situation when you use prophylaxis to avoid EHIT?
Actually, we didn't give in our protocol any prophylactic anticoagulant, as we use the standard techniques for having 2 centimeters away from the common femoral vein. So we didn't use this.
Okay, do you have any comparison of these results with any other procedures on the veins which are not conducted near to the saphenofemoral junction, like mini phlebectomy surgery or whatever? Did you try to check this in any other clinical scenario, these markers?
You have a point, sir. We are running now another study comparing the standard technique to the crossectomy technique to know if we will have the different results.
Okay, that's fine. Thank you. Thank you very much. We look forward to hearing about that later. Now let's move on to the next talk, which is going to come from Oman by Dr. Al-Makrakiwi, who's going to talk to us about brochures and the willingness of women to be offered treatment by male physicians.
Good evening, this is Ghayth Al-Mahrouqi. I'm a surgical resident at Oman Medical Specialty Board. I would like to thank the organizing committee for giving me the opportunity to present in this conference today. And I would like to take the opportunity to thank my mentor, Dr. Edwin Stephen, for his support and encouragement as well. So the title of my study is "Does a patient information brochure affect willingness of Omani women with varicose veins to be examined by a male surgeon?" It's a prospective randomized single-blind study. So I come from a place where women won't expose their body parts to a male surgeon, physician, or even a nurse. And this is because of our culture. So varicose veins are not uncommon among Omani women. And what inspired me to proceed with this study is the fact that we don't have a female vascular surgeon in Oman yet. And it has been noticed in our OPD that the majority of our female patients are reluctant to be examined by a male surgeon, have a duplex ultrasound done by them, and therefore a management plan cannot be made. And there are patients, female patients who would actually refuse a surgical management offered by a male surgeon. So this study is the first of its kind. It has never been conducted in Oman before. The objective of this study is to assess the effect of an information brochure on patients' attitude, acceptance, and willingness to be examined by a male vascular surgeon in the presence of a chaperone. Moving to the methods and the materials of my study. So we're planning to conduct the study over a period of 6 months. Our target sample size is 100. So we're planning to randomize these patients into 2 groups using odd and even medical record numbers. So the experimental group would receive an information booklet and the control group won't receive a booklet. The information that will be collected through a questionnaire, the age of the patient, because we want to compare and see whether younger generations would have a different attitude towards this issue or no. We'll also collect information about the marital status and the number of parity, and see and assess whether this would affect the willingness of these patients to be examined by a male surgeon. So in Oman, we have many tribes. So we also want to assess whether those patients who live in rural areas would have a different attitude toward this issue compared to those who live in the urban areas. We would also collect information about the occupation of the patient and the seat classification, and see whether that would affect the willingness of these patients to be examined as well. So then these patients will be reviewed a week later by a male vascular surgeon who would be blinded to this process, and he would assess the willingness of these patients to be examined by him as well. The brochure contains the definition of varicose veins, the different risk factors, symptoms of varicose veins, classification, the different diagnostic and treatment modalities of varicose veins as well. In conclusion, the aim of this study is to assess whether an information brochure would affect the patient's knowledge about their disease and their willingness to be examined by a male surgeon as well with a chaperone. So by this, I reached to the end of my presentation. I would like to thank you for listening, and I would like to invite you to visit our beautiful country, Oman, as well. Thank you so much.
Thank you very much for the presentation and these pictures. Of course, there are the problems from which many of us are quite away. I mean, regarding the willingness of the patients in many countries, it's not a problem. But I understand your situation, and having this situation, as you mentioned, do you have any data about the prevalence of the disease in your country? It's possible to check this in any way. Do you know something available? How often it happens? If there is in reality no way to check this objectively.
Thank you for your question, Doctor. Well, there is no study that has been conducted and that actually revealed the prevalence of varicose veins among females. However, we tend to see like almost 100 to 200 patients in the OPD per year. So it's a good point, and we are actually planning to study and find out the prevalence of varicose veins among Omani women. It's a good point to be added to our study as well.
Okay, thank you very much. And we look forward in the future to you being maybe appointed to a consultant post in Oman so that you can deliver the service that maybe the ladies would like. So it's my great pleasure to introduce the last talk of the session, which is the use of bleomycin, and this is going to be done by Dr. Salim Ahmed from Lahore in Pakistan.
I am Salim Ahmed, and I am interventional neuroradiologist in LGH Hospital, Lahore, Pakistan. The topic of my talk is off-label use of bleomycin, a study of intrarenal and the intraarterial applications. Intrarenal bleomycin has been used off-label to treat the various conditions. These include hemangiomas, vascular malformations, telangiectasia, several types of nerve sheath tumors, extracranial malignancies, and the high-flow lesions like head and neck AVMs. Currently, there is a limited amount of evidence from randomized controlled trials comparing intrarenal bleomycin with other local treatments. In this study, we demonstrate the clinical applications of intrarenal and the intraarterial bleomycin, dosages, techniques for administration, and efficacy for each condition were also provided. It was a prospective study of 500 patients. So my results were complete resolution occurred in 85% of hemangiomas, 90% of the low flow malformation, including the orbital periorbital lesions, and 90% of neurofibromas. In all extracranial AVM cases and tumors, bleomycin was used as an adjunct therapy, and they showed a reduction in the size and power of bleeding. Of the 3 patients who presented with bleeding within orbital lymphatic malformations experienced complete resolution. Pain and swelling were encountered in all cases. In 1 patient of the orbital venous malformation, post-sclerotherapy patient developed blindness in the eye. So given its ease and safety in administration, efficacy and availability, off-label use of bleomycin and bleomycin foam can be considered another primary or adjunctive therapy in both peripheral and the central conditions by the intervention neuroradiologist today. So how we select the patient? All patients were initially examined in the multimodality meeting in the presence of experts, and the symptoms were identified. The patient underwent the CT, MR, Doppler. DSA was performed in all cases when there was a suspicion of high flow lesion, and the joint intervention strategy was planned. If the lesion was multilobulated or large in size, multiple punctures were needed, and almost 15 mg of bleomycin and foam with a 20% albumin were given. Post-operatively, patients were followed subsequently for 3 years. Primary tool for measuring the success was the palliation of symptoms and cosmetic improvement of disfigurement. So the details of my patient, there were 175 males and 325 females. Venous malformations were seen in 326 patients, lymphatic and malformation 45. Mixed lesions were 35, neurofibromas 15, and hemangiomas 55. Head and neck AVMs were 7 and tumors were 17. The results and the treatment outcomes already discussed. So my first case was a young boy of 18 years of age who presented with a pulsatile swelling over the neck and gruesome swelling of the lip and the ear, and he had previous 2 failed surgeries. So I decided to do the angiography first, which does not reveal any high flow lesion. And when I did the percutaneous puncture, it was a high flow kind of the venous malformation directly draining into the superior vena cava. So I decided to decrease the flow by giving the percutaneous glue injection in the first session. And after that, subsequently, I give the sclerotherapy injection after 4 to 6 intervals, and then there is a decrease of the lesion. My next case was tongue hemangioma, and again, she was a young girl who presented in the ER with the bleeding episodes, and she was continuously bleeding. Her hemoglobin was dropped up to 3 grams, and she had previous 4 failed surgeries. So I decided to do the angiography, and after that, I give, in the same setting, I gave the percutaneous sclerotherapy injection with the bleomycin, and the 15 mg of bleomycin was given the first session. After the 4th session, you can see that the tongue is absolutely right, and there is a decrease in the post-contrast enhancement on MRI. The next is a case of a young lad. He was presented with the proptosis, pain, and discomfort in the eye, and it was there since childhood, but now there is increase in the size of the proptosis on Valsalva. He was a medical student, so I decided to give the sclerotherapy injection. So I approached the lesion through the sclera, and after the 2 sessions, you can see that there is a 90% reduction in the size of the lesion. The next case is a unique case, and it was a large retropharyngeal space venous malformation encroaching the airway. So it was very dangerous to do this procedure. However, he was bleeding from the oral cavity, so I decided to give the percutaneous injection through the mouth. And you can see after the 3 years, there is no recurrence of the lesion. However, the main lesion was still there, so it was a palliative procedure. My next 2 cases are Klippel-Trenaunay syndrome and the blue rubber Breb-Nevis syndrome. And again, the sclerotherapy was used as a palliative measure to decrease the bleeding and pain in both cases. Orbital lymphatic malformation are notorious for the bleeding, and you can see that there is a large proptosis, conjunctivitis, and the swelling after the minor trauma. It was diagnosed on the MRI. There were multiple cysts, so I decided to aspirate the blood first, and it was aspirated by the negative aspiration, and the 10 cc was aspirated, and then 2 sessions of sclerotherapy with the bleomycin were done, and you can see that there is a decrease in the size of the lesion, both cosmetically as well as on imaging. And this was the case in which it was used intraarterially as an adjunct therapy. And the next is my last case, and he was 3 years boy who was diagnosed with NF1, presented with the right orbital neurofibroma and glaucoma at the same time. So the surgeon didn't want to operate him twice. For this neurofibroma, I decided to give the sclerotherapy, and you can see that there is a decrease in the proptosis as well as the swelling, both cosmetically as well as on the imaging after one session of the sclerotherapy with the bleomycin. So I end up my talk. These are my patients, and they bring the happiness to my life. Thank you so much.
Congratulations for these results and experience. I have the question: how you work? How do you work in your center? It's a multidisciplinary team, or you work as the single specialist in the field that is very particular because it differs between the countries, and usually, especially if we take into account the using off-label treatments, drug not registered for these particular indications. What's your policy of working? Do you work with the others, or are your single decisions?
Thank you very much for your question. I am dedicated interventionist, but because our hospital is a big hospital, it's a public hospital, and we have all kind of modalities there. So we on the weekly basis, we do have multimodality meeting. And in the multimodality meeting, all kind of experts from ophthalmology department, from the plastic surgery department, from general surgeons, they send their patients who have these kind of lesions. And then in their presence, we decide that how we are going to treat these patients after the confirmation of the lesions and after deciding the mode and also combined procedures. I usually do these ophthalmic eye procedures in the presence of eye surgeon, and a plastic surgery person is also there when I do their case. So this way I do it.
Thank you.
It's a multi-specialty thing.
Thanks.
Okay, thank you very much. And that was the last presentation of this session. I'd like to thank all the presenters and all the audience for listening, and I'll hand you over to Dr. Jindal.
Thank you to all the chairpersons, Professor Aaron, Maz, Venkat, and YP. It has been really wonderful session, and thank you for helping us out. And Dr. Sandeep, Dr. Raju, Dr. Venkat, really thank you. If you can just send us the results, we'll compile them. And now we move to the last session here. It's going to be on the NOACs, and I'd like to invite the chairpersons, Dr. N.S. Rahul, Dr. Gulshanjit Singh from India, Dr. Srinath Rathore, Dr. Hussain, Dr. S.A. Hussain from India, Dr. Surjal Shah, Dr. Vivekanand. Now we'll move to the first lecture by Dr. Ramakrishna Penjala. He is the past president of Venous Association of India. He's going to talk about simplification of DVT management. Tarun, are you here? Yeah.
Sir, we are, sir.
Good evening to you. Ladies and gentlemen, thank you for giving me this opportunity to talk to you about simplification of DVT management. Simplification of DVT management is the need of the hour in a country like India, where a large number of people are affected by deep vein thrombosis. The incidence of DVT is common in hospitalized medical patients and surgical patients. The incidence and prevalence depends on the various risk factors and the age of the population. Autopsy studies have shown that in many cases, antemortem diagnosis was missed, and in medical and surgical patients. In the initial trials, contrast venogram was the gold standard for DVT diagnosis. In the later trials, color Doppler scanning has become the gold standard for the diagnosis of deep vein thrombosis. A few studies have used the advanced imaging, such as CT scanning and MRI scanning, for detecting the VTE. In 2012, in ENDOR study, Indian data was presented by our group. In this study, The risk of developing VTE in patients across the world was similar. That was to the tune of 50% based upon the ACCP criteria. That means every alternate patient in the acute hospital bed is at risk of developing VTE. But it was observed that the thromboprophylaxis was given in only 16% of the surgical patients in India, whereas it was much higher in Western countries. Risk assessment models were therefore introduced to identify the people at risk of developing venous thromboembolism. DVT can be symptomatic or asymptomatic, but both can lead to pulmonary embolism. They need to be treated with utmost care. DVT needs to be treated effectively. What does it mean? It should prevent recurrent DVT, fatal, non-fatal pulmonary embolism, without any risk of bleeding. At the same time, treatment regime must be simple to follow. That means keep it simple and safe is the logo. There should be no long-term side effects such as post-thrombotic syndrome, chronic pulmonary arterial hypertension, and so on and so forth. If we were continuing the anticoagulation, there should not be any type of bleeding complications. Overall bleeds, fatal bleeds, major bleeds, clinically relevant non-major bleeds should be less. And at the same time, the management of the bleeding should be simple and correctable. When the effectiveness of safety and are established, we think about home-based therapies over the hospital-based therapies. Patients can be treated with the comfort of the home. That is the whole essence of management of deep vein thrombosis in a large country like ours. The incidence of complications determines the need for more complex hospital-based therapies such as thrombolytics, endovascular therapies, and stenting. In general, we give injections of different types of heparin for a few days, followed by oral anticoagulation agents. We are also training our patients to take self-injections at home in this process. Treatments become simple if there is no need to monitor the effects of the drugs with blood tests and adjust the dosage of the tablet. There should not be drug-drug interaction. There should not be drug-diet interactions, and the conventional oral anticoagulants fail in this arena. If the patient must take medicines for months to years in this group, it becomes a concern for the patient and their families. Pharmacogenomics are helpful in some patients requiring unusual doses for the safe anticoagulation which is to be effective. When we ask the patients their choice of treatment, oral tablets is preferred by majority, but when there is no better other choice, they accepted the complex therapies such as thrombolytics, angioplasty, stenting, and so on and so forth. So, ladies and gentlemen, I simplified the information from all these trials: ENDORS, MEDINOX, PREVENT, Artemis, clots, SELECT-D trial, Einstein studies, Amplify, Stroke study, and then placing the information before you and the preferred choice of the patient. And my slogan is to start with the tablet, stay with the tablet for a long period. Pop a pill, stay at home is the simplest treatment one can expect for DVT. We hope that it is possible for the majority of the patients. The next simplification is weekly once tablet for DVT. Let's hope that is not too far. Thank you.
Any questions from Dr. Pinjala, please? We can have one question for each talk, please. If we don't have any questions,
it is so simple. There is no need for questions.
So you have made it so simple. So Tarun, can we go to the next talk by Dr. Sanjay Desai? It's a very important topic because there's an ongoing research. It's the NOACs in children. You know, there are last 1 year there have been few publications on this, so I think it will be interesting to know about this.
Good evening, and Thank you, Vaikon, for inviting me to give this talk on NOACs in children. It's wonderful to be here. Probably the first major meeting for the 2021, and always happy to be associated with Vaikon. And every year we used to look forward to meeting all of you. Well, some years are different, and so is this year. So here we are live, and we do interact, and hope to continue the stream of knowledge and exchange ideas amongst us. So coming to my topic on NOACs in children, I think obviously not much is known about this, and we hear quite a bit of NOAC work which is happening, but we really don't know. In fact, I had to look at a bit of literature to see what really is happening. Well, first and foremost thing I think we should remember is that DVT, thromboembolism, VTE is becoming more and more prevalent in the pediatric population. Of course, it's not in terms of the percentage what we see in the adults, but definitely we are seeing quite a big number of VTE amongst the pediatric population. This also may have to do with the awareness and with our pediatric colleagues picking up VTE and DVT, and also has to do with a lot of hospital-acquired interventions, a lot of pediatric interventions, a lot of neonatal work which is being done. So definitely VTE is being seen more often among the pediatrics, and we have to look at managing this. And I think most of us are called in for managing these patients, and we still lack a lot of clarity in how we do. Presently we are extrapolating the adult data and using it in the children. Even with our pediatric colleagues, we have had a lot of discussions, and still we are not really clear or proper guidelines in picture. The differences which exist, I think, is especially in the pediatric patients, the hemostatic cascade, is dynamic and it's still evolving. So it's not really clear how they are going to respond. And children less than a year don't have the completed their coagulation profile, and they still have much to develop. The pharmacokinetics obviously differ. The half-life, the creatinine clearance, etc., is also age dependent, and the severity of the illness does make an impact amongst these patients. So anticoagulation choice is affected also by the diet, the age, and amongst the pediatrics we have the neonates, the young adolescents, etc. So there is still a difference between a neonate and an adolescent where probably can switch over to an adult. Now, what we have a problem with the existing anticoagulation in children is, you see, either we are using heparin or low molecular heparin, or we are using humidins. Now, both of them have to have an injection. In the sense, if you're giving heparin, obviously it has to be either subcutaneous or intravascular, etc. Now, if you're even giving warfarin or anything, you still have to monitor INR. Again, it involves an injection to draw blood. So among the pediatric patients, not very comfortable. So I think with the advent and with a lot of works happening in DOACs, hopefully it will stand out as a good alternative, or probably the ideal alternative, or probably the ideal therapy in managing the pediatric patients. Just broadly, just to give an overview, we all know that DOACs, we have two classes. One is the factor 10A inhibitors, and the other one is the direct thrombin inhibitor. Now, indications in neonates, like I said, as we are seeing more and more interventions, more awareness, the indications are changing. We see a lot of central venous catheters, umbilical vein catheters, access, etc. So that is leading into DVT in these catheterized veins. Of course, renal vein thrombosis, inferior vena cava thrombosis, and thromboprophylaxis in congenital cardiac surgery, etc. Now with surgery happening at a much younger age, especially in the neonates, we still have to consider prophylaxis. So that's one of the indications, especially in the neonates. Of course, as the child grows up, any routine cardiac surgery will require anticoagulation. Any aneurysmal surgery will require, and of course, to our topic of interest, risk of VTE, cancer-associated risk of VTE, treatment of VTE itself will be an indication for anticoagulation. Currently, dalteparin is amongst the DOACs which has, I think, finished a couple of trials in children, and probably is on a conditional approval for use. Right now, unfractionated heparin, low molecular heparin, warfarin, etc., is what is being used in the pediatric patients. What I think probably most of us are using. Of course, if you cannot use heparin, there are alternatives with bivalirudin and agratoban and fondaparinux. But this is probably the standard which most of us are following. Now, if you just look through what is currently approved by FDA for antithrombotics, if you look at the pediatric status, you see, except unfractionated heparin, we really don't have an approved antithrombotic drug, because most of them, even the low molecular heparin, the fumarins, etc., are still, as mentioned, as routine off-label use, though some of them have done trials and have been relatively said to be safe. So we really don't have an approved other than unfractionated heparin. And among the DOACs, almost all of them are still under investigation. So there are, I think, dabigatran, the direct thrombinamide, has finished a couple of trials and has gone through FDA fast track. Other than that, most of them, as I go through my talk, are still in the completion stage or is probably still in the enrollment stage. So state of the DOACs for pediatrics in the current era. Several trials are going on. The guidelines are still not clear. Clinicians, as of now, we have to decide the benefits versus risk, whether it is DOACs or even if it is unconventional treatment, etc. We still have to look at it. Now, the advantages of DOACs, like I said, is once it comes into the picture, oral route of administrations, including liquid suspension, which is very ideal in children, rapid onset of action, very few drug interactions, predictable pharmacokinetics, and of course, no need for monitoring. I think that's going to be the biggest advantage. I'll just run through some of the DOACs which are currently in the pipeline. Rivaroxaban, as you know, is among the initial FDA-approved DOAC, which was available, both indicated in cardiac and VTE. It's a factor 10A inhibitor. Amongst the trials in pediatric, we have the Einstein Junior, which has 2 phase 2 and 1 phase 3 trials, which is undergoing. And again, these are evaluating from children from as 6 months to up to 18 years. And patients even between 12 and 18 years are much more better compliant and easier to handle. Now, this trial is ongoing, and we have 2 trials, like I said, which is estimated to finish in 2021. And we have apixaban. Apixaban has got much lesser numbers, but this is also a drug which is being evaluated in the pediatric population. We have quite a few of these studies, again expected to complete in 2021. A couple of them are just started, and probably will need another 2-3 years before we see how this drug is going to work out. Edoxaban, yes, this is a drug which, in fact, we at Ramay are part of this trial, and we have enrolled patients in this trial. And I really find it, as we were going through this trial, it's why DOACs is taking so much time in pediatric population is because obviously there's a lot of ethical consideration. There is a lot of apprehension, putting a child, getting a consent, talking to them about a trial drug and trying to get an approval is much difficult than speaking to an adult, and we are all very concerned. So when it comes to a child, we don't really get that consent or speed track, because the moment we said a trial drug, obviously they're more apprehensive. A lot of children don't enroll. We also have had pediatric monitoring. We have an ethical review board which is monitors it very closely. So I personally know how difficult it is to enroll patients, especially in the pediatric age group. This particular trial, we have been working closely. We have gone through various age groups in which we have used the drug. Again, this is a comparative along with standard of care. I think we have almost got all the cohorts except cohorts between 6 months and 2 years. I think we are still about 10 or 12 patients short globally, and once that is done, this trial should be completed, and probably will know the results. So maybe we expect third quarter of this year to have some results with edoxaban. Dabigatran, like I said, is probably one of the drugs which we tracked, and it's got a conditional approval as of now because they have completed trials. Some of the trials have finished, and the initial reports have given a good safety profile, and it is definitely shown to be non-inferior. And I think this is something which we can look forward amongst the DOACs to be there. Now, coming to the biggest problem with any anticoagulation is the reversal. And DOACs reversal, we all know there are reversibles with iduruzumab and andexanet alpha. Though they are good, they are specific in terms of their action. Unfortunately, both of them are not still effective or not been approved in use in children. So I think this is another factor which will make decision making quite difficult when it comes to considering DOACs in even for that matter general anticoagulation. So in conclusion, yes, in a child, it's very important that we give a drug which is more compliant for the child, more easy. So a simple suspension to a simple capsule, simple tablet makes it much more easier, and no monitoring makes an added benefit. Obviously, any kinds of injection in a pediatric population is not a good choice, and we have to try and see as much as possible to get a good oral drug which does not require monitoring. It should not have dietary interactions. It should be easy to take, probably once a day dose makes it more compliant. So as of now, I think we are still to see much light in the end of the tunnel, but it is there, and lots of work is being done, and hopefully we will see some of the results of these trials by the mid of this year, and we should have a good idea of how we can go forward. So thank you very much, and wishing everyone a great meeting and happy times. Thank you.
Thank you, Sanjay. Any questions, please? We can take one question, please. Thank you, Sanjay. If we don't have any questions, we go to the
Thank you.
By Dr.
Thank you, Rahul.
Thank you. He's the head of the department of Medanta Hospital, New Delhi. He's going to speak on a very important topic, and anticoagulation strategies in patients with VT and latest evidence in CAT. CAT is cancer-associated thrombosis.
Hello, good evening, friends. My topic today is anticoagulation strategy in patients with venous thromboembolism and latest evidences in cancer-associated thrombosis. I must thank Dr. Rahul Jindal and Dr. Bedi for organizing this symposium in a very difficult time, but congratulations and all the best for them. I'm going to actually discuss my presentation with two reference cases, one with cancer and one without. The first one is a 42-year-old male who came to the clinic with acute right swelling, which was essentially without any shortness of breath and had no significant past history, either personal or family. He had a D-dimer which was positive, and the Doppler was confirming the right iliofemoral depopulated deep vein thrombosis. His pulmonary artery angiogram CTPA was negative. He was put on 10 milligrams of apixaban twice a day for 7 days, followed by 5 milligrams of it for 6 months. And at 3 months follow-up, he had a D-dimer which was normal, and he had very well recanalized flows on Doppler. So the question here was that why was apixaban chosen over the standard of care, which is the vitamin K antagonist for acute deep vein thrombosis? We have sufficient data today to back this decision that we took, that the Amplify trial shows that the recurrence of VT and VT-related death, the apixaban demonstrated non-inferiority to enoxaparin and warfarin in a very large cohort of cases, and it significantly reduced major bleeding by up to 69% as compared to enoxaparin and warfarin. And this is basically the basis for our discussion today. Another discussion point is, why is long-term or extended treatment required in the risk of complications, including fatal pulmonary embolism? Long-term and extended prophylaxis treatment is aimed at prevention of recurrence of venous thromboembolism, and indefinite treatment, especially in such cases like the one which we are talking about, reduces the risk of recurrence by up to 90%. And this has been substantially backdated, backed by data which has been published in 2015 in the World Journal of Hematology. Now, why was apixaban chosen? Is it better option over rivaroxaban, which is used once a day? This also has sufficient data to back our decision. The safety and efficacy of NOACs in patients with venous thromboembolism. Rivaroxaban, the apixaban shows that there is a 63% reduction in the relative risk for recurrence of VTE and a 46% reduction in the relative risk of major bleeding. And this is essentially the reason why apixaban was chosen over rivaroxaban. The second case that we will be talking about is the one with cancer, the 72-year-old lady who had a colonic cancer, who underwent a colectomy and hepatectomy for metastases, and developed acute right recurrent femoral vein thrombosis 1 week after starting chemotherapy. She denied any personal or family history of the same. So how should this lady be treated? It should be a factor 10A inhibitor, a low molecular weight heparin, or warfarin. And here again, we have a lot of data to back our decision that dolteparin versus VKA in cancer patients with VTE. This was a study which is called the clots study, which established the role of dolteparin in patients with cancer-related VTE, and this was and carried on as the treatment option. But low molecular weight heparin associated risk of recurrence was still significant, up to 10%. No reduction in major bleeding occurred whether we used low molecular weight heparin or alone, or with along with vitamin K antagonist, and subcutaneous injections, as you know, are uncomfortable. So a SELECT-D, a pilot trial, was tried in which rivaroxaban was treated was tested against low molecular weight heparin, and this showed that most of the major bleeding effects for GI bleeds, and patients with esophageal and GI cancer bled much more with rivaroxaban than with dolteparin. So dolteparin was the drug of choice for such patients, and that was what continued till the next study, which was the Caravaggio. This is the study which actually changed the entire thinking and the thought process about NOACs in cancer-associated thrombosis. And the combination of both high risk of recurrence as well as bleeding in cancer patients, and which obviously required additional studies in efficacy and safety of anticoagulant treatment. And this was tested in this new Caravaggio trial, in which cancer patients with newly confirmed VTE, 1,170 patients were tested with apixaban as compared to the dolteparin, which was the standard of care till then. And tested against for primary outcome of recurrence VTE and principal safety outcome of major bleeding. And these patients, most of these patients had PE with or without DVT, and about almost 52%, and about 47% of them had DVT alone. Active cancer in practically 97% cases in both apixaban and dolteparin groups. Most of the cancers were either colorectal or upper GI, and this was basically because these are the patients who used to bleed a lot on initiation of anticoagulation therapy. So Caravaggio actually changed the entire thinking process. Oral apixaban was non-inferior to subcutaneous dolteparin for the treatment of recurrence of venous thromboembolism in patients with cancer, and the frequencies of major bleeding was similar with apixaban and dolteparin, including major GI bleeding. So this established the role of apixaban in cancer-associated thrombosis, because the risk of bleeding was reduced, and the recurrence of venous thromboembolism was established anyway as compared to dolteparin. So this has been and will be the standard of care currently. So to sum up, around 2/3 of patients with symptomatic VT manifest with DVT alone, and cancer-associated thrombosis, no increase in GI bleeding was seen with apixaban, and as compared to warfarin therapy, as apixaban was associated with less risk of recurrence as well as bleeding, and is found to be more effective than rivaroxaban in preventing the development of recurrence and major bleeding events. So thank you very much for the patient hearing, and I think Caravaggio has actually has revolutionized our thinking, and I think will be probably the drug of choice for cancer-associated thrombosis, because it does actually reduce the risk of recurrence as well as give us a reduction in the risk of bleeding, which is so comforting to a clinician. So thank you very much for this patient hearing, and thank you organizers for organizing this meeting. Thank you.
Thank you, Dr. Rajiv Parekh, for a wonderful talk. I think he could not join. I can't see him here on the panel. Dr. Rajiv Parekh, are you here? No. Okay, then we will move to the next talk by Dr. Praveen Jindal. He's going to speak on demystifying the role of medical management in chronic venous disease.
Good evening, everyone. This is Dr. Praveen Jindal, the vascular and endovascular specialist from the city of Dehradun. I'll be talking about demystifying the role of medical management in chronic venous disease. We all know that varicosity is basically the penalty for verticality against gravity. Now, these varicose veins are caused by underlying chronic venous insufficiency with ensuing venous hypertension, which leads to a broad spectrum of clinical problems. And the successful long-term results in the treatment of these primary varicose veins of truncal origin depend on the elimination of the highest point of reflux and elimination of the incompetent venous segment. Imagine a patient living with this. Nobody would like to. So what are the etiology, that means causes of this varicose veins? It increases as the age increases. The risk of varicose vein increases because the veins become less elastic and the valves become weak. Ladies are more prone for this due to their hormonal changes. There could be family history. Obese people are more prone. And the most important among all the factors is people who are standing or sitting still for long periods of time without any physical activity. So chronic venous disease, what are the symptoms that we are looking for? It is a wide spectrum of symptoms that one can think of, and at times it is very difficult to express for a patient. They may say it's a tingling or an aching sensation or a heaviness or a tiredness, and at times restlessness, fatigue. So there is no specific symptoms that patient can, pinpoint it to that this is the particular symptom that always happens. And what are the signs as a clinician that we are looking for? Though the symptoms point to the CVD, but at times there may be no visible signs, or we could see some spider veins or actual varicose veins with or without edema, and may or may not be skin changes in the form of pigmentation or eczema. And at rare cases in a long-standing patients who have the CVD, we might be able to see a small active venous ulcer or a healed venous ulcer. So chronic inflammation is the key component of this CVD. The current understanding is basically there's a venous inflammation which leads to the damage of the venous wall as well as the venous valves, which leads to the symptoms. And early treatment is essential to prevent progression of this disease. And the venous pain is basically related to nociception, because there is inflammation in the capillary and the vein wall, which leads to the activation of these receptors, and there is pain which is very difficult to express. Edema in these patients is characterized by usually being there in the lower legs, around the ankle or in the feet. At times it is pitting also, and the Earliest manifestation some patients say is that they have tightness of the shoes. And this is typically relieved by leg elevation, and the next day morning, patient doesn't feel there is any swelling or any edema. And ultimately, this CVD may lead to leg ulcers. And the characteristic of these leg ulcers is usually they're on the medial side of the ankle or the foot or the lower leg, may or may not be painful, but with a pale granulation tissue, may be surrounded by eczema and the hyperpigmentation. We may be able to see some varicose veins also. So what are the management options for these CVD patients? It ranges from medical therapy, including and not limited to compression therapy with surgical intervention in the form of endovenous or open surgical techniques. There are various techniques we are all aware of, from chemical ablation using foam sclerotherapy and thermal ablation using either laser or radio frequency. And in the surgical therapy, we have those venous strippings, open surgical ligations, and phlebectomies. The treatment recommendations for edema is usually when the patient comes to us, we basically look for any superficial venous reflux, or we look for any varicose vein. If there is some varicose veins or there is a superficial venous reflux, the first choice is always surgical intervention. And if the patient refuses, or there are other reasons for not to undergo surgery, the alternative is usually the most recommended is MPFF with or without compression therapy. Similarly, in the active ulcer, we might have to at times admit these patients, give them a good bed rest with the antibiotic coverage and a proper ulcer management in the standard format. And again, if you are looking for varicose vein or superficial venous reflux, and if present, the first priority is again surgical therapy. But if not recommended, if not present, what is the alternative? Alternative is again MPFF with or without compression, with obviously local care of ulcer. That's a standard practice. The compression bandages are equally useful, more useful, and they help in reducing the ambulatory venous hypertension and improve the microcirculation. Now, they are made of either elastic material, depending on self-applications or physician application, or they could be inelastic, depending on the severity of the chronic venous disease that we are dealing with. What is the goal of the surgical management? The goal of surgical treatment is basically to improve the patient's symptoms from leg pain, swelling, and discomfort, and improve their basic quality of life. And to achieve this, plenty of interventions do exist for treating these superficial venous disease, as well as the deep venous system. But every surgical procedure or minimally invasive procedure have their own limitations or complications. We all know from sclerotherapy, we might get hyperpigmentation or pain or ulcer formation. And with the radio frequency or with endovenous laser ablation, we do get burns, we do get nerve injuries, hematomas, and bruising. And can MPFF as an adjuvant to these therapy help improve the management of chronic venous disease? Let's see. The evidences and recommendations in the management of medical management of chronic venous disease are like this. International Angiology, the latest guidelines published in 2018, they have compared the various things from the capillary leakage to the venous stone to the valve damage and lymphatic drainage with various components, including MPFF, including calcium dobicelate, viscous, coumarins, and anthocyanidins. MPFF has been found to be useful in all the levels of from lymphatic drainage to capillary leakage to the venous stone and improving the venous wall and the valve tone. And what is the magnitude of the effect of each of these drugs on the individual symptoms? Again, among all these 9 parameters, from pain to heaviness to redness to skin changes and edema, and most important, quality of life, MPFF is strongly recommended by the researchers because it reduces complications. MPFF acts at all the levels, from leukocyte endothelium interaction to the release of inflammatory mediators, and the activation of the inflammation and acting on the nociceptors. So giving these MPFF in conjunction, in adjuvation to the surgical procedure usually improves the quality of life and the healing process. Even in the ulcer healing, there's a strong recommendation by the researchers that MPFF should be recommended, and it hastens, it promotes the ulcer healing. So less time is required for the ulcer to heal. So MPFF has been considered an essential treatment for the management of venous ulcer. From this graph, we can see in 723 patients, the mean median time has been reduced to almost 35 days from the control group in these patients. Like I told you, it halts the vicious cycle of venous inflammation and acting at every possible level, preventing venous hypertension by blocking the release of inflammatory mediators. And it has also been endorsed by the American College of Phlebology and Union of Phlebology, and it is proven that it protects the microcirculation from the damage induced by venous ambulatory hypertension, along in adjunction to compression therapy and the local wound care. So these are the various textbook recommendations on MPFF one can go through, and this is the Indian consensus on chronic venous disease, which has been published by very august people who are already there in the audience today. I'm sure they would love to highlight the recommendations of this consensus statement. Thank you very much.
Thank you, Dr. Parveen. And I think he's unable to join us today. So now we go to the next topic, Dr. H.S. Bedi's need for reversal agents while using NOACs in DVT.
Yes, Tarun, we can start. Thank you. Dear friends, it's a pleasure to be here with you today, and I'll be talking to you about reversal agent for direct oral anticoagulants. So I have no disclosures. I bring you greetings from my institute, my co-faculty, and my state of Punjab. Now, we started with oral anticoagulants, the vitamin K antagonist, went on to the direct acting oral anticoagulants, earlier called the newer oral anticoagulants, and now we have the reversal agents for these anticoagulants. Now, this is important because a lot of patients who need these oral anticoagulants are not given them because one is fearful of what to do if the patient starts bleeding. So now we have the answer. When do you want to reverse? Basically in two situations, in a patient who needs an emergency surgery or a patient who's getting massive bleeding which is not getting controlled. So these are two situations in a patient on a direct anticoagulant. So we have one reversal agent, that is idarucizumab, or Praxbind is the trade name, and it was developed specifically for dabigatran. The FAB region of the molecule binds to dabigatran very strongly, in fact more than 350 times that of binding of dabigatran to thrombin, and this is irreversible, and so reverses the effect of dabigatran. So this was a study called Reverse AD, study of reversal effects of idarucizumab in patients on dabigatran. 503 patients in 39 countries and 173 sites, published in 2017. Two groups of patients, group A with uncontrolled bleeding, group B with needing emergency surgery, both on dabigatran. Primary endpoint was the reversal measured by DTT and APTT, and secondary point was the hemostasis as seen during surgery, mortality, and APTT levels, and restart of anticoagulation. So there are two patients. Group A, which means bleeding, was 301, that is 60%, and the rest were those needing surgery. So the type of bleeding was mostly intracranial or gastrointestinal, and the type of surgery needed in group B was either a laparotomy or orthopedic bone fracture or a cardiovascular. So this is what we found. In group A, the DTT level fell immediately, the direct thrombin level. And similarly in group B, once you gave the Prexbine or idarosizumab, the DTT level fell very rapidly. Similarly, the dabigatran level fell, which meant that the dabigatran was all taken up by the Prexbine, and the APTT level, that is the effect of dabigatran, also went away. So these patients who had bleeding, within 2.5 hours, the bleeding stopped, and the patients who needed surgery, within 1.6 hours, they were operated upon, and majority of them had a normal hemostasis as seen in surgery. So these were the key results. 5 grams of idarosizumab was given, resulted in immediate, complete and sustained reversal of anticoagulation. Median time to cessation of bleeding was 2.5 hours. Median time to surgery in group B was 1.6 hours with normal hemostasis. Now, there were some patients who were part of this trial from India, and we'll just tell you a few of them. This patient from Delhi, 80-year-old lady, was on dabigatran for AF, had a fracture neck femur, needed urgent surgery. Dabigatran, of course, was stopped. APTT was high, was given 2 doses of Prexbine and taken for surgery, and very little bleeding. Normal hemostasis was found. APTT level was monitored, fell down. Calcutta, 61-year-old man, had massive lower GI bleed, was given the antidote, and the bleeding stopped very rapidly. Another patient had a fall and an intracranial hemorrhage. Surgery was planned, and meanwhile the antidote was given, and the patient improved, and surgery was deferred, and the patient did well. So there are other reversal agents for the other oral anticoagulants, and we have for rivaroxaban, we have andexanet alpha. However, this has some drawbacks. It targets other parts of the coagulation system, also targets heparin. It is not widely available and needs a continuous IV infusion as compared to Prexbine, which is a fixed dose, and it is available as a preloaded syringe. So what can you do for these patients who are on rivaroxaban? There are a few things you can do. One is, which I did, this patient needed emergency bypass surgery for a left main stenosis with unstable angina. And so we used a device called cytosorb during the cardiopulmonary bypass. This basically physically absorbs all the rivaroxaban, and the patient did well. And another thing you can do is therapeutic plasma exchange. So to summarize, I've told you about the available antidotes for the direct oral anticoagulants, and there is a lot of research happening for the better antidotes and for antidotes to drugs which are not available now. Thank you very much. If there are any questions, I'll be very happy to answer.
Any questions, please? Okay, if we don't have any other questions, we are running 40 minutes late, so I'm pushing it a little bit. The next talk is by Dr. Shekhar, role of RAPS in compression therapy.
Good evening, friends. I'll be talking on the role of RAPS in compression therapy. When we talk about RAPS, we mentioned RAPS, we always think of something to eat. So what exactly are adjustable RAPS, these compression RAPS with Velcro fasteners? What exactly are they? Well, they are one of the most remarkable innovations in the field of compression therapy in recent years. These are actually garments made of short stretch fabrics, which wrap around the leg and adapt to the shape of the leg, and are adjusted according to the desired pressure and are fixed with Velcro type closures. Since the fabric is a short stretch, when placed on the leg, this behaves with a high rigidity index so that it presents resistance to changes in the volume in the calf and achieves more effective pressure peaks during the muscle contraction than compression stocking, whose fabrics is basically elastic. Moreover, considering that they exert low pressure at rest, they are usually better tolerated than the elastic fibers, besides being a system of easy application removal by the patient himself or herself. It also allows readjustment of the pressure exerted throughout the day by repositioning the Velcro type closures. This possibility of adjusting the pressure adapted to the changing volume of the leg avoids the main limitation of the short stretch bandages, which we all are aware, which is the rapid fall of the bandage or the loosening of the bandage associated with edema reduction. Different designs have been marketed with variability in the degree of tissue stretching and the type of placement, depending on the model, the system of selecting, and the controlling the pressure. We wish to achieve certain changes. So when would one prescribe wraps over bandages or our conventional stockings? Patients who are most benefited from these systems are those who are unable to wear stockings, especially those who are obese or have age-related osteoarthritic problems, those with extreme or very irregular leg diameters that we commonly see, especially in women, those with limb disorders, skin disorders secondary to lymphedema and phlebolymphedema, in which they are very practical alternative to the typical flat neck stockings. So basically the benefits of adjustable compression wrap devices is easy application and removal, autonomy for the patient and family members, pressure that can be readjusted from time to time, adaptation to legs with morphological alterations, and hemodynamic effectiveness due to its high stiffness index. What I use in my practice is the Compraflex by Sigvaris. These are some of the pictures. You can see the Compraflex compression device. Most of them we use with the liners. There are various different types of liners and they have different features. The basic liner, the transitional liners, the complete liners, and the cotton liners. Each one of them has its typical characteristic. Along with it, the unique feature of this Compraflex wrap that we see here is something called the AccuTab. I've got a video at the end of my presentation which will tell you exactly what it is. And this is basically just a simple device that easily attaches to the Compraflex compression garment, and you can use the AccuTab, and with the help of that, you can actually adjust and readjust the level of compression that is desired, and can be done with the patient himself or herself. It's not that the AccuTab is just a gimmick. It has proven accuracy for resting pressures, and it has been tested using PicoPress, which is recognized and has been recognized for its high accuracy and reproducibility. The Compraflex also has extendable straps, so depending on the type of patient and depending on the variability of the edema, the patient might require a larger length of a strap to start with, and then might need to reduce it to a shorter strap. So that facility is also, that feature is also there in Compraflex. It also comes with an additional feature of a Compra boot, meaning that one might also, in addition to a Compraflex calf compression wrap, might also add on a Compra boot for compression of the foot as well, with its unique features, as you can see here. This is a case safe, an index case safe for a patient who has probably something like a lymphedema here, as you can see here. And in this, a full leg is wrapped with this, using this wrap extenders right up to the upper thigh, and it gives you an amazing wrap around the entire leg, and the quality of life is definitely improved by using this kind of a wrap in this lady. This is a brief video for about 2 minutes or so, telling you
Before
about
applying the AccuTabs, ensure that the garment is applied
exactly
according
the
to the
AccuTab is.
instructions for use. To apply the garment, your knee should be bent at 90 degrees and foot placed firmly on the ground. The strap should be rolled back and fixed to the sides of the garment. Gently close each strap. Do not apply tension. This means that you should not pull the straps any further than is required to fix them against the sides of the garment. Once closed, the straps will be flat with no gapping but not stretched. The straps are then set at no compression. The AccuTab devices will guide you in accurately setting the level of therapeutic compression. Attach one AccuTab precisely at the end of each strap. The AccuTab should extend straight out from the end of the strap, with no angling or gaps between the tab and the strap. Be sure that one AccuTab is placed at the end of each strap. The AccuTabs do not have to be applied in a specific order. Some of the AccuTab devices will look upside down. To ensure the AccuTab is on correctly, check that the 40 to 50 mmHg line is furthest from the end of the strap. Pull each strap to the prescribed dosage indicated by the lines on the AccuTab. The end of the strap should be placed directly on the compression line at the appropriate level. To provide the level of prescribed compression, each strap must be pulled to the same line. For example, if 30 to 40 mmHg is the prescribed level of compression, pull each strap to the 30 to 40 mmHg line. Do not vary the level of compression between straps. If an AccuTab must be placed near the back of the garment, it can be trimmed to locate the desired compression range by touch. To trim the AccuTab, cut the device precisely on the line indicating the desired compression range. Apply the trimmed AccuTab to the garment following the application steps. Once cut, the AccuTab cannot provide guidance on any compression levels above the trimmed portion.
Well, that is about the AccuTab. And finally, to conclude, what do studies say about these wraps? There are potential improvements in time to healing, reduction in costs, the number and duration of nursing consults, and the improvement in patients' quality of life. Though I might confess that there aren't very many studies, but whatever limited evidence is there, it does suggest that the results of these studies at least suggest that there is a clear benefit of using these in achieving adequate therapeutic compression adapted to the patient's need. Thank you.
Thank you. Thank you, Dr. Shekhar. Any questions on the wraps, please? So I think we can go to the last lecture by Dr. Ashkat from Kazakhstan. How I do it, treatment of leg venous ulcers. Thank you, Dr. Ashkat, for joining.
Good evening, everybody. Congratulations for this excellent event. Thank you.
Thank you, Ashkat.
Dear colleagues, first of all, I would like to express my gratitude to Dr. Rahul Jindal and Dr. Bedi for the invitation and the opportunity to share my own experience at this conference of the Venous Association of India. Thank you very much. My presentation is devoted to own experience of treatment of varicose veins, leg ulcers. We treated 66 patients with mean age 55 years old. We treated patients with 75 cases with axial reflux of grids of venous vein. Shots of venous veins was presented in 21%. Association of truncal vein reflux and perforator veins reflux were in 22.7% of cases. Mean size of ulcer before treatment was 14 square centimeters. Maximum ulcer size before treatment was 40 square centimeters. We used two-stage treatment of venous leg ulcers. First stage of treatment included two-component compression stockings and topical application of actinidium hydrochloride. Second stage of treatment included endovenous thermal ablation, mini phlebectomy or sclerotherapy of tributaries, and ultrasound-guided sclerotherapy of perforated veins. Two-component compression stockings, including first component with 18 millimeters of mercury for day-night using, and 23 millimeters of mercury. We used second component of compression stockings for daily using. With total pressure of two component, 41 millimeters of mercury, up to 12 weeks. Wound management we performed with topical application of wound hydrogel containing actinidium hydrochloride during up to 8 weeks. Actinidium hydrochloride is antiseptic with antimicrobial action against a wide range of pathogens, including resistant nosocomial infections. This randomized control trial shows efficacy and cost effectiveness of actinidium wound gel in the treatment of chronic venous leg ulcers in comparison of modern wound dressings. Early wound healing was merely observed under actinidium wound gel treatment, whereby all treatment costs were generated by actinidium wound gel alone. This randomized control trial shows a comparison of an antibacterial sandwich dressing versus dressing containing silver. Microbiological eradication was observed on the 28th day of the study among 33 patients in the treatment group versus 6% of patients in control group. On the 56th day of the treatment, this percentage equaled 72% and 35% respectively. The rate of healing was faster in the group of actinidium than in the group with silver dressings. The reduction of pain level was higher in the actinidium group, in contrast with the control group. The presented results indicate that the efficacy of dressings containing actinidium is high compared to silver dressings. We used follow-up after start of therapy 1 time per week of first 2 weeks and then 1 time per 2 weeks. The goals of first stage of treatment are wound cleaning and reaching of epithelialization or complete healing. The goals of stage 2 of the treatment are complete healing of the ulcer and prevention of ulcer recurrence. We used endovenous thermal ablation as a second stage of treatment. Complete healing of ulcers in all patients within up to 12 weeks. The average time of beginning of epithelialization was 31.5 days. The average complete ulcer healing time was 52.4 days. Thermal ablation we used in treatment of 24 patients. Thermal ablation after reaching of the epithelialization was performed in treatment of 15 patients, 9 patients treated with thermal ablation after complete healing. The average complete ulcer healing time after thermal ablation was 27.8 days. This is just one case for demonstrating effectiveness of compression stockings with actinidium hydrochloride combined using. This slide shows results after 3 weeks of wound preparation and compression, 2-component compression stocking therapy. Then we performed endovenous thermal ablation of venous vein. This slide shows results after 10 weeks after endovenous laser ablation. What should we pay attention to? Given that treatment is carried out on an outpatient basis, patients should be carefully trained in the daily use of compression stockings. Accurately measured compression stockings is the key to patient compliance and successful compression therapy. It's essential to teach the patient how to properly care for the ulcer. Further supportive therapy in cases after endovenous thermal ablation, compression stockings of the second class of compression for at least 1 month with further constant use of stockings of the first class of compression. Further supportive therapy in cases without endovenous thermal ablation or surgery, compression stockings of the second class of compression until the elimination of axial or perforator reflux. Combining use of 2-component compression stockings and wound hydrogel containing octinidyl hydrochloride is effective method treatment of venous-like ulcers, and the venous thermal ablation is effective method of correction of chronic venous insufficiency and allows to decrease duration of vein ulcers healing. We hope to meet our Indian colleagues this year in person. Thank you very much for your attention.
Thank you. Thank you, Ashkat, for a very nice presentation. Please, any questions, if anybody wants to ask? Thank you, Dr. Ashkat, for joining us.
Thank you very much.
Yeah.
Thank you very much for the invitation and
very happy to see
the possibility to be in part.
Thank you. So now we come to the conclusion of all the lectures, and thank you everybody. And so now we have 3 minutes of video presentation by the Sonosite.
We find it in the everyday, those everyday moments when we can be there. The hundreds of sunrises or hours logged on the move. It's those moments that make us, where the smallest things can make a difference. Our decisions and experiences, they shape us into who we are. They can take us halfway across the globe, to new places, places that we barely know. Within these experiences, we gain insight that allows us to remember that we are all connected. Like the ripple of a sound wave, our actions have the power to impact those around us. Our actions can save lives. Our tools, training, skill set, education, it all comes down to one thing: care. Care is about connection, the connection that is made with others. It's about having something that works right every time. And at the end of the day, we know that our job is done. We think, concept, and craft every element of what we make. The time has been spent and actions and decisions made that make it all worth it. At the end of the day, or the beginning of a new one, we are driven by ingenuity and fueled by the passion to innovate. It comes back to this, that those everyday moments are the ones that matter. This is to all of you that work hard every day to care for others. From saving a life to seeing a new one for the first time. To those that make the sacrifices, the hours away from home and time spent on call. All of you, your experience, your care, you make us who we are.
Not looking for
Thank
that.
you, friends. Thank you, Sonoside. So now we move to the last session. It's a general body meeting. Please, I will request whoever is not a member, a life member of Venous Association of India, they can delog and thank you for attending the meeting. And please, the executive committee meeting can remain as a panelist, and the rest of the people can go as an attendee, so that there are fewer people on the screen and we can discuss all the burning issues. And I will hand over the mic to Dr. Roy Varghese. He's the current president of Venous Association of India. And Dr. Roy Varghese, and once we finish this, then we'll have the result sessions, and then we'll have a concluding remarks from Dr. Dekiwadia and Dr. Malay Patel.
Thank you, Dr. Rahul. Can we start the general body now?
Yes, please, sir.
Yeah. Now I'll try to make it as concise as possible. First, the time is already, we are about 40 minutes later than scheduled. First of all, let me congratulate the Vicon 2021 team for the meeting they have been able to hold in this pandemic time. Then, next what I wanted to tell is Dr. Sunil Agarwal is no more with us, our past president, and we will miss him. But I'm sure that he is with us and listening to us virtually from heaven. And then more on Sunil Agarwal later. Now, we'll come to the next is all of you are aware that we are having a PCPNDT program going on, and it is in advanced stage. Unfortunately, it was partially discussed in the EC meeting yesterday, and since the matter is under judicial consideration, we will not discuss further in public. This was the funding for this was 5 lakhs from personal funds of Dr. Dekiwadia, and 5 lakhs from Roy Varghese, and 10 lakhs from the fund of VAI. Now, we have been fairly doing well financially, and then let me ask the current treasurer to Senior Professor Sanjay to present the accounts of the VAI so far.
Good evening. Thank you, President, and good evening, everyone. I think it's been a tough day for the organizers and for everyone. Let's make it brief. And yes, I took over as an interim treasurer, and it's been phenomenal to know how well things are managed and to see what state we are in. And as you know, I have been associated in the later half of it. I will keep it brief. For the details of the financial thing, I think we'll have a report which will be circulated among everyone. I'm so happy to note that in the last year, we had an incoming of about 21 and an expense of about 7 lakhs. The details of which will be discussed. And most importantly, I think what Dr. Shweppaderia's conference has done and given us is almost about 40 lakhs. So I think it's been a phenomenal year, and I'm so happy to take over at a time when we are in surplus and probably looking at utilizing this money. For the details of the report, I would either request Dr. Rahul to elaborate on it, or we could circulate it in the interest of time. Thank you, President. I think we'll go on with your permission. If needed, we can go into the details.
We can circulate, Roy. We can send the financial report to all the VI members, and they can have a look.
Yes, Rahul. So I'm okay to say that yes, we are about 60 plus in terms of the last year what we have gained. The details can be discussed.
Dr. Roy, can you unmute yourself? Can you unmute, sir? Yeah. Dr. Roy, can you unmute, please? Yeah. No, you have got muted again.
Sir, just press it once, sir. Thank you.
Okay, Roy, we can move forward. Please, all the members, if you have any questions or anything, just put it into the chat, please. Tarun, if you can just forward the chat to us so that.
Sure, sir. Sure, I'll do that.
We can pick up the questions immediately.
Sir.
Because if everybody is speaking, then nobody will be able to talk on the virtual. So if please, if any queries, any questions, just keep on putting in the chat. We will take up all the questions, try to take up all the questions, so that there is no confusion. Dr. Roy, by that time, you can move on so that we can finish on time. Sir, you're mute again. Yeah.
Yeah. I would request Dr. Padaria to present the accounts of formally in a very brief way, if he's still here, about the Mumbai Vicon.
Sir, he does not appears to be here,
no, sir.
But Dr. Sanjay has already mentioned that we really need a standing ovation and a claps for Dr. Shah Padaria and his entire team, and because he has really put in the Venous Association of India in a very big way. He has generated a profit of around 41 lakhs, which is going to be transferred tomorrow to our society account. And you will all be very happy to know that in future, all the conferences money we are taking directly into VI, and all the money can be paid directly from the VI, and that will be really wonderful for a transparent association. And all the checks and all the money can come. So from this year only, from the this year, we have taken all the money directly into VI account. So all the companies will pay directly into VI account, and all the checks which we are going to pay to the vendors will be from the VI account.
Thank you, Rahul. Now I request the secretary to make his report. Dr. Deepak, please.
Yes. Good evening, gentlemen. And once again, congratulations. All of us are really thoroughly enjoyed this conference, one of the best. After all the webinar fatigue that we had, I will now, I've made a small presentation, PowerPoint. I'll just share my screen. So I'm going to give you the Secretary's report for the year 2021, the year of the COVID, and where all of us went through a lot of struggles, and we have learned a lot of things in life, and we have learned to cope with one of the worst pandemics this year. I think this was a year which we will never forget. And also, this is also a year where we all lost our friend, a founder of this association, a teacher, a guide, and a philosopher, who's been a beacon of light to many students and young surgeons. And we will really miss him. He died in a very tragic road accident. And as friends and students of Dr. Sunil Agarwal, we had a tough time moving on, and it's almost a year. February 4th was the day that the horrific accident happened, and it's almost a year, and we have successfully moved across. And we're in his memory, we have also started a Sunil Agarwal oration. The oration will be done at the next Venous Association Conference, Vicon at Chennai, and the family, the wife, the parents of Sunil Agarwal are kind enough to donate a sum of rupees 2 lakhs for the oration. So the oration will be held in Chennai next year. And this has also been a year of webinars, and the Vicon and the Venous Association rose like a phoenix and held a record 34 national and international webinars, and we had people from all over the world, you name it, from South America to Australia to across the Atlantic, the US, Southeast Asia, places like Paraguay, Chile, who all took part in our combined sensory webinars, which were a roaring success. And a special thanks to the organizers, the organizing committee, and especially a word of thanks to Mr. Dr. Malay Patel, who with this contacts was able to bring in all these people from across the world. And in a sense, it was a time where all of us got to know a lot of people, in spite of the fact that we were all not able to travel, we were able to connect. And the Venous Association was a platform where people from across the world were able to connect, and we made a lot of friends this year. Just sitting at home, we made a lot of friends. And thank you, Rahul, Bedi, Dr. Malay, Shoaib, and Roy Varghese, and who's been a backbone of this society. Thank you so much for helping us connect with people all over the world. And then we've had people writing books as well. And one of our own, Ajay, has written a book on venous malformations, which has been recently published. And congratulations, Ajay, on this wonderful book and endeavor. We hope that you will write more such books on venous pathology, physiology, and venous work. And nothing is finished with mentioning Dr. Shoaib's success story. He's been elected the Vice President of the International Union of Angiology. I request everybody to give him a clap. And he's also the coordinator of the new South Asia chapter. And a special mention to Shoaib, which Honorable President has already made. A wonderful conference, one of the best conferences that we've attended in just terms of numbers. And fortunately, it was probably the last international conference before the COVID took over. We were lucky to conduct this conference, and we were lucky enough to complete the conference. And especially the last day, more than 1,000 people came for the workshop. And it was great for the Venous Association and all the people who were involved. And there have been several publications of merit. There's been a concession statement at the International Union of Angiology on superficial venous thrombosis, and where Dr. Malay has been one of the authors in that. And the good news is Acta Phlebitica, which is the journal of the IUA, which is an index journal and is a very good impact factor. And we will become very soon, the Venous Association will become an affiliate member of IUA, and we will be able to publish papers, and they will give us a lot of priority in doing that. So a lot of things have happened this year, including an increase in number of new members. We've had 15 new members who have joined us, and the society is now quite a big society. We are around 360 odd members, and we are growing in every conference. And special thanks to Serdia, and Serdia has been one of the backbone, and they've been really helpful in every endeavor that we have taken. And I must really thank Serdia for all the help. They've been instrumental in the growth of this society. The Vicon 2022 will be held in Chennai, and Professor Radhakrishnan will make a small presentation at the end of sometime during the general body meeting. Thank you very much, and long live Venous Association of India.
Okay. Can I have the mic once more?
Sir,
you're on, sir.
You're on mic.
Yeah, thank you. Now, regarding one of our biggest push in the years to come must be to get these papers, which we are only presenting in various conferences, published. And for that, I have two important people, senior professors. One is Shoaib. He is the editor of a very important journal. And also our own Sanjay, who is also an editor of a very much indexed journal. I would request all of you to send your papers And when you are thinking of writing a paper, to write the SOPs, the protocols, directly to them, call them and tell that we are in the process and please help us. And I'm sure both of them will help us. Thank you. Then the next thing which I want to tell is, we are, all of you are aware that we are having a ultrasound project. It was started by Dr. Rahul Jindal to help and teach many people the venous and the vascular ultrasound, which is happening in Chandigarh. Except this year we could not do that. I also request the Vellore people, the Kolkata people to restart it, and some more centers which I have identified personally. One is in Jammu under Gurjit Singh and Kohli, Arvind Kohli if possible. Professor Gulshan Rajkot under that is Western India under Dr. Dicky Wadia. Then in Nagpur under the guidance of Dr. Shoaib. In Indore under the guidance of Dr. Hari. In Bhubaneswar if under the guidance of Nehar Ranjan. And many more centers are senior members are requested to send in the proposal to the governing council and also the new VI team which is taking over. Then the next is let us have the election before the election results. Let us have the prize.
Roy,
yeah.
Radha has to present the
okay
Chennai thing.
Let's have that first.
Radha, are you there? Can Tarun?
So, please tell me the name.
There is a video by Dr. Radhakrishna on Vicon next year. Radhakrishna has started screening.
Yeah, he's there, sir. He's there.
Okay. Yeah, it's just going to be a minute. It's just something about Chennai, and so the plan is for to do the Chennai Vicon in 2022. The probable dates will be 21 to 23, which I checked as there is no other events going on in the time. And the theme which I have thought about should be veins demystified, which is going to be appropriate because as we are getting more knowledge about the basics of the venous disease and the hemodynamics, I think we can give a better clarity about the venous disease and its management. So next I would like to just show a small video about Chennai. And
you hear the audio?
Dr. Radha?
Yeah.
Is there an audio in this?
okay, so with this, I invite you all. Hopefully, we have a real conference in Chennai from my institute, Sri Ramchandra Medical College. Thank you.
Rahul, there may be a few points. Rahul.
Yeah. There are one or two points.
Yeah. One is, I think, not I think. We have confirmed Kolkata meeting for after Chennai, and Dr. Dikkevadia will oversee that under Dr. Krishnendu Chatterjee, senior vascular surgeon, and of course Dr. Jayanto. I think.
So we had a proposal from Calcutta and Jammu And so EC meeting decided that because we have never been to the eastern part of the country, and I spoke to Dr. Gurjeet also today, and he understands that Vicon should get into the east part of the country where we have never been. And it will be better if we go for Calcutta first, and then we can think about, later on if we want to go to Jammu or some other place. And
yeah, Jammu we should go.
So Vicon 2023, Calcutta we thought, but any objections or any points anybody wants to make, please.
Jayanto has agreed, isn't it? Right?
Yes, sir. Yes, sir.
Okay.
I spoke to him. It is Dr. Dickey's and my responsibility to see that it happens well.
Great.
So no questions till now from the delegates end, sir.
Okay.
Please, can I continue?
Yes, sir, please.
Yeah. Now, Rahul, are we going to announce the prizes now?
Before
because
that,
election usually, election usually comes last.
Okay, sir. We can announce that. And should we go for, where is that? Elections are there. Tarun, you have compiled all the results.
Yes, sir. I have, sir.
You got the PPTs, right?
Yes,
and
sir.
For the results.
Yes,
and first of all, I'd like to invite Dr. Poonam from Sardia. She's here.
Just a minute, sir. I'll upgrade her.
Can be on the line.
Bring her on the stage, the lovely lady.
Sure,
And,
sure, sir. Sure.
Where
She is being promoted to panelist, sir.
Thank you. And Dr. Poonam, welcome. And if you can have your mic off. Yes, thank you for joining.
Okay, thank you, Dr. Yeah.
Thank you for joining. And we are starting to declare the Servier Young Research Award. And thank you, Sardia, for supporting. You want to say something?
Very quickly, maybe if you want to finish the announcement and then I could say some words, would that be better?
No problem. Okay. So the declaration of the results of Servier Young Research Award are there with Tarun. And the national awards will be announced by Dr. Roy Varghese. You can play the slides, please. The first 3 slides. Dr. Roy Varghese, please.
Yeah, Dr. Vishwanath Atrepurapu gets the first prize, I think. Yeah,
Yes.
Congratulations.
I hope he's here on the in the attendees, and congratulations to you.
Rahul, please go ahead and announce because you are more familiar with the program.
Okay.
Yeah.
Second prize, please. Next slide, please. The second prize goes to Dr. Prajna Kota on genetic profile of veno-lymphatic malformations in Indian population. Third prize, luckily we have been shared by 2 people. Dr. Harini Aturu on experience of patients living with lipodermatosclerosis and on clinical outcomes of endovenous ablation with 1940 nanometer laser. Congratulations to all of you. Shivangi will get in touch to you regarding how she is going to send the award money. Next we go to the international things, and Dr. Malay Patel, Dr. Sanjay Desai, and Dr. Shoaib Padaria, if you can declare, please. Dr. Malay.
So please unmute yourself, sir. Dr. Rao.
Can we have the slides, please? Yes, thank you. Yeah, the Servier Young Researcher Award International goes to the first place, Dr. Salma Ahmed. Topic of off-label use of bleomycin, a study of interlesional and intra-arterial applications. Congratulations, Salma.
Tarun, if you can mute the mic from where there is a disturbance. Guys, there was some mic which was causing disturbance. Please see. The next prize, please.
Can I announce? Is anybody there?
Please.
The second place goes to Dr. Ahmad Farid, Rad 1. The topic was autologous platelet-rich plasma versus conventional dressing in treatment of chronic venous leg ulcers. Indeed, a great topic, and it should make a big difference in our future understanding and treating of these patients. Congratulations, Ahmad. And the final third place goes to Dr. Gaita. Again, a very interesting topic. Does a patient information brochure affect willingness of women with varicose veins to be examined by a male surgeon? Prospective randomized single-blind study. A very bold study indeed, and congratulations, and we hope it makes a difference.
Thank you, Dr. Sanjay.
Congratulations to all of you.
Yeah, just guys, for your information, all these 6 awards, they contain around $700 each, and US dollars, and all this has been because of the grant from Surdia Pharmaceuticals. So, Dr. Poonam, mic to you. Thank you.
Thanks, Dr. Rahul. In fact, thanks to all the executive committee members of VICON, and on behalf of Surdia Pharmaceuticals, myself, Dr. Poonam Gupta, really thanks each one of you all present here for allowing us to collaborate, giving us that edge in VICON to keep up the spirit of this entire clinical research and application in day-to-day clinical practice ongoing. Well, somebody said it very rightly in the past, that the common facts, evidences, practice habits that you see today pharmaceuticals just taken the SCR of Servier and very much Indianized the name of DIA, that's DIA India, makes it Surdia. Very quickly, we are a non-profit foundation. This is governed largely by a group of people and not by a group of capital. Allows us to reinvest 25% of our revenues back into research and development, and which is why this Young Servier Researchers Award is being made possible. Our vocations, the company's vocation is to enhance therapeutic progress to serve patient needs at its best, and we have a clear. We have about 100 million patients worldwide in one corner or the other who's being benefited from Servier medications. We are number 1, the leaders in phlebology, as doctors largely present here know that. We are also leaders in cardiovascular area, 2nd in Europe and 5th worldwide. We do understand that today's COVID times have been challenging. The vaccines out there, but hats off to all the COVID line warriors today who's present on other side of the screen for being really upfront on the services that they have offered. A very quick and important note, specifically in the current COVID times, with Servier medications, that is in Surdia, we do not have any Chinese API coming in, which means the raw material is sourced from a single factory, and here it's reproduced back in India. That means at any given point of time, your patients will not run out of the issue of non-availability of the medications. Well, last and important note, for all the candidates who've been part of this Servier Young Researchers Award, a very big congratulations to you first for participating in it, and second, of course, to the awardees for winning it. We hope this continues each year and more number of participants can benefit from it. And special thanks to Dr. Rahul Jindal, Dr. H.S. Bedi, who's been all throughout really putting in this pressure that everybody must go and at least submit something in the Young Researchers Award. And the big man, of course, Dr. Roy Verghese. Dr. Deepak, Next year, Chennai, we'll see you there. Thank you very much.
Thank you, Poonam. We will move on to the best.
Poonam, that was a
Sir, can't hear you. Sorry.
Sorry, who is this? Sorry, hello. Okay, we lost. Now we move on to the Doctor's Free Paper Award.
Poonam, that was just a minute, Rahul. Poonam, that was a wonderful presentation made by you. Somehow the connectivity is getting connected and disconnected. However, thank you for your wonderful presentation.
Thank you, sir, once again, and have a good evening. Vicon is being fantastic this year. And I think one of the highest participations of all the years that I've attended is for this Vicon. So once again, wonderful. Over and out. See you all. Bye.
Thank you. I'll hand over the mic to Dr. H.S. Bedi and Dr. Pinjala for announcing the prizes. There are 6 prizes for the doctors. There are 2 first prize, 2 second prize, and 2 third prizes. Tarun, you can forward. Yeah.
Is Pinjala there? No. Okay, I'll announce it. The first prize, Dr. Vishwanath from Hyderabad. Prevalence of deep venous disease in patients with non-thrombotic advanced chronic venous disease. And we have a joint first winner, Dr. Nivedita Mitta from Bangalore. So there are 2 joint winners. Congratulations. Can we go to the second slide? Also, they are all we have 2 winners for all, is it?
Yes,
so
sir.
Dr.
There are 2
Nageeb, okay, 2 first prizes, 2 second prizes. All right. Dr. Nageeb from Egypt, outcome prediction of DVT. And Dr. Piyush Chaudhary, our own Piyush Chaudhary, very proud of him. Long-term results of endovascular management in KPS. Congratulations, both of you. Next, please. Third is Dr. Parmesh Chandra from Varanasi and Dr. Nikhil Dhanapal from Chennai. So congratulations to all the winners. In fact, congratulations to all participants. Winning and losing is okay. I think all of you did presented very well. Well done.
Thank you, sir. Now we will move on to the Nursing Free Paper Awards. Dr. Deepak Salvaraj and Dr. Sarvanan, please, if you can do the honors. Tarun, can you move on, please?
Dr. Sarvanan, are you there?
No, I don't think.
Okay, the first prize goes to Mr. Anubhav George from India. His topic was vac dressings. And there's another joint first prize, Sister Navjot Kaur, also from India. Topic was tumescent anesthesia, does composition of the tumescence matters. Are any of them here, or I don't think they're all here?
No.
Okay, we'll go on to the second prize. The second prize is to Sister Laila Al-Shaba from Egypt. The effect of high negative pressure wound therapy on healing in diabetic foot ulcers. And also Sister Manpreet Kaur, again from India, use of human chorion tissue allograft for non-healing venous ulcers. And the third prize, Sister Manpreet Bangu from India, use of platelet-rich fibrin in venous ulcers, and Sister Sugandhi, also from India, our initial experience with CLACS. Overall, it's been a fantastic representation by all the nurses. We hope to see more of nurses and wound managers participating in years to come. Thank you.
Now we got Dr. Ajay Khanna back, Dr. Roy Varghese, and Dr. Ajay Khanna, can we give the mic to you?
Yeah, please.
Yeah. So your mic is to you. Dr. Ajay Khanna is an executive member of VI, and he's going to speak. The slides will speak himself. Tarun, please. We are very, very proud of you, and it's really wonderful. It's that you decided to do this in Venous Association of India.
Just trying to share my slides.
Yes, sir, please.
If somebody is sharing the slide,
yes, sir.
Please allow me to share the slide.
So you can share your slides, sir, please, sir. Ajay, sir. Thank you.
Can you see my slide?
Yes, sir. We can, sir.
Right. Thank you, Dr. Rahul. I think it was a very pleasant memory for me when in fact, the 4th book was released only on 6th of January 2021. And this book has been released from the Springer. This is Vascular Malformation, and it has been edited by myself and my colleague, Dr. Satyen Tiwari. And this has got 22 chapters. And out of these 22 chapters, there are 3 chapters which has been written by the persons from USA, 3 from Europe, 1 from South Korea, 1 from Bangladesh, and 1 from Nepal. And 13 chapters has been written either by our association, Venous Association, and the other persons. And in the Indian contributors from the VAI is Dr. Kohli, Dr. Rahul Jindal, Dr. Ajay Savlania, and Dr. Sumit Kapadia. So I must thank everyone here who has joined for this venture, and I'm really thankful to each and every one. You know, these are my few other books which are there from the Springer or from the JPs. And the ulcers of the lower extremity which is there, we are going to bring out the second part of that, and that will be the unusual ulcers of the extremity there. And this will be again taken by Springer, and I will request all the members of the VAI here who can contribute as they have contributed before. You know, one of the book, Venous Disorder, my co-author was Dr. Rahul Jindal, and there were so many persons from the VAI. They have contributed in that. So I will expect the members of VAI to also contribute in my new venture of the unusual ulcers of the extremities. And this will be almost a part 2 of the ulcers of the lower extremity. So I'm again thankful to the VAI for allowing me to use this forum for that. And I'm really thankful to all the members of the VAI and the other persons who has contributed to my book. Thank you very much.
Thank you, Dr. Khanna. And please, be sure Shwangi has already taken all the photographs, and we will try to promote this book to approximately 1,300 people across the world, which we have an access to. And she will get on this within the next week, and we will give it a very big highlight all across the world.
Thank you very much. Thank you, Rahul. Yeah.
And we'll also try to promote this into an August course. And I talk to you personally, and if we can provide this book, to all the candidates who will attend the course.
You know, these all books are quite costly one. You know, they all cost approximately more than £100 here.
Yes, sir. So that's I'm going to talk to you and negotiate with you for a.
No, that's what I'm telling that yesterday I got a call from Naren. He said that, sir, if you can give us a bulk order for that, then we can bring out the paperback edition of that.
Yes, sir.
And that will be much cheaper. All right.
So that's why I'm saying. So if you can send a letter to the Springer, and we can give a copy of this. We'll pay the price, and we'll give a copy of this to the people, so that more and more people can benefit. With all so much effort you have done.
All right. Thank you very much. Thank you. Sure.
And so any other issues, Dr. Roy Burgess, Dr. H.S. Bedi, I'll hand over the mic to you. I don't have any other program left with me, except the election results, which are going to be announced. Dr. Roy Burgess, Dr. H.S. Bedi. Dr. Roy Burgess, yeah.
You're muted, Roy. Yeah.
Yeah. Now, I request the governor to announce their election results.
Okay, sir. I have already WhatsApped you the list. We were actually very lucky that the amount of nominations papers which were filed in, they were absolutely equal to the empty posts. So we don't have any elections to run. So we had a post of treasurer, which Dr. Gulshanjit Singh has applied for it, and he is elected as a treasurer. Welcome.
Congratulations.
Sir. And we got 8 executive members who have applied for it, and starting from Dr. Vimen Samuel from Vellore, Dr. Jayan Das from Calcutta, Dr. Ajay Khanna from Varanasi, Dr. Anjali Davle from Maharashtra, Dr. Ankur Bhatnagar from Lucknow, so Dr. Robbie George from Bangalore, Dr. Rahul Naik from Bangalore, Dr. Piyush Chaudhary from Punjab. So actually talking it all across the country. So we have got members from nearly all parts of India, so which is very, very good.
Congratulations to all of you. Now, it's my pleasant duty to hand over the charge to the next incoming president, Professor Harinder Singh Bedi and team. Harinder Singh Bedi and team, I request you to take over formally, but we will be giving you the charge in Chennai in an open meeting to make it a sonnet and lumiere. That means all the light, sound, and glory. At the same time, in this Vicon, we were supposed to have 2 orations, the Ted King oration and Sunil Agarwal Memorial Oration. The people selected were Dr. Pinjala and Dr. Dikiwadia. They will present the oration in the next meeting. Dr. Bedi, please take over the association.
Thank you, Roy, and it's an honor to take over from you, and I sincerely hope that we'll be able to carry on the strong traditions that you have set for us. And of course, we count on, and I know that we will have your support as we will of the rest of the association. So, good. Thank you very much.
If there is nothing else, I think you can call the meeting to an end now.
Yes. Is that anything else that we have pending, Rahul?
Rahul sir, you need to unmute yourself, sir. Rahul sir.
Sir, I'm just looking at any other questions which are there in the chat box from the VI people. Dr. Venkat Reddy has asked, who is going to conduct the meeting in Calcutta? Dr. Roy Varghese, please.
Yeah, the meeting will be conducted by Dr. Jayanto, executive member. It will be overseen by his immediate boss, the senior vascular surgeon, Krishnendu Chatterjee, and also Dr. Dikiwadi and Roy Varghese.
Okay.
Because it's a very important meeting. They have already conducted 2 meetings, ultrasound meetings and 1 general meeting. So they have the experience.
Okay, sir. There are no more questions now, and really thank you to everybody who has really helped Dr. Bedi and myself, in this time. And there are a few things which we want to say, in terms before I hand over the mic to Dr. Dikiwadia and Dr. Malay Patel. First of all, really like to thank the IT team, who has been really the backbone. Tarun, if you are here, and thank you. I know there was some hitches in the beginning because, to accommodate, we thought there will be around 800 to 1,000 members on the group. So, and thankfully we prepared for it, and we had around over 600 registrations for this meeting from more than 42 countries. So, which was really fantastic. All the lectures were very well, and we were a bit late in terms of questions and answers, and but otherwise everything went well. We really like to thank all our sponsors, and you should go and look into the stalls, how the stalls are made. They are so beautiful, and virtual stalls. And if nobody has gone, you should go and see those stalls. They're really beautiful stalls. And thank you all the sponsors, for helping us to conduct this meeting. And I think Dr. H.S. Bedi, any other point you want to make?
I want to put on record the really great work that Rahul and of course Shivangi and the rest of the team has put in. My contribution has been very little, but I'm so happy that the hard work that everybody has put in has given such good fruits. Thank you.
I really like also to say sorry to anybody whom we could not include in the program. As you could have seen, even only 5 hours program virtual is very tiring for everybody. And so we could not have extended the program to include everybody. So please, I'm really sorry if you are not happy with the role which was given to you, but you could have seen how we have adjusted the program. It was very difficult. And I really like to thank Shivangi and Sagar. They have been really working up to 11 o'clock night every day from last 20 days to organize everything. And I think I will close the program and want to hand over the mic to Dr. Dekiwadia and Dr. Malay Patel to say a few words.
So Dr. Dekiwadia is not here, sir.
Okay, Dr. Malay Patel is also not here, looks
No,
like.
sir.
So I'll hand over the mic to Dr. H.S. Bedi only.
So I call this meeting to this excellent meeting, and we do wish that some of the talks would have been longer, but everything good has to come to an end, and we look forward to great cooperation from all our members, and looking forward to Chennai. So thank you, everyone, and good night to all of you.
Good night, sir.
Good night and cheers.
Bye bye.
Good night, sir. See you in Chennai.